And I won't be repeating a lot of what Dr. JP has mentioned, but we have a great lineup of presentations today, and we encourage everyone to really participate as much. My name is Niwama Nyarita, and I am the head of marketing and communications for the 5th National Safe Motherhood Conference. Yeah. So in a moment, we will watch a video that highlights the inspiring moments that we had yesterday, that we captured from the sessions of yesterday. But before we do that, I would like to re-echo for members that have just come in what we are going to be going through today. We'll start with a keynote address from the director, IPAS, and then we'll also have a plenary session about harnessing routine health data to advance equity and coverage, and that will be chaired by Prof. Peter Waiswa. We'll also have another keynote address by Dr. Dithan Chiraga, and we'll also have parallel sessions after lunch. In Renzori Hall, we shall have the Safe Motherhood Forum on sexual and gender-based violence. And we'll also have another parallel session in Acacia Hall about beyond teenage pregnancy. And in Ebony Hall, we shall have harnessing multisexual engagement, and that will be chaired by Dr. Benon Musasizi. We'll have also, in Mahogany Hall, we shall have a session on making quality antenatal care a reality. And finally, in Jacaranda Hall, we'll have a session on tackling infections and emergency threats. Yeah, so all these sessions will have great speakers, and we encourage you to choose where you think you want to go. And finally, from 16:30 to 17:30, we shall have our grand closing ceremony. And in that session, we'll also have a presentation of conference recommendations and key actions, and also our commitment drawn from all the sessions we have had since day one. And finally, we'll conclude this year's conference with plenary awards. So the awards ceremony is going to be here, okay? And in that awards ceremony, we'll recognize the outstanding contribution and contribution of the NSMC champions for this year. And finally, we'll have the awards dinner, which will be mainly for the invited guests. So if you don't have a card, I am sorry. Yeah, but it will mainly be for the invited guests. So ladies and gentlemen, allow me to call upon our IT to put up the video for yesterday's sessions.
So, good morning, distinguished colleagues, ladies and gentlemen, all protocol observed. It is such an honor and privilege to welcome you to this important plenary session, and I do this with deep appreciation for your continued commitment to improving the lives of mothers and children in our country. I am especially humbled to be moderating what seems to be the first session. For the last 5 years, we've been meeting, but this seems to be the first session dedicated exclusively to newborn health.
Neonatal mortality has reduced drastically from 1990, where it sat at 37 deaths per 1,000 live births globally, to around 17. Unfortunately, this still means that we have 2.3 million neonatal deaths every year. Every single day, 6,300 babies die before reaching 28 days of age. And most of these deaths happen in settings like ours.
We have had challenges over years in terms of reducing newborn mortality. Although over the last 5 years we made some progress where we were able to have a reduction of about 18% from 2016 to 2022. However, the journey is still long for us in order to achieve our 2030 targets of reducing newborn mortality to 12 per 1,000 live births.
You remember when we met here last year, we met here last year in October, and many of you were part of the convening. We had our third Health Promotion Disease Prevention Conference, and we took some resolutions from that conference. I'm happy to let you know that since last year, we have been able to mobilize over 120 billion Uganda shillings for the Community Health Workers Program.
Good afternoon once again. I wanted to tell Dr. JP, don't say how many years of experience, so people don't start calculating how old I am. But when it comes to discussing issues of maternal and newborn health, I don't care if you calculate I'm young or old, but my passion remains unchanged, so that's why I'm here. We were reflecting on the session we had this morning just before break, Joanna. Some of us have lived that experience, or we know somebody who has lived that experience. When Joanna said she went to Naguru on Sunday, and the doctors were not there, people were laughing, others were saying, oh, but because they have gone to church. But we need to discuss when they go to church, somebody has to stay there and ensure that people like Joanna are able to get the services that they need.
So our targets as a country are mirrored on the global targets of the Sustainable Development Goals. And as a country, we are privileged to say that we thought that all the targets as embedded in the Sustainable Development Goals, if we committed, doubled our efforts, like you saw yesterday with the figures, they are attainable, they are achievable.
Globally, the issue of health workforce is a global issue. It's not only a Uganda issue. We are estimating a shortage of 18 million health workers to be able to achieve universal health coverage globally. We are also seeing that countries which have a higher density of health workers are actually seeing lower maternal mortality and neonatal mortality. When it comes to Uganda, bring it home. I know I've had a number of people saying we are training so many health workers. Haven't you? You know, with all these medical schools, training schools, there's a school of thought that we are training many. However, in Uganda, we have a population of 45 million, close maybe, some people say 50 million, but we have 1.9 doctors per 10,000 population. We have 15.2 nurses per 10,000, and we have 7 midwives per 10,000. So is this really showing that we have too many health workers?
Now, colleagues, it's important for me also to note, and as Dr. Mugahi highlighted, that we had a very unfortunate incident of the passing of some of our colleagues. We are going to take a moment of silence to recognize. We lost 3 healthcare workers, unfortunately. It's a very bad moment, and we could stand to, in respect of the souls of our soldiers that have passed.
Thank you so much. Thank you so much. I would like to encourage you that on this eventful final day of the NSMC, we encourage you to take pictures, but also post them on your social media platforms. Give this event the visibility that it truly requires. Thank you so much.
All right, thanks very much indeed, Rita. Colleagues, we shall delve into our very first plenary session for the day, and that is going to be chaired by none other than Dr. Lillian Sekabembe, the country representative for PSI. And a little bit about Dr. Lillian. Dr. Lillian is a country representative for Population Service International, with over 20 years of experience in global health and development, including emergency response. As a medical doctor and public health specialist, she has led impactful initiatives in maternal and child health, HIV, sexual and reproductive health, malaria, and health system strengthening. Recognized as one of the top 60 African women in development by Donors in Africa Foundation in 2022, Dr. Lillian is known for her expertise in policy advocacy, gender mainstreaming, private sector development, and health commodity supply chain management. She has played a significant role in advancing sustainable development in Uganda and other regions. Her collaborative approach has enabled her to work closely with diverse stakeholders, including donors, NGOs, government ministries, UN agencies, academia, religious and cultural institutions, plus the private sector. Through these partnerships, she has driven policies and programs that improve health outcomes and build resilient health and intersectoral systems. A round of applause as Dr. Lillian takes the podium, ladies and gentlemen.
Thank you very much, excuse me, Dr. Bagala. Dr. Bagala was reminded yesterday not to mention years of experience. However, I believe he did this to recognize the passion that we stand with here on this podium to discuss issues of safe motherhood. So I'm going to assume that we have had a protocol that has been mentioned, and I'll stand on that. So, good morning, everybody in your capacity. I prefer to call you distinguished guests, colleagues, and partners. It is my honor to welcome you to this pivotal plenary session on strengthening post-abortion care and advancing reproductive justice for safe motherhood. Uganda, we know, has made commendable strides in maternal health, yet we all recognize that unsafe abortions remain a persistent yet preventable contributor to maternal mortality. And we also know that this is especially among adolescents and young women. We had the statistics yesterday, on the first day as well, where the ministry was reminding us that teenage mothers account for about 18% of the 3,000 maternal deaths we see annually. And in numbers, absolute numbers, that is about 540 deaths among teenage mothers. In addition to that, we see that over 45% of those deaths are women below 24 years. Again, absolute number, that comes about 1,400. Again, figures are showing us that about 7,000 teenagers sought post-abortion care services in 2023, which is again an alarming figure. So these figures are telling us that unsafe abortion is not only a health system challenge, but also a profound reproductive justice issue. So despite global and regional commitments, including the 1994 ICPD and Maputo Protocol, both ratified by Uganda, women and girls continue to encounter stigma, legal ambiguity, and barriers to accessing timely, safe PAC services. So without deliberate action, unsafe abortion remains a major obstacle to Uganda's safe motherhood agenda. So today, we gather to confront this reality with courage and clarity. We are reminded of what Dr. Mugahi said on Wednesday. He said that we are burying our heads in the sand, well knowing that our young girls are having sex at 10 years, 11 years, and even 9 years. And if we keep burying our heads in the sand, we will not boldly come out to explore the options that will help our young people live a better life and at the same time reduce our maternal mortality agenda. So today we'll explore how post-abortion care, a life-saving intervention, must be recognized not only as a health system priority, but a matter of reproductive justice. We will reflect on Uganda's progress from policy reforms to community innovations and examine how multi-sectoral collaboration can dismantle stigma, but protect our providers and uphold the rights of women and girls. So I am believing that from this session, the outcome will be, we'll be able to generate actionable recommendations to help us institutionalize post-abortion care as a life-saving and rights-affirming intervention central to Uganda's self-motherhood agenda. We will draw lessons from national and regional advances so that we are able to move reproductive justice and also have accountability and affirm multi-sectoral collaboration. I want to recognize that this session has been convened by the Ministry of Health, the Reproductive and Infant Health Department, in partnership with IPAS Alliance and other partners. And I also want to reaffirm that it's generously supported by IPAS Africa Alliance Uganda, that is headed by Anna Kuku, and the Park Steering Committee. I want to also recognize that the park guidelines were launched on Wednesday. Dr. JP, allow me to kindly show the guidelines. It is the hard work, thank you. It is the hard work of that committee, which represents many of us, that these guidelines were launched. They are on your tables, you can take a look at them. But also allow me to recognize the members of that committee that stood and made sure these guidelines were launched on Wednesday. So any member present of the committee, I kindly ask you to stand up for recognition, because it's your hard work that resulted into this guideline. So we appreciate you for the great work that you have done. So I'm inviting all of us to engage deeply. I urge all of us to engage deeply, actively listen and participate, and boldly, I ask that we boldly contribute to this conversation, because it's important as we advance the safe motherhood agenda as a country. I believe that together we'll be able to shape our future where no woman dies, no young girl dies from preventable causes. So we believe that out of this conversation, every girl will have access to dignified, timely, and safe care. So to set the ball rolling, I'm going to ask the panel, as I introduce them, they'll be coming they'll be coming up. So like Dr. JP previously mentioned, that this session is framed within strengthening post-abortion care and advancing reproductive justice for safe motherhood. We are going to have a keynote address that will be led by Dr. Kitui Musoba. He's the director, IPAS Africa Health Alliance. Dr. Kitui will frame our conversation, and the panel conversation will then grow from what he will be discussing. So allow me to introduce Dr. Kitui as he comes here. He spearheads efforts across the region to advance reproductive justice and expand access to contraception and safe abortion services. A medical doctor with an MPH from the University of Nottingham, he brings 20 years of progressive leadership in public health and development across Africa, Asia, and in global roles. His extensive experience includes leading large-scale programs focused on maternal and child health. Dr. Kitui's background combines clinical expertise with senior roles at organizations like Oxfam, IMA, World Health, and MSF, ensuring a holistic, systems-based approach to health. He's a strong advocate for health equity, accountability, and rights-based interventions, and his research has focused on improving health facility delivery uptake in Kenya and the region at large. Dr. Kitui Musoba, you're very welcome. Joining us on the panel is Miss Judith Isuka, a senior midwife at Mujuku Health Center 4 in Toro District. Judith will help us frame the conversation as a frontline service deliverer. She'll help us further define, tell us about the provision and providers' reality when it comes to PAC services. I'm privileged to have worked with Judith Isuka before. She's a registered midwife and a post-abortion care mentor and provider serving in Mukuju Health Center 4 in Toro. She has 20 years of experience in health service delivery with a strong focus on maternal and child health, post-abortion care, and family planning services. Judith is deeply committed to promoting safe motherhood and improving access to quality reproductive health services at the community level. Her passion for mentoring fellow health workers and advocating for women's health continues to inspire her work in advancing reproductive justice in Uganda. Ladies and gentlemen, please meet Judith. You're welcome. Next, I have the honor of introducing Dr. JP Bagala. We all know who he is, but allow me to speak about who fathered. I don't know if you know all his titles and that good work that he's doing for us. But Dr. JP Bagala is an associate consultant of obstetrics and gynecology with the Ministry of Health and a scientist and lead NASMEC Institute. He is currently the acting assistant commissioner of reproductive health and infant health at the Ministry of Health. He remains the national coordinator for the local maternity and neonatal systems at Uganda's Ministry of Health. He serves on the advisory board of Africa at the International Urogynecological Association. Dr. Bagala leads initiatives to strengthen maternal and neonatal care and collaborates with health workers, policymakers, and development partners to advance evidence-based interventions across Uganda. Dr. Bagala will be able to frame a conversation around national policy and health systems leadership, and he will be contributing around institutionalizing PAC across Uganda's health system. So with so much honor, join me in welcoming Dr. Bagala to this conversation. It's an honor. Allow me next to introduce Dr. Lois Nyanjao. She was very clear that she loves her botanical name. So Dr. Nyanjua will be giving us a regional perspective about policy and health system strength strategies from Kenya. But that awesome lady is a distinguished local global health leader with over a decade of experience shaping large-scale health programs across Eastern Africa. Renowned for her strategic vision and transformative leadership, Dr. Lois has consistently driven health policy reforms, regional partnerships, and resource mobilization efforts that align with both regional and international priorities. Currently, serving as head of maternal health at Kenya's Ministry of Health, she leads the national maternal health agenda, advancing high-impact interventions, strengthening quality of care, and improving system coordination across counties. Her previous leadership roles include head of early childhood development, where she guided Kenya's transition to the nurturing care framework, and head of partnerships and coordination in the National Cancer Institute of Kenya. where she mobilized funding, convened the first National Cancer Summit, and oversaw the rollout of Kenya's digital cancer registry system. She has also held strategic positions in primary healthcare, cardiovascular disease prevention, and universal health coverage, as well as represented Kenya in global forums as UN liaison officer, building bridges between national systems and national health networks. You're welcome, Dr. Lois Nyanjua. I believe her bio speaks to the overall agenda I've been speaking about since we came on Wednesday. Yesterday was a self-care conversation, and the work she has done within the NCD, I think that speaks to further enhancing the safe motherhood agenda. But last but not least, allow me introduce Dr. Polyphil. I have no power to pronounce his second name, and I hope that once he comes up to speak, he will be able to say it. Dr. Polyphil is a prominent academic and researcher. He is based in Rwanda with a focus on public health and clinical medicine. He's an adjunct assistant professor of obstetrics and gynecology at the University of Utah and a lecturer at the University of Rwanda. Dr. Polyphil's research encompasses a range of critical topics, including the prevalence and management of postmenopausal symptoms, as well as maternal mortality causes in Rwanda. His work has been published in reputable journals such as Climate, and Obstetrics and Gynecology, highlighting his commitment to advancing medical knowledge and improving healthcare outcomes in resource-limited settings. In addition to his academic pursuits, he has been involved in practical interventions aimed at enhancing evidence-based practices in the management of acute infections. His studies, particularly those conducted at Gitwe Hospital, reflect a dedication to addressing pressing health issues through rigorous research and implementation of effective healthcare strategies. I had to read that out because they are joining us from Rwanda and Kenya in the region, and they deserve for us to get to know who they are. So Dr. Polyphil will be speaking about will be providing legal clarity and innovation in PAC delivery. And we believe that we'll be able to learn from Rwanda's experience. That took a while, but I believe it was worth us understanding who's speaking to us and the value they bring in this safe motherhood conversation. So we have, like I'll say it again, that we are framing our conversation around reproductive health, reproductive justice in relation to PAC, post-abortion care services. So let us begin with a keynote address from Dr. Kitui Musoba, the Regional Director at IPAS, whose leadership continues to anchor national and regional discourse on reproductive health and justice. We are believing that his conversation will frame PAC and reproductive justice and then lead us into the panel discussion. You're very welcome, Dr. Musoba.
I want to stand on the protocols that have been established throughout these past 2 days. And so, ladies and gentlemen, good morning. It's a great pleasure to speak to you today on the topic of strengthening post-abortion care and advancing reproductive justice for safe motherhood. And I have a speech here that I don't want to read word to word so that we can have a conversation. And so I'll just talk through my key messages even as I frame this topic. But before I go into the substance of my keynote address today, I want to start by congratulating the government of Uganda, and especially under the leadership of the Ministry of Health, for the great work that they are doing to save the lives of mothers in Uganda. I think I've been personally very impressed, especially with the statistics, with the progress that we've made as a country over the past 10 years. But still, one too many women still die from preventable causes. And I think, as a society, to be honest, I think we should collectively be ashamed every time a woman dies from giving birth or from a pregnancy-related matter, because it's completely preventable. Especially in 2025, we have all the technologies we require to save women's lives. And I know the Minister of Health has really been on the forefront to lead us all in making sure that we save the lives of women and girls. So the leadership of the Minister of Health in institutionalizing, including the post-abortion care guidelines and life-saving services, because we know that despite the proven benefits of services like post-abortion care, these services remain completely inaccessible. And we can talk about some of the drivers of why women who require these life-saving services are not able to get them, including stigma around abortion in itself, the divergent views on sexual and reproductive health and sexual and reproductive health rights. And PAC services is, I know Dr. Richard says that we've finished all the low-hanging fruits, but I feel like post-abortion care services is one of those low-hanging fruits in advancing safe motherhood in our country. We also know that even where an abortion is medically indicated, as per the laws of the land, saving lives, for example, even a good quality abortion cannot be provided to some of these women as well. And so even the unsafe abortion services actually happen in our own health facilities, partly because of lack of skills or lack of equipment or lack of clear guidelines. And I think for me, that's why the advancing of these post-abortion care guidelines really plays an important role. I would like to move to my second slide. I think so why does post-abortion care matter? I think we saw early this week, around the statistics of the women who are dying in our health facilities, and complications from unsafe abortion play a very, very significant role to that as well. For example, when you look at so when you look at the complications from abortion, we see the figures going down, but we're still at 4%. There was another figure there also about pregnancy-related sepsis. These are women who come in from infections, and they have high fever, and they require antibiotics. And I think I want to speculate, and I can be corrected, that some of those infections and sepsis are usually arising from complications of unsafe abortions that have happened elsewhere, and then women show up in health facilities because of some of those complications. And I think under the ministry's stewardship and the technical leadership in this space, we are seeing very significant progress. For example, approval and inclusion of drugs like Combipac as a life-saving drug within Uganda's essential medicine lists, the establishment and leadership of the National PAC Steering Committee that we've just acknowledged, because they've provided leadership to the creation of the guidelines that exist. The development of the National PAC Training Manual as well will really help to build the skills of healthcare workers at facility level to provide these life-saving services as well, but also championing of self-care approaches, including the use of digital technology that we've seen this week, giving women the autonomy to manage their reproductive health as well, and the provision of infrastructure and enabling environment that allows partners to complement government efforts through commodity supply and provide a training and community level interventions. Also, the establishment and functionalization of local maternal and perinatal death surveillance structures, I think for me is very commendable, because then for every woman who dies from either complication related to pregnancy can be audited, and those issues that really underlie why the woman dies can be addressed. Where am I supposed to? Oh yeah, there we go. So I think the other question I wanted to ask is, why is post-abortion care services necessary? And I think for me it's really important for us to look at the upstream causes and determinants of unsafe abortions in Uganda, so that we can be able to have a very open conversation around what we need to do to save women from dying. And I use the analogy of a stream because I think for me it frames the issue better for me. So when you talk about post-abortion care, we're really talking about preventing these last deaths here downstream from a cause that we can actually prevent. But it should not be lost to us that by the time a healthcare worker gets a girl or a woman who requires post-abortion care in a health facility, that we as a society have failed her so many times upstream already by the time she reaches there. And I also symbolically use the symbols of male and female, because if you go upstream on the bridge, it means that upstream there are women who are falling through into the river, but we're not picking them up early until a post-abortion care service is necessary. And so, for example, when you look at every time a girl or a woman dies from complications of a safe abortion, is the immediate cause is that we could not be able to provide post-abortion care. And we could not, a healthcare worker could be there, but maybe they are not even allowed to provide post-abortion care in the first place. And this could be lack of skills, lack of equipment. We have the MVA kits, for example, that could easily do that as well. Or if you're a midwife or a nurse, maybe our guidelines say that only doctors can do manual vacuum aspirations. And therefore, a woman dies in our health facility because we've just failed her at the facility level. And most of the time is because of things that we can actually do. And I think I was really encouraged by the kind of conversations we've had this week, and especially the efforts led by the Commissioner, Dr. Mugahi, in terms of making sure that we have equipment, the skills, the healthcare workers, and health facilities. And we're doing even skills transfer and task shifting or task sharing with other cadres of healthcare workers who can provide their services. But if you follow upstream a bit, you realize that why do we have unsafe abortions in the first place? And I think we were reminded, I think as has been mentioned by Dr. Lillian, is our girls are having sex. And it's 2025, and we can try to wish that away, but our girls will continue having sex. And they're not having sex by themselves. They're having sex with a man or boys, for that matter. But the consequences of, and I'll come to that later, the consequences of unwanted or unintended pregnancies 100% lie on the girl and the woman. And so they're seeking unsafe abortions because we as a system fail to provide for them options out of these situations that they find themselves in. So if you go upstream, you see again unintended pregnancies, and these unintended pregnancies happen because of many reasons. We can easily say, oh, let's make sure that family planning is readily available. But for you to really understand, then you have to go upstream again to figure out, why are people having sex? Or why do we have sex? And I'm sure you can list a whole list of reasons why we have sex in the first place that then makes post-abortion care downstream necessary. And some of that sex is consensual, it's wanted, it's out of pleasure, it's for many other reasons, but sometimes it's out of violent acts, rape, incest, abuse at household level, the lack of power by women, even among married couples, to negotiate for sex, for example. These are the drivers of some of the unintended pregnancies that arise from the sex that we have in society. So a lot of the sex that is happening in society is not necessarily at the control of the woman, who then bears the consequences downstream. And then we leave always the men off the hook, who are actually 100% of the cause of the unintended pregnancies in the first place, whether violently or through consensual sex as well. So I think for us, as we engage with the issue of post-abortion care, let it not be lost to us that there is upstream causes that are causing these women to fall off the bridge into the water, that we as a system, multi-sectorally, have to go upstream and figure that out and fix that as well. It's not enough. PAC saves lives, but I think I want to make that it's not enough to just save lives downstream when we're not dealing with upstream causes as well. So, and I think for me, this is where the concept of reproductive injustice comes in, because mortality from complications of unsafe abortions are not random. They are not random. So when you look at the people who are dying from unsafe abortions, they are first of all 100% women. Where are the men who plant these seeds? I've never seen a man who's died from complications of unsafe abortion or intended abortion as well, because where are we? So I think the first challenge we have to do is we men have to take 100% responsibility for sowing those seeds that make post-abortion care necessary. And there are many, many ways that we as men can take responsibility, including making sure that we are not violent, consensual sex, for example, but also standing up for the rights of women when they want those services, because we planted the seed and then disappeared from the picture. We also see the rural and urban divide on this as well. Death from complications of unsafe abortions are also very economic in the sense of wealth dictates the access to care as well. If you are a woman of means, if you don't want an intended pregnancy, across the world you can get a very good safe abortion anywhere. even if it means flying to Kenya or the US, you can always do that. So you see then the inequality of complications of unsafe abortion as well. And then we see regional disparities, but also we've talked about the teenage crisis, which I don't really want to belabor. But we are really failing our young girls and women. There's a research that was done in Kenya recently by the APHRC that shows that in Kenya, in 2024, there was about 762,000 abortions. Out of that, 80% were from married couples. So there's also a lot of myths around it as well, because women in marriages are getting pregnant and they don't want those pregnancies and they're ending up having abortions and they're not dying. Why? It's because they have means, they have economic ability, and therefore the economic element for that, I think for me, is what really describes the injustice around this as well. So when we talk about reproductive justice, for me it's a broader framework that includes reproductive rights, but also addresses the social, economic, and political conditions that impact reproductive health and choices. When we talk about reproductive justice, we're actually saying the right of every woman to have a child, to not have a child, and to be able to parent a child in a very safe and healthy environment. It's a principle that emphasizes that reproductive freedom encompasses all these choices. And I think as society, especially men, we can play a bigger role to advance that as well. So I really want to commend the Ministry of Health for some of the stewardship that they've provided, especially I think I mentioned the issue of Combi Pack, the PAC guidelines, the training manuals, the self-care approaches that really can go a long way to reduce some of these deaths. And in terms of health system readiness for post-abortion care service delivery, ensuring autonomy, equity, and safety, I think for me is really important. And to really emphasize that, Dr. Mugahi, we are not finished with the low-hanging fruits. And I think for me, making sure that all facilities are fully equipped with facilities like the MVA kits, misoprostol, Combi Pack is a necessary first step. Training healthcare workers, VCATing them so that they have their values clarified, so that they can provide services with less judgment on clients who are coming to them, I think is equally very important. But also having strong referral systems, I think is equally important. But post-abortion care must be seen as part of the safe motherhood with plenty of upstream multi-sectoral responses. And my last slide really talks about the power of partnership, because when you talk about the deaths from complications of unsafe abortion, it's not a health system issue only. The health system can play a part on providing post-abortion care, or providing also abortion care as well, where the law allows, as provided by the laws of the land. But it's a health and justice and education system. We have to work, first of all, I'm not preaching to the choir, but we have to deal with the stigma that we have against abortion and against post-abortion rights, because our boys and girls, our men and women love sex. I love sex. You love sex. We are going to continue having sex. And as we continue having sex, there's going to be continued unintended pregnancies if we don't do upstream work to really reduce that as well. But also we have to deal with gender-based violence and defilement that really expose some of our girls. Law enforcement and community, I think for me ensuring timely survivor care is really important, but also the civil society and professional bodies coming in to do advocacy and learning to support the efforts of the Ministry of Health. So with those remarks, I really want to stop there, and I'm really looking forward to engaging with you in terms so that when we meet here again next year, we can actually probably see that we've eliminated completely upstream causes that make PAC necessary, but also that women are able to enjoy their reproductive justice in a society that enables them to do that. I thank you.
I think Dr. Kitui deserves a stronger, a bolder hand clap. And with that, Dr. Kitui, we're appreciating you for that powerful keynote address. In your presentation, you end by reminding us the theme of this conference, as we see on the screen, is strengthening multi-sectoral collaboration and mutual accountability for safe motherhood. You've helped us understand why PAC is necessary. When us understand why PAC matters. You've gone ahead to help us understand reproductive injustice and how it's going to be the iniquities that we're seeing in the country. But the bold statement that is telling us that we, the women, bear the brunt of that injustice. And it's delightful to see that both men and women are coming together in their different capacities to discuss the matter. So with that framing, allow me to get into the panel discussion. And our first speaker is Judith Isuka, who I already introduced. Judith is going to help us, is going to discuss issues around facility level park provision and the realities as a provider that they face, the barriers, the challenges, and the opportunities that we see as we deliver park services to both the young and the older women above 24 years of age but live within the reproductive age group. So Judith, I'm going to ask you to step up and speak about the practical barriers to park provision in the rural facility setting, and what does a supportive environment for park providers look like? Over to you, Judith.
Thank you, Thank you, Dr. Lillian. I'm Judith Isuka. I'm a midwife. I work in Mukuju Health Center 4. The practical barriers we face as providers. Being a provider, we have had so many barriers while carrying out the park services. And one of them is inadequate supplies and equipment, stock out of essential park commodities, such as manual vacuum aspirations, kit, infection prevention supplies. We have analgesics, and then also antibiotics. Those are the common drugs we mostly use because as providers, we always handle the last minute cases, that is hemorrhage, infection, and then sepsis. So how do we go about with that? The solution would be to ensure a consistent supply chain management with the dedicated park commodities, whereby we have to increase on the budgets and functional logistics, and which can coordinate, and this one could be coordinated between the districts and the facilities. Then also we have limited trained personnel. Often only 1 or 2 midwives are able to give this service. And you find some of these midwives, they have to go off. And once somebody goes off, it means there's no continuity of service or someone is transferred. So you find the services are disrupted, and then also the solution would be to expand park training to more midwives and nurses to build a critical mass such that we have skilled midwives and providers at all lower level facilities. Another challenge we face as midwives, we always have stigma and judgmental attitudes. Some health workers and community members, they still attach stigma to women seeking park services, which at times discourages them from seeking timely care. So the best solution would be to do a VCAT, the value clarification and attitude transformation sessions for both the nurses and midwives, and also to make sure that people get this information. We clarify on the providers' attitudes, health workers' attitudes, and the community. And then we also have weak referral systems where you find at times these complicated cases can be delayed due to lack of transport, or you find that there's poor communication between facilities. So we need to strengthen that. We need to strengthen that gap between the providers and the facilities where we refer to. So the best solution would be to strengthen referral linkages through reliable transport mechanisms, clear referral protocols, and then also mobile communication between facilities. Inadequate privacy and confidentiality. You find most times we don't have spaces. We lack spaces in our facilities. You find that these mothers come, they want the service, but you find it is the same space, they are doing antenatal deliveries, so they have fear in seeking those services. So we empower our IPs and MOH to make sure we have enough spaces for PAC services in our facilities. You also find the rooms are not conducive enough. They are depleted, they need to be renovated, and when someone comes and sees that kind of environment, they are not even ready to open up to us. So we need to do a lot and prioritize, and also make sure within our maternity units, we ensure that we have respectful care for these mothers. So what is the supportive environment in PAC? How is this supposed to look like? For me as a midwife, I expect an environment whereby I'm valid, I'm protected, I'm equipped, and I'm motivated. So with that said, we expect availability of essential drugs. Providers must have continuous access to safe equipment, infection prevention materials and supplies, and then functional infrastructure. And then also we expect supportive supervision and mentorships from our district mentors. And then the peer learning and feedback from the people who come to give us this support, so that we are able to build our confidence and skills. We also expect emotional and psychosocial support. At times this work is so demanding, and we expect peer support groups and stress management opportunities like these ones. When you come here after that stressful work, you feel you are really rejuvenated. I expect midwives, by the time they go back from here, they are going to do better. Then also we also expect clear policies and legal protection. I'm happy I'm able to see the guidelines in our tables. So I expect that environment where I'm protected, no blame. At times you find there are risks while they are providing PAC. So with these approved guidelines, I feel the health system should be able to clarify policies and define their scope of practice, our scope of practice, and then legalize our backing. Then also recognition and motivation, acknowledging PAC providers, acknowledge their contributions through awards, career progression, inclusion in districts, and strengthen their morale. So these are some of the things which can motivate us. If in a district you can sponsor some of your midwives, it should not be necessarily the IPs. The DHOs should take this and make sure they recognize and motivate their midwives by sending them to attend this kind of conferences, because they have a lot of learning. Then also expect enabling leadership, whereby facility and district leaders should advocate for PAC, allocate resources, and ensure integration with the family planning and other reproductive health services. So with this said, in summary, I would say improving PAC requires investment, not only in supplies and skills, but also in a supportive system that protects and empowers midwives. When midwives are enabled, women receive safer, more dignified, and timely care across. So, thank you for listening.
Thank you very much, Sister Joyce. I like the way she ends. So, thank you. In a nutshell, have you heard what I've said? For me to serve you better, please hear me, so that I will ensure that no young girl or woman dies because I've not been able to deliver the PAC services that they require, because I am not protected from the system that finds me guilty for delivering post-abortion care just because there is the word abortion in the services that I offer. So this really leads us into the next conversation that is discussed and going to be led by Dr. Bagala, who is required to help Sister Judith navigate this complicated space of a health system, unless strengthened, I'm not able to deliver, but also a social system that, if not protected, there is no justice for me. So I will not deliver the service. So Dr. Bagala, in your capacity, we are asking that you discuss with us the measures needed to institutionalize PAC services across Uganda's health system, in line with the guidelines that you led in that development. We are also asking that you guide us on how Uganda can strengthen the commodity security, supervision, and referral that Sister Judith spoke of. We are also asking to hear from you what lessons can be drawn on policy alignment and strongly on accountability. Over to you, Dr. JP.
Yes, thanks very much indeed, our moderator. First, to really thank every person in this room, because I think when we started the efforts around the maternal perinatal death surveillance and response, as the Commissioner highlighted in his presentation on Wednesday, and the local maternity and neonatal systems, which I provide a strategic oversight for at the Ministry of Health, we've seen significant change. But this has taken a team at national level, a team at the regions, a team at the district, and a team at the facility. And for us to be able to cascade and institutionalize PAC, it's going to take that same approach and pathway. When we realized that PAC was known an area that was being given due attention, as the ministry, we led the establishment of the PAC Steering Committee. And we were privileged that that space had quite a number of players. But what was lacking was the central coordination. And that's what we had to provide, the central leadership. We had, as the ministry, we had to provide that piece. As soon as we instituted that piece, we agreed as a steering committee that we needed to be very intentional. And in being intentional, it required us first to look at the building blocks of the healthcare system, from the guidelines that would enable us to have a well-informed, competent workforce, to look at the commodity needs and essential supplies, which the previous speaker talked about, looking at the financing to ensure that we are pooling resources. The reality of the matter remains that we are short when it comes to resources. We don't have significant resources there available. So harnessing every single coin that we have from the various players was very, very critical. Ensuring that data is at the center of every conversation that we have as a steering committee was very critical. But also we realized that there was a bit of silo operation or segmentation in the way business was being conducted. So we really had to ensure that we are getting everyone on the same table to have a common conversation. And for me, I really want to appreciate every single partner who is part of the PAC Steering Committee for really layering efforts behind the vision of the PAC Steering Committee. And what the PAC Steering Committee did, as in addition to mapping the various players, was to ensure that we have that guideline. And I'm very happy that in this 5th National Safe Motherhood Conference, we've had it launched. Now, it's not to be shelved, but the content of that guideline is to be put to use. And every healthcare worker who turned up here today, let's go with that message that we have to turn that guideline into actual practice. Now, the other piece that we had to do, we realized that, okay, fine. If a doctor or a midwife graduates after school, they never get an opportunity to have their skills refreshed. But also, we had a little bit of segmentation of the various manuals that speak to PAC skills. And so we agreed as a team that let's pull all this together and have a harmonized PAC manual, which we did. And very soon that will be out. So that is contributing to the institutionalization of PAC service delivery. But it's also very important to note that we provide PAC across our different levels of care, away from national referral maternity centers to the lowest level, and that is the center 3s. And I really want to appreciate partners, because I've been privileged to visit some areas that IPAS is supporting, and I was very, very amazed. I found midwives in Tororo providing Pudendo nerve blocks. Very amazing, and safely. And what occurred to me was a question of how can I get another midwife in Kampala Metropolitan competent enough to provide that level of pain relief? Because we've seen some clinicians providing PAC services under uncomfortable circumstances. So that speaks now to the skilling which we will have to further undertake. So through the PAC Steering Committee, I know the time is very limited. Through the PAC Steering Committee, we are very, very intentional to ensure that we leave no healthcare worker behind. And we are very, very intentional to ensure that every facility that provides PAC or maternity services is reached in terms of receiving the guidelines that we've launched in this conference and ensuring that the skills of the healthcare workers that see these women are refreshed on a continuous basis. Now, the issue of commodities still remains quite critical, and I think the midwives talked about that. Now, it's our responsibility as the ministry to ensure that the commodities are available. But also what we are saying to the managers in facilities, that with the small envelope that we have, can we prioritize and ensure that we have the essential critical commodities that will save that bleeding woman who has lost a pregnancy when she reports to a facility? Because we've visited some facilities and they have stocked a good number of vaccines and rabies vaccines, but they don't have IV fluids. And we've always wondered, how are we prioritizing the way we are procuring commodities? So our gospel on preaching how to prioritize to essential critical commodities remains very, very critical. But also as government, we've increased on our resource envelope for commodities. And I think the Commissioner talked to that earlier in his remarks on Wednesday. We've increased across all levels of care. But the intention of that increase was to ensure that we are increasing on the amount that facilities can procure as far as the essential emergency critical commodities are concerned. Now, once we have these commodities in the facilities, the accountability of their utilization becomes also critical. Now, the utilization of the commodities to ensure that they are not getting legs out of the facilities into the private centers remains very critical. And that speaks to the leadership that we are providing in our stores, the commodity stores to start with, the store managers that are managing these stores, the facility managers. We've undertaken supervisions and we found that the store managers abandoned the shop and they left their duties to just untrained nurses. So the management of commodities remains very, very critical. And that speaks through the entire cascade of leadership. Now, the regional mechanism is very important to foster all that. The local maternity and neonatal systems are very, very key. And we are very intentional at the Ministry of Health to ensure that every LMNS is supporting efforts to do with reproductive, maternal, newborn, child, and adolescent health. Because that's our regional RCH framework at the Ministry of Health, and we want to ensure that the regional referral hospitals are also supporting the lower level facilities. We started what we call the integrated technical support supervisions. The issue of supervision remains a critical challenge. As the ministry, we've revised our approach and modus operandi to make it very intentional. And we want to encourage our district colleagues to be very intentional when it comes to an issue of supervision. And when we say supervision, it should be intentional. It's not just touring facilities, but it's appreciating what these facilities and the healthcare workers in those facilities are doing. While we are struggling with issues of absenteeism, both organized and non-organized absenteeism, is because we still have gaps in supervision. If the facility managers don't do their job, and if the districts don't help us to be strong on the issue of supervision, then we shall not perform. as a country. So it really starts at that lower level and then it cascades up. The results start from even the head of maternity, that in charge, you as an in charge, a midwife in charge of labor suit. Are you able to account for every single officer within your unit? We've seen rotas, duty rotas that have been manipulated to cater for organized absenteeism in facilities. Those are things that we have to individually reflect on, because at the end of the day, we are not serving the people that we are meant to serve. The issue of mentorship, I've talked about that. That must continue. And my colleague here talked about how we have to strengthen our referral pathways. That is very, very critical. The issue of referral pathways, yes, we've tried as the ministry to ensure that we have the vehicles in place. But it's not just about the vehicles. And moderator, please, you lend me the minutes left because I can speak till tomorrow, but you just tell me that I have 2 minutes and then I can stop. So the issue of just having the ambulance is not enough. If I have a mother and I've received that mother in a level 2, but this mother, I appreciate with my conscience and skill and knowledge that I cannot manage that mother. How do I facilitate the movement of this mother to a level where she should be managed safely? But also to ensure that when she reaches where she's supposed to go, they are ready to receive her and respond to her timely. In most cases, we contribute to the second and the third delay, obstetric delay. So it's upon us, and the reason we come here is to reflect on how do we ensure that we are doing more of what we are supposed to do to save and ensure that the lives of women are protected. I talked about the issue of procurement, that we have to be very intentional and ensure that we are prioritizing. And I really want to conclude with these 2 issues. Every single person in this room is a leader. Every single person. For as long as you're a healthcare worker, you're interacting with colleagues on that unit where you are, and that takes particular leadership skills on how you communicate, on how you interact, on how you handle complicated patients. So you are a leader. Can we exemplify those skills of being leaders? Every single health facility manager, every head of the district, the DHOs, the ADHOs, every single chief administrative officer, and for us at the Ministry of Health, we have been given the opportunity to serve our country. Can we do it with the utmost effort that we can? Because there is another person out there that doesn't have the opportunity that we have. Leadership, governance, and accountability. And accountability should be at the center of the safe motherhood movement, for which we are having the conversation today, but also should be at the center of every single effort that is going to ensure us that every single mother in this country receives quality, safe PAC services when they need them. Thank you.
Thank you very much, Dr. JP Bagala. I think Dr. JP is in a very hot seat because we all turn and look at him with the expectation that the ministry must take care of us. So as he spoke to critical issues. And he reminded us of the fact that for us to manage PAC and the unsafe abortions, we must, from the health perspective, frame them within the health system perspective. So he talked about the WHO building blocks of health system strengthening. But out of that, he spoke of things that we must be aware of and are held responsible for as health workers, but also collaborative partners in the delivery of the PAC services. So allow me appreciate the ministry for their boldness in coming out and guiding us on developing the guidelines. And we must recognize the effort that they put into this whole system. Teenage pregnancies is difficult to talk about, but they've again come out and said, because the young population is dying off, let's work together with the PAC committee and develop the guidelines. Let's develop the LNMS system to guide the delivery of services, inclusive of PAC services. So I think the ministry deserves more recognition for the great work that they do. Because many times we come out and say we facilitate the ministry to deliver the work that they're supposed to do. So we take a back seat as partners and leave them in the hot seat. So we thank you, Minister of Health, under the leadership of Dr. Mugahi, for the boldness that you are putting forward to manage the issue of unsafe abortion, but also provision of PAC services. So a round of applause to the ministry and to Dr. JP for speaking to this matter. But allow me to emphasize one more thing about supportive supervision. The other day or yesterday, Dr. Richard spoke about the empty ANCs that we offer. It is very plausible that when we go out to deliver, to provide supportive supervision to Judith as they offer services, we also provide empty supportive supervision. We go in, we make a round in the city, we check, do you have this, do you have the other? Then we go away. But we never sit down to provide that guidance for them to feel valued and supported. So it remains a call to us all that when we go in and say we are facilitating the means to deliver services, what exactly are we doing as we are holding them accountable, the delivery of services? So thank you very much, Dr. JP, for that great deliberation. And this gets us into the learnings that we must learn from our neighbor, Kenya. So I'll introduce, I'll ask Dr. Lois Nyanjao to come up and speak to us about what strategies that Kenya has used to reduce unsafe abortion-related mortality in their country, and how Uganda can translate policy frameworks into routine PAC delivery. Over to Dr. Lois.
Thank you so much, colleagues, and I really want to thank the government of Uganda, Ministry of Health, for inviting we from Kenya, Ministry of Health, to come and share our reflections on our landscape in matters PAC, and congratulations on releasing the PAC guidelines. It's a really strong step towards doing justice. I want to appreciate Dr. Kitui's keynote address, where he took us through a root cause analysis, and he asked the 5 whys of why women and or girls are dying from complications of abortion. And he walked us through the journey of getting to the upstream causes of the challenge that we are facing today. And that frames very well this discussion we're having today on reproductive justice. So thank you very much, Dr. Kitui. To respond to the area I am to reflect on, and to share what Kenya has been able to put in place in responding to the challenge of mortalities relating to post-abortion, I would like to invite us to think it through the funnel approach, moving from outward coming in, and this leads us straight to a rights-based care notion. As a region, when I say region, I mean the East Africa region, we are party to international treaties and conventions. For instance, we are all party to the Sustainable Development Goals, where we have a responsibility to deliver on SDG 3. We are party to the African Union Charter, the East African Community Treaty, and others. And all these treaties and conventions require that we provide the high standard of living and well-being for our populations, and we also harmonize our health policies. So we are invited to learn from each other and harmonize the health policies so that we as a region, we are brothers and sisters really, divided by artificial borders, but we bring or carry the well-being of our populations first. So in line with the responsibilities we have to the global community and to ourselves as a region, Kenya took this and inculcated in the Constitution of Kenya 2010, providing that all Kenyans have the right to the highest attainable standard of health, and tied to this is the right to emergency care. Picking from that, our legislation, which is the Health Act of 2017, provides that, or rather defines health as the state of physical, mental, and social well-being, and therefore ascertains that all Kenyans must access care as enshrined in the Constitution. Based on this, we then developed our health policy and our reproductive health policy, 2022 to 2032, which assures or provides that Kenyans will get unhindered access to maternal and newborn health care, including services that lead to the termination of pregnancy where it is medically indicated. Learning from this, or picking up from this, we then developed our post-abortion care guidelines. And these guidelines essentially assure Kenyans of services for post-abortion care, which in our context begin from the point where a woman or a girl presents with bleeding. So we will frame our discussions from this point in the context of Kenya. The PAC guidelines in Kenya are anchored on 5 elements. One, the first and foremost being counseling and awareness raising for our clients, and then treating the complications of incomplete abortion, managing any comorbidities or pre-existing conditions, providing family planning choices and services, and then building up partnership between the community and the healthcare providers. And when I took a glance through the PAC guidelines that are just released in Uganda, I find that all these 5 elements are instituted in the guideline, and in addition, to which I am learning from, and I'm really proud of Uganda for this, including the standards for post-abortion care within the same document. And I think this is an area we should commend Ministry of Health Uganda for. And thank you very much. So, in my view, and from the Kenya experience, the learning that I find is worth sharing is that we have really transcended the notion of access to healthcare and access to emergency care throughout the policy framework, starting from the Constitution of Kenya, through the Health Act, through the health policy, through the reproductive health policy, and eventually to the PAC guidelines, so that we enshrine and keep sharing the same message that our women and our girls deserve to receive unhindered access to care, and for that matter, emergency care should be universal. In the translation of policy to practice, I want to align with the comments made by Dr. Bagala that this practice should transcend the 6 building blocks of a health system. The governance structures and the leadership initiatives are paramount. And I'm really encouraged, and I learned from Uganda, on there being an agency that drives the leadership and governance in matters PAC, where we have, in Uganda, you have the PAC steering committee, and I think that's an area for learning from the region. In terms of health financing, we have to accept and be intentional in generating and using the evidence on the return on investment in implementing or responding to abortion or post-abortion related issues. Without evidence, it becomes hearsay or ad hoc information, and we have to learn to use and generate that return on investment evidence for all of us. On matters human resources for health, in Kenya, we intentionally have standardized messaging at the pre-service and the in-service level so that we harmonize the knowledge that is utilized by our health workforce in responding to unwanted pregnancies and also the complications that come to incomplete abortion. One area that I find stands out very strongly, and I believe it needs to transcend beyond the health workforce, is the use of VCAT. VCAT stands for Values, Clarification, and Transformation. where we, as stakeholders in this sector, we analyze our own individual values, biases, and perceptions, and reflect on what is really important for our clients. So whenever we are building up that capacity or training on post-abortion care services, we require that each individual is taken through VCAT. In the area of health products and technologies, and I'm really appreciate the discussion that has been done by Dr. Bagala and Judith, I acknowledge that we seem to have similar challenges in Kenya and perhaps maybe in other jurisdictions. Supply chain security is an area that is growing, and I hope that we can also pick lessons from Uganda and build on that. Other than including post-abortion care commodities in the essential lists, making sure that they reach to the lowest level facility, and even in the case of jurisdictions that allow to the community levels, it's an area that we definitely should build up. In the area of service delivery, in Kenya, we have integrated PAC services in the normative service areas for maternal newborn health and, say, outpatient areas. In the community level, it's an area we are building up. Our community practitioners, who are we call them now community health promoters, are now a paid cadre, and that has really helped us standardize and increase the reach and scope of community services, which is more so education and referral for services. Health information systems cannot be understated. Their role in enabling decision-making, in generating evidence, and supporting continuous improvement is something that investment in should begin at scale and be maintained in there for prosperity across board. The partnerships that enable this robust provision of services sometimes can be touchy, I agree, in terms of PAC, but they must be fostered and they must be cultivated. And I will repeat, in my view, if we all undertake values, clarification, and transformation, I believe the partnerships across board, whether it is in public or state and non-state, or among CSOs, or among other constituencies of community engagement, I believe that will really build up healthier conversations. Thank you very much, and I look forward to engaging with you all.
You know that saying in the Bible that says iron sharpens iron, or did I choose it from the wrong book? But as Dr. Lois spoke and Dr. Bagala kept shaking his head, I understood that he understood what he needs to go forward with. So thank you very much, Dr. Lois, for ably speaking the issues that you're facing, we are facing, and what we can pick up. At the start of your conversation, you did say that your guidelines that you have are very integrated. So even when we have launched ours, we are required to go back and do a quick review. To what extent are they integrated to deliver appropriate services to the person who needs them the most? So Dr. Bagala, I trust you have picked everything you need, and we have what to move forward with. And all members of the PAC steering committee and everybody present, because even though the guidelines have been launched, we need to improve them for the betterment of the well-being of the people of Uganda. So thank you very much, Dr. Lois. You did mention about evidence. You did mention about the VCAT, how far we can go with that. You did mention about governance and also digital or AI-related issues. So this leads us into the next conversation by Dr. Polifile, where we are, as a researcher and an academic person of academic background, we would like to learn from Rwanda how you have navigated the legal ambiguity and provider hesitance with evidence. We also want to learn more about the innovative models that Uganda can adopt from Rwanda's PAC system. I'm trusting you do this in just 7 minutes. Thank you.
Thank you so much. The ambiguity around post-abortion care is a common problem everywhere in the world, and interestingly, even in the developed world, where they have all the resources to look into their problems, it still persists. But nobody is going to respond to our issues here if we don't develop our own eyes, our own lens to look into our own problem. Rwanda has taken that as a personal problem, and we navigated it with stringent mechanisms. So some of the key mechanisms that I can share, there has been policy clarity. So the government of Rwanda, through the Ministry of Health, issued clinical guidelines and ensured they are very well implemented with standard operative procedures that puts post-abortion care as part of the routine care. This did not only shift the issue of abortion from a morality standard, but it also made it as a duty to treat. So we are trained at school, but when it comes to providing this, sometimes we hesitate. So this made sure that it's translated. There has been also strategies for task sharing and shifting. So most doctors, including myself, I'm a gynecologist, but I remember very well that I was trained how to do a digital vaginal exam or labor monitoring by a midwife. So how to ensure that the uterus is well evacuated, there is no retained product of conception, that retained placenta that may lead to postpartum hemorrhage. So all these, the essential techniques were by a midwife. But at some point, we had a policy that allowed only doctors to do this post-abortion care, offering these services. And somewhere in the middle, we realized, but they are trained by midwives, there's essential skills. So why don't we allow the midwives? So the government of Rwanda, the Ministry of Health, ensured that the tasks for women suffering from abortion complications, abortion process, who are coming for bleeding from abortion, they can be managed by the midwives. And we trusted the midwives because we trusted the education that they are given at school. And also VCAT training has been emphasized for both in service and the pre-service training, which reduced stigma and emphasized the professional duties. So also accountability. I love that from the very beginning of this conference, all the keynote speakers and our chief guests, they all emphasized on accountability. So Rwanda took accountability and also quality improvement activities on its hand, doing facility audits, and look into the near-miss events, not only maternal deaths, but also near misses. So did we really need to have, to give transfusion to somebody? Why couldn't we have done something different to prevent going this far? And also we looked into post-abortion care indicators through our HMIS portal, and we discussed this data and what it means to our own population. We emphasized on patient-centered care, so special care for adolescents and people with other people with special needs, ensuring every health facility has a dedicated care for the marginalized communities. So nothing is going to work if we don't put the key, the service users into consideration. So with our 4x4 strategy, healthcare workforce, in the next 4 years, Rwanda has made sure that women are part of this movement. We increased the number of women attending medical school and residency program and other advanced training, fellowship, and so on. They do understand better the problem of women, and they teach other care providers better than other educators that based on research only. So, and also partnership with other organizations, and we looked into the regional capacity. So I think Uganda can also learn more from what is existing. So when you look at the policy, the post-abortion care policy and the SRH policy in Uganda, it has the key components that can really translate into healthier practices and prevent maternal mortality and morbidities, and we all have a safe motherhood. So there is this one model they call the Kingdom model of agenda setting. Post-abortion care can need to be on the national agenda. So it's not going to work if, as care providers, we don't generate sufficient data, we don't take the genuine data, and we speak to the policy and see, are we conflicting with the policy? Then the policy knows we are conflicting with this, and then it also informs the political will to look into it. So the clinical guidelines, I love that they recently, during our first day, they launched the guidelines. And one thing that we need to do is trust these guidelines. They were developed from our own data, our own information. Even when you don't necessarily agree with them, trust that they are meant for the best health of a Ugandan. So, and also capacity building. So generate e-modules that can teach people on post-abortion care, provide mentorship and the provision of doing maternal mortality and morbidities that are related to post-abortion care. So I've learned that the DHIS is well used in Uganda, and it can be also an entry point to look into what we are doing, what are the main causes of maternal mortality and morbidities when it comes to post-abortion care. So, and emphasize on community referrals and continuity of care. And when there is no national capacity to advance or increase access to post-abortion care, use the regional capacity. There is some capacity in Kenya, there is some capacity in Tanzania, there is some capacity in Rwanda, Burundi, Ethiopia. Let's take this and use them. And in the end, finally, to prevent the need for abortion, let's accelerate the uptake of contraception. Thank you.
Thank you very much, Dr. Pofile. He speaks French as his first language. So we are delighted that he could ably articulate critical issues. And he ended by saying, we are the East African community, in a few words. So we have the opportunity to learn from our neighbors. I'll emphasize that iron sharpens iron. And when he reminds us that we as Ugandans know our problems, so we must create solutions or design solutions that suit our problems, then he speaks to what Dr. Kabanda spoke yesterday, that we must co-create our solutions because they could be different in different contexts and regions. Dr. JP spoke of the LNMS system. You know that we have regional LMNS systems. The issues in Kampala are so different from the Borneo region. They're so different from the Eastern region. So we are reminded that we know our problem, so we must deal with our problem within our context. And Rwanda is known for taking what we have designed and implemented. But he's reminding us that even them, even when they are adopting what we have, they first understand the issue and utilize our frameworks to make their life easy. But data remains the essential or key ingredient as you're designing and developing your programs. So thank you very much, Dr. Polifile, for giving us a better understanding of how you navigated the legal ambiguity and the provider hesitancy. You spoke about the task shifting. You spoke about, you're reminding us of the VCAT, or you're reminding us of the accountability framework that you're utilizing, and the special models. But you're also telling us that, we have special groups that seek services. You talk about people with special needs. And I hope that those will have data that helps us address that specific needs that come to PAC service delivery. We have come up, a few questions have come up that we should take a moment to address. Many are very specific to the different countries, to Rwanda and to Dr. Lois as an example. But you can take a moment to view them. And in 1 or 2 minutes, then we'll be able to address them. The person managing the screen, do you mind going back the first question, please? We need a deliberate move to enroll the private sector providers while implementing PAC guidelines. Dr. JP. The second one, and the PAC committee. Number 2, how can you integrate contraception in the school healthcare package in order to reduce the issue of unsafe abortion? I will read the question again. I'll say the question again. How can you integrate contraception in the school health care package in order to reduce issues of unsafe abortion? I'm reading it again intentionally because we've had comments about the sexuality education package. And unless we look at it critically and understand the needs of our country, then we might not be able to address that question. But we have an opportunity to look at it deeply. Then how can we handle the issue of schools which expel students after being identified pregnant? This has led to many girls doing criminal abortion. What is being done to handle the issue of private clinics doing illegal or induced abortion and referring severe cases of failed or incomplete abortion? Dr. Lois, have you seen? Thanks. How has Kenya handled challenges of BTS, traditional birth attendants, when it comes to safe abortion care? Okay, safe abortion care. What drives implementation of strategies to curb TB activity? In our communities, many women still believe that after abortion, they are to get pregnant, so it's difficult to convince them to use family planning. I'm going to ask our panelists, Dr. Lois, Dr. Judith, and Dr. JP, in 1 minute, to each address the questions that are coming to you. Dr. JP, the issue of school and sexual and sexuality education, definitely coming to you as government, because you know the frameworks and the guardrails around it. Then Sister Judith, you speak about what you're seeing in the community and the TBAs if you can. But this also goes to Dr. JB, briefly. After the response to those questions, then we have a special guest online who would like to make comments to the meeting. So quickly, please.
Yeah, thanks very much indeed, our moderator. Yes, it's true that we have work to do when it comes to the schools, but when it comes to adolescents and young people, we are looking at the school and out of school, because also the out of school are quite significant. But very importantly, our school adolescent and school health guideline is really informing our interventions, and we've established district committees to support both the schools and the out-of-school adolescents. We've instituted accountability platforms which happen every Friday, targeting the adolescents and young people. And we've taken a multi-sectoral approach that, and it speaks to our theme today, the multi-sectoral approach in addressing the issues affecting the adolescents, but also improving safe motherhood. And that brings on board the Ministry of Education, the Ministry of Gender, Social, and the Ministry of Gender, Labor and Social Development, and the Ministry of Health. But also we've onboarded heads of schools, we've onboarded the cultural and religious leaders, because we believe that the conversation around how we can improve and tackle the challenges of the young people in schools, all out of school, requires that multi-sectoral approach. And on the issue of the TBAs, we remain very intentional. We've issued a guideline as the ministry on how they should be approached, and we continue to track that through our respective districts to ensure that we avert mortalities that are happening within the TBA practices or clinics. Thank you.
Thank you very much, Dr. Bagala. Dr. Lois?
Yes, thank you very much for that question, very important. In the Kenya experience, and I believe in this region, traditional birth attendants are a very critical component of our society. And in Kenya, I would say probably 10 years ago, we took the approach of, more of a radical approach to ban activities by the TBAs, but this did not succeed very well because they are really a valuable resource within the society as perceived by our population. And so we changed approach, and we now have taken them in as part of the workforce within the community. We have transformed these practitioners to what we are calling community health promoters. We train them on delivering awareness, education, and linkage within the community, and we enroll them as community health promoters. And this has really improved our scope and our coverage in matters, education, and linkage from the community. So essentially, we applied VCAT, and I will keep repeating, VCAT is a game changer. You may not call it VCAT when engaging with the community members, but the principles remain the same. Clarify the values and transform the attitudes so that you achieve the end goal that you're looking for. Thank you.
Thank you very much, Dr. Lois. You're becoming a doctor, Judith. I declare that. So I keep referring to you as Dr. Judith, but Sister Judith, in 1 minute, please. The question is about the community. It has kept running. How we are involving the community in the management of post-abortion care. It was among the first questions.
What we have done as Tororo, IPAS has been able to fund some community organizations who are giving information. They have been able to train VHTs, they have been able to train peer champions. These are people who are already on the ground, and they're giving in information, they're meeting the religious leaders, the cultural leaders, and then ourselves also when we go for outreaches, community engagements, we give this information and people are able to get it. That is how we have managed.
Okay, thank you very much, Sister Judith. More questions are coming through. Many are directed to Dr. Lois, the learnings we're getting from Kenya. Many are going to Dr. Bagala as the Minister of Health lead person, and others are going to I think, the learnings we're having from Rwanda. And I'm going to propose that as many of them are pointing to the quality of care, many of them are pointing to the frameworks, the health system strengthening, WHO building frameworks. So we are being guided on how, or we are being questioned on how we can best deliver quality park services, and in which framework. We are also being asked, how do we manage post-abortions within the education system, because they exist. We are being questioned on how we've institutionalized the existing frameworks in the country. For example, in the community we have TBS, how do we best work with them? Because even when we try to curtail them, people will still seek services from them. I think it's a question for us to go back with and be able to address. And hopefully when we return in the next 1 year, we'll be able to speak to them or even speak through them as the year goes on. There's a question about the private sector. I need to confirm that the private sector is greatly involved in this delivery mechanism about park services. But a question I think that remains to us is, how well are we controlling the quality of care in the private sector? Is something for us to deeply deliberate upon, and it has been talked of over and over again. We have an important speaker online who should be speaking to us, addressing us shortly. But if it's agreeable to Dr. Mugahi, can I close this session and then we'll ask them to speak to us. So we'll do this very quickly. We were set to complete this conversation in about 15 minutes. I want to confirm to the audience that we have taken the questions, we have tried to package them, and I hope that as we reflect on this session and in the closing remarks, the questions will be highlighted about PAC because it's a delicate conversation, and we'll have commitments on how to address them within the next 1 year. And when we are returning a year later, we are speaking with tangible results on how we've managed that process. But before we close this session, and before we get the last thinking from every panelist, allow me to boldly pose this question to us and reflect on PAC and unsafe abortion in the country. I recognize the challenges of speaking about it, yet it is the open secret that we all don't talk about. So, we have heard from our panelists that post-abortion care is multifaceted. It's an issue that the medical, legal, social sectors must deal with, but it remains a very personal issue. We've explored issues about service delivery, we've heard about the health system, we've heard about the legal issues, and what Rwanda and Kenya have done, and what we must learn. Now, I want each one of us to pause and reflect deeply, because it's a personal issue. And if we take a step back, and we hope that we understand PAC in the lived realities, what do we believe about PAC as individuals? Is it worth investing in as a nation? Is it worth us talking about in such a session? And if it is, then how do our cultural, religious, and social narratives shape the access and stigma for PAC services? How? It's a point of reflection for all of us. And even when we won't be able to speak about it because we're running out of time, I want us to think deeply, and we can give our responses in Slido and say, and address the question that how can we foster open dialogue and greater public understanding of PAC as a critical element of safe motherhood? I ask again, how can we foster open dialogue and greater public understanding of PAC as a critical element of safe motherhood? If you can please type into Slido. We'll be able to see that at the end or at the break time. How can we foster open dialogue? Dr. Atwine to address the session.
Thank you so much, Dr. Lillian. And without any more comments, it's a very sensitive and nice discussion, and the conversation will continue. I want to invite our PS, someone who is very passionate about maternal and child health. PS, we are in day 3. I know you are rushing to the airport, but please address us as you move to the airport, and we are happy to hear from you. IT team, please. I don't know where you are, if you are able to do visual, but go ahead, Dr. Twine. Thank you.
But I want to thank you so much for organizing and coming to attend this Safe Motherhood. Am I clear? The network. I'm in transit. I'm just going to the airport. I don't know whether you are able to hear me properly. Are you able to? Am I clear?
Yes, we can hear
you. First of all, I apologize for missing this very, very important meeting that I was looking forward to, but I had to leave to represent my minister, who is right now busy in political activities. And I really felt so bad that I missed this Safe Motherhood, because it is always very, very close to my heart. I want to take this opportunity to thank the organizers of this meeting, the sponsors. Without you, would not be able to convene this meeting. And I am glad when I joined, were really talking about the lessons learned from different countries, but also emphasizing the multisectoral approach as the theme of this meeting. The meeting I'm attending right now here is attended by global leaders. And the shift now is going back to multisectoral and really talking in real sense of multisectoral approach, because sometimes we talk about multisectoral approach and collaborations, but it remains superficially implemented. The global community is now realizing that the way to go to manage all these challenges that we are having lies in integration and multisectoral approach. And I'm glad, I believe all of you in the room, I don't know which people attended this time, but I really want, hopefully, that in the subsequent meetings, we want to see education present, gender present, so that it is really a collective effort. It is very, very clear that Ministry of Health and partners cannot do this. We can only do this and do it better if we work together and each one playing their roles. One area that is still not very well implemented, and I think when I joined, the discussion was ongoing on school health, on girls in schools, and we need really to focus on adolescents. The issue of post-abortion care, I found under discussion, it is something that we cannot discuss in detail in the meeting like that. It needs a critical thinking, a deep dive in the factors that are causing our girls to go for abortions. And we will not change this because these are our values. We will not continue to embrace abortion as a country, but we must look at the factors that are leading to these girls getting pregnant at young and tender age, and they opt for abortions. We are also cognizant of the fact that many of our girls still are getting pregnant and drop out of school. And that affects their future, it affects their livelihood, and sometimes it leads them to having complications at birth. The efforts that we are making as a country are yielding results because we are seeing, I think that the even teenage pregnancy has slightly reduced, but it still remains a big burden. I want to congratulate the teams that have been working very closely with the school health and also the communities to make sure that the girls, even those that they drop out of school, are supported. I want to thank partners that have come through to support these young girls, especially in rural areas, that the ones that could not go back to school. But the burden remains a very big problem for our country. I pray that in the next Safe Motherhood, it will give us opportunity to showcase the interlinked activities, the integrated activities between the line ministries of gender and education and other relevant ministries like local government and agriculture, and all those are factors that somehow are leading to these girls dropping out and getting pregnant and getting all these complications. And so we really need to continue to work, to be intentional in looking at the factors, addressing the factors in totality, a more comprehensive approach. I do believe that the efforts that we have put in the last few years, they have brought us results, and really we celebrate these results. But at the same time, I know that the burden at hand is still big. When I joined, one of the persons was talking about the TBAs. As a country, we will not adopt what other countries have adopted in accepting TBAs. What we need to do is to continuously educating our masses. I do believe in years to come, when education levels get better and we have less and less people, less educated population, they will learn the effect, the bad effect of TBAs. And therefore, we will not be able, and we should not be very quick to take on other people's experiences. We must, as a country, stand out and educate the public. We must educate and actually focusing on the dangers of having our people kept at the TBAs for long and we lose lives. We must bring out the statistics and evidence-based discussion to the population so that they are able to learn from first-hand experience. We will not go back because the generations to come will be more cognizant and more educated. I believe they will not be able to go to the TBAs. We have brought closer the services to the people because now 91% of the population are within 5 kilometers reach of our facilities. And so the message must be very clear that you do not have to go to the TBAs. The facilities are near you and they are able to, and as we continue to improve the services at Health Center 3s and making sure that they are more functional and they are more equipped and staffed. Once we start implementing the recruitment of as according to our structure, our new structure, we will have doctors at Health Center 3s. That means in every sub-county, we will have doctors at health center 3s. And therefore, there is no reason whatsoever we should go backward and start talking about going back and use TBAs. And therefore, we must be firm, we must be consistent, we must be deliberate, and we must design our programs that will take our population forward in terms of knowledge, in terms of understanding of why we have to go to facilities instead of the TBAs. So I really wanted to put that one very clear, because we will not go backward. We will not be able to say, let's go back and bring TBAs again and train them and blah, blah, blah. No, that one we close the chapter and we will not go backward, because our population now is more educated and they are nearer the facilities. The task that is at hand as government, we need to make sure that we put proper services at health center 3s. And we make sure that we have equipment, we have the medicines, we have the staff, so that people have no reason to go to TBAs. We must ensure that we have quality services at facilities that attract the population to come to us for care. We must be able to speak about the ills, the evil that are associated with going to TBAs. It is a journey. It will not, definitely the mindset is still, we have to deal with the mindset of our people. We have to continue to educate them. But I do believe that continuously educating the public, we will get to a time when we will not have those TBAs and they will have no job. They'll run out of job. That is something that we are very optimistic about as a country, and I do believe that this is the time to get our shoes on and we make sure that we deal with seriously the issue of TBAs, because it is something that is contributing. Like I missed your presentation. I really wanted to see whether we have some data regarding the mothers that have died at the hands of TBAs, but I do believe that they are significant even now. So the work is cut out for us for the next 1 year. As we talk about multi-sectoral approach, we need to discuss the integration. I was very happy when I came in this meeting, and from the time I got here, they are talking about integration, and they're talking about integration in a manner that I have not heard it before, because the world has realized that that is the only way that is going to help us. So the activities concerning adolescents, the activities that we are going to implement moving forward, that are going to give us even better results, quicker results, more resounding victory against these evils we are fighting, are going to emanate from how we are going to integrate together with other line ministries and activities. And I hope that really moving forward in our safe motherhood conferences, we want to see all these ministries participate. I would be so glad to see and to hear what education is doing, what activities we are undertaking in schools by education, because we cannot implement these activities ourselves as health. We want to hear what education is doing, the practical approaches to integration as far as adolescent health is concerned. Activities on post-abortion care, activities on obstetric and and community, because we have even gender. I'm glad I think PS is the one who opened the the youth conference. So we need to see now what the activities, why are at the implementation level, and how is local government coordinating our activities at subnationals to make sure that we are all together, we are moving together. So these are things that we want to foster, we want to continue talking about. And I really want to take this opportunity and apologize very, very much that I have missed. But I know that you've been having great time. Thank you so much. I saw the attendance. I was watching on YouTube. I think the attendance has been great. And we just convey our condolences to the family of our midwife who died in an accident while she was coming to attend the function, the Safe Motherhood Conference. So allow me, as I conclude, I want to congratulate all of you. I want to congratulate our staff, right from the VHTs, the CHUs, the midwives, the doctors, the LMNS teams that have been religiously meeting, the other leaders like COW, RDCs, LC5, and other partners, especially the implementing partners and development partners that have been supporting us in this space of safe motherhood. Thank you so much. The guests that came from our neighboring countries, the guest speakers, we are very grateful. I've missed you because I was looking forward to meeting you. But we hope that God will keep us safe and we shall meet next year. God bless you, and we wish you the very, very best of the day. Thank you so much. Bye-bye.
Dr. Atwine, before you go off, I believe you've heard the Dr. Atwine, before you go off, I hope you have heard the applause from the audience.
Yes.
We all recognize the challenges that you face in being present with us in the last couple of days, but we are very grateful that you took a moment to speak to us and remind us of why we exist and the role that government is playing in ensuring that the population lives healthier lives and we achieve Vision 2040. Thank you very much, Dr. Atwine. The comments you have made, we've taken them at heart, and the conveners of the conference will ensure that through the year and when we return at next year in 2026, we will be able to respond to those issues that have been raised. Thank you. Allow me, members or audience, to close our session, recognizing that Dr. Atwine has spoken to critical issues that came up during the conversation. Given that we should be closing by 10:30, I will, on behalf of the panel and the keynote speaker, I'll ask Dr. Kitui to give us one commitment based on the keynote address that he made and what members, and the question that came up to us and the point of reflection as we frame PAC from the reproductive justice perspective. Dr. Kitui, briefly, please.
Thank you very much. Lillian and Dr. Diana online, we really appreciate those comments. I know our time is fast spent, so I'll be very brief, but I want to ride on what the PS has said. I think health services at facility level must make it easy for women to come. And so I think that's a critical, important, place for us to start. I think the other thing that I want to really take away as well is that the issue of why our women and girls are choosing to have unsafe abortions that makes them PAC necessary is a conversation that probably requires a deeper conversation. And I think that's probably an invitation for the ministry to convene stakeholders to have that conversations around, if you remember the diagram I showed, what are the upstream causes of these unsafe abortions, so then make PAC necessary so that as a society we can address them and deal with them. And I think as we do that, I just want to pose one question that all of us have to think is, I think we've talked about lived experiences a lot this week. And I think for me, as we design health systems, as we work with ministries of education, as we work with law enforcement, for example, one question we always have to keep ourselves asking is, what do women want in 2025? What does women want when it comes to reproductive justice, when it comes to security and safety? A lot of the unintended pregnancies arise from violence, from incest, from rape, from lack of skills to negotiate safe sex and everything else. I think as a society, we can't run away from that question. And I think it's a question of reproductive justice, asking what do women want? And then organizing services, not around any ideology per se, but around what really women want in this age and time. Thank you.
Thank you very much, Dr. Kitui Musoba, and thank you to the panel. Together, I want to reaffirm that today's dialogue has reaffirmed that post-abortion care is not just a clinical intervention, and I believe we all agree, but it remains a matter of dignity, equity, and justice. We've been reminded by Dr. Atwine, as she spoke, that as government, they recognize the burden of unsafe abortions. They further recognize that it's greatest among the adolescents and young women. But she has guided us to say that we must remain firm, consistent, and deliberate to manage the issue at hand as Ugandans, even as we adopt learnings from our neighboring countries of Kenya, Rwanda, or the East African community at large. She has also emphasized the fact that the framework that have been done, or we have already implemented, we must take integration and cross the T by having a full understanding of what integration means, and not simply scratch on the surface of what integration is. She has reminded us that it is multi-sectoral management, that we must go beyond Ministry of Health, we must have Ministry of Gender, we must have Ministry of Education, and we must have Ministry of Local Government, because that is the spaces in which we live. So as we close this session, we are all required to carry forward the urgency and clarity that this session has ignited. Let us commit to protecting the providers, the midwives, the nurses, the doctors must be protected because they too require justice. We must protect and empower communities because we know that TBAs who are still existing live within those communities, and even we must protect our minds as individuals because of what we believe and what we trust and define as urgency and power. We must also embed PAC within Uganda's safe motherhood agenda, not as an exception, but as an essential care. Allow me and join me to thank Dr. Kitui, our keynote address speaker, thank Sister Judith from Tororo Municipality or Hospital, thank Dr. JP Bagala, who's an organizer of this conference, but has been able to speak about government's perspective about PAC. Join me in thanking Dr. Lois, all the way from Kenya, who has spoken to us about what they're doing in management of PAC. And also Dr. Polifil, who is speaking from Rwanda's perspective in academia and the legal ambiguities. We believe that the recommendations that have been made, the insights provided, will all help us manage the unsafe abortion issue that stands before us, and we will be able to translate all these into action, accountability, and lasting change. I believe that together we can build a future where every woman and girl has access to safe, timely, respectful care, because reproductive justice is not an option, but it's fundamental. Thank you very much.
Please, let's take some photos. Please, let's take the photo. Yes, let's take the photo. Quick photo for this very powerful panel. Thank you very much indeed, colleagues. It's time for break tea. And tell me where to look. All right, so colleagues, let's go have some tea, all right? Let's go have some tea. 11:15, let's be back. 11:15, let's be back. And we shall be rolling into a very interesting session. A very, very interesting session which you don't want to miss even a single minute. Thank you.
turn it on. Janet, I want to turn it on. Even if Mama tulia. Rachel. Rachel, step forward.
they smoke cannabis. Doctor say make a pop one of this. Make me fly like say I'm Aladdin. Come bring some kind melodies. Oh, mama, myself no do pass like this. So many things inside of my jeans. I slide down the BTs.
All right, ladies and gentlemen, it's time for us to roll into our next session for the day. And please try to tell a colleague who is seated next to you, maybe still grabbing a coffee to hasten their footsteps so that we can start. I'm very sure Professor Peter Waiswa would want really to speak to a full room, isn't it, Prof? So as we get people in, Prof, we're going to roll. Don't be worried about the numbers. The scientific committee, let's get people in. Let's try to encourage people who are still outside to come in as we start. Thank you. So, colleagues, and Prof, we shall compensate your time. So, please make sure that you take the time you're supposed to take, 20 minutes. That's very fine. We shall get some time of lunch. So, colleagues, in this plenary session, we are going to have a very high-level presentation looking at Uganda's progress in reproductive maternal newborn, child, adolescent health, and immunization. And that is going to be presented to us by none other than Professor Peter Waiswa. A little bit about Professor Peter. Professor Peter is an associate professor at Makerere University, School of Public Health, College of Health Sciences, Uganda, and also a visiting researcher at the Karolinska Institute. He's the founder and coordinator of the in-depth network Maternal and Newborn Research Group in Accra, Ghana, and the Makerere University Maternal and Newborn Center of Excellency in Uganda. His research interests include health systems implementation research and evaluation with a special focus on maternal, newborn, and child health. He regularly engages in policy debates, advocacy, and planning at local, national, Africa, and global level. He is widely published in maternal, newborn, and child health and health systems. He sits on the WHO Advisory Board on Maternal, Newborn, Child, and Adolescent Health. Ladies and gentlemen, a round of applause to Professor Peter as he takes the podium to speak to us. You're most welcome indeed, Professor Peter.
Yeah, I'm trying to wait for the presentation. So in this presentation, I'm going to have a co-presenter, Mr. Waiswa Ronald. He's a statistician and a research fellow at the School of Public Health that I work with. So the purpose of this presentation is, really the main one is to show how we can use our routine data, all routine data, DHIS2, DHS, and any other routine data to actually have a good estimation of population coverage. And so this is what we shall be presenting. But globally, we have a group called the Countdown 2030. And the Countdown 2030 is coordinated by the African Population and Health Research Center, APHRC in Nairobi. And Makerere is one of the coordinating unit. And what we do we look at country data and see how well a country is progressing towards the Sustainable Development Goals. But we intentionally decided to use routine data without making surveys. So that's the main thing I wanted to say. And I work with a number of people. Some of them are in the room from Makere. There's Dr. Catherine Virabwa, just got her PhD a month ago. Rogers Nsubga, a research fellow. Leonard Waswa, who is here. Dr. Joanita Mutioba, who is our head of department for epidemiology and biostatistics, and Ms. Shava Magi. But we work very closely with the Ministry of Health, Dr. Mugahi, Mr. Jim Ogwar, Kasos Alan, and Albert Besje in immunization. And also, we collaborate with the GFF, Scott Francesca, I think she's around in the room, Dr. Grace Mlindwa, and Ronald Muhomza, who is from APHRC. The thing is not moving. Okay. So, really the main point is, especially now, you know that everybody is suffering from defunding. And even for many countries, surveys, like demographic surveys, we actually off the map, although they are trying to come back, but we don't know whether they'll be funded. Uganda is a bit ahead because it funded its last DHS. But when we have problems with funding, you have to get better solutions. And there is no better solution than the use of routine data to know what is going on. The routine data we have in the country is mostly DHIS2. And the DHIS2 in Uganda, but also DHIS2 in Uganda, but also in many countries, is improving. In fact, countries that we look at across Africa, Uganda currently has one of the best DHIS2 in terms of data quality. So you should clap for it in terms of data quality. So you should clap for it yourselves, Uganda as well.
We have a structured approach. Before we dig deeper into the analysis. So this aggregated monthly data, especially at district level, we perform quality assessments. And this includes checking for completeness in reporting, analyzing the consistency of the data, but also looking out for extreme outliers. So based on those three dimensions, we make relevant adjustments, and then we come up with a better data set. From that data set, we can now look at the raw reported values, depending on the indicator. From that, we are able to identify a better denominator that can give us estimates which are close to population level. So for service coverage, we know the numerator is always very straightforward, the population that has received the service. The most challenging problem is the denominator, where we look at the population that is actually in need of the service. In this case, which we call the target population. So, colleagues, allow me to take you a step-by-step assessment that we do for us to arrive to the correct or to a better denominator. So I'll give an example of DPT1 coverage if we want to look at the denominator, which is the number of infants who are eligible for DPT1, we move from left going to the right. So from the left, we have the number of pregnancies. And these pregnancies can be estimated from ANC attendance. We get a proxy, it's a proxy indicator, because we know ANC1 is almost universal. So from the number of pregnancy, if we remove the pregnancy losses, we can actually get the number of deliveries. But also we know that some deliveries result into multiple births. So we also do some adjustments based on the outcome of the births to come up with the total number of births. So from there, we remove stillbirths, and when we do that, we get the actual number of live births. So therefore, to get the number of infants who are eligible for DPT1, from the live births, we have to take off all the neonatal deaths. So if we want to go further to get the denominator that can be used to give us estimates for measles 1, we also have to take off the number of deaths that occur within the 1st to the 9th month. So that results. So we are seeing that generally completeness in reporting facility data has improved. And in the first row, we are seeing that by 2024, 97% of the facilities were actually reporting data directly to the DHIS2. But also, even when it comes to extreme outliers, the percentage of districts with extreme outliers has also improved. So by 2024, almost 90% of the districts had no extreme outliers. So generally, the overall annual data quality score for the data that is reported in the DHIS2 has improved from 2020 to 2024. So we also try to validate the findings we get from facility data with what we see in the surveys. And the surveys we compare with the UDHS, but also with the situation analysis for the newborn health. So this survey was conducted in 2023. So from facility data, the first bar, the blue, represents estimates from facility. The middle represents estimates from the UDHS, and then the green represents estimates from the CITAN. So we see that what we are getting from the facility data is almost close to what we are seeing from the surveys. So we go further to understand the trends. So using facility data, we can see that the population level ANC first trimester has increased by almost 7 percentage points from 2020 to 2024. But also we can visualize this and see the performance by region. These are population level estimates, but derived from facility data. For institutional delivery, it has also increased from 65% to 74% in 2024. And also we are seeing that we are seeing good performance in Ankole and Chigezi, but also even Bogisu and Bukedia. So we go further to illustrate the performance, the coverage of cesarean for the 2020 to 2024. So we are also seeing improvement, increase in cesarean section. By regional, we are seeing almost Kampala is the only region that is able to meet the WHO standards for cesarean section. So regions like Karamoja, Busoga are not really performing to the expectation. So we go further to understand the differences across regions. So this graph represents the inequalities in coverage. So each circle is a region. Across, that's the national estimate. So we are seeing that from 2020, the inequality in institutional delivery has narrowed. By 2024, almost all regions were had above. Some regions were able to achieve 100%. But also we are seeing there is a gap between the best performing and then the least performing region by almost 30 percentage points. Because we look at 60 and then the 90. So we go further to dig deeper into the child health. So for denominator still, here we illustrate Penta 3 and then measles. So the red line is the estimate from UDHS. Then each bar represents the coverage based on a particular denominator. So for the first graph on your left, we are seeing that Penta 1 gives us an estimate which is close to what we are seeing in the survey. Therefore, Penta 1 can be a better estimate for Penta 3. Same applies to measles. So we further try to understand the performance by region over time. So green indicates good performance. So when it comes to immunization, there has been progress across regions, with almost all regions having 80 and above coverage. The same story happens with measles. The population level coverage for measles 3 has also improved. We are seeing a lot of green. So that means that the country is doing a tremendous job when it comes to vaccination. So we can also further try to look at the inequalities. So much as all regions have achieved 80%, we are also seeing an increase in the gap between the best performing region and the least. So the inequality has somehow increased, and this is measured by what we call the median absolute deviation from the median. We abbreviate it as MADM. So it has increased from 6 to 7. So thank you very much. I want to invite Prof. Peter. Thank you.
So I think what we are trying to show you is that we can use our DHIS2 data as long as we improve it. If we do adjustment, we can have a good estimation of population level coverage and on a routine basis, even on a weekly basis. And there are so many other indicators we can measure. We just presented a few, just as an example, but we can measure all the maternal indicators, including actually mortality, Not really, we don't expect like within a 5% confidence interval like many scientists would want, but data that is relevant for program implementation. We can also do for child health in terms of birth weight, BCG, all the vaccines, but also mortality. We can also do on other indicators around system performance, like hospital performance, efficiency, all this capacity we have within our unit at the School of Public Health using routine data. So to conclude, is that really our purpose is to show you that routine data, if improved, is a very powerful tool for knowing what is happening in programs. I know that the ministry does measurement this routinely, but I think what we are bringing as added value is methods for adjusting so that you're able to get a population level estimate. And you can estimate district coverage, but also national coverage, but also you can do equity analysis on the data. We have this capacity at the school. We've been training our students, but also we would like to train district-level statisticians and to popularize this so that we are able to produce national reports. In fact, some years ago, we actually did evaluation of the sharpened plan using the same methodology. And I think it is the only major report we have for the sharpened plan. Thank you for listening to us. I think the ask is we don't have the resources to continue doing this. We would like support. And we thank the ministry and the GFF and the partners who've been working with us, including APHRC, in coordinating and doing this work. Maybe one critical result which Ronald presented, since I have Professor Nachimuli here, is really the C-section, since we are into a maternal conference, which is showing that if you want to reduce maternal neonatal deaths, emergency obstetric and newborn care must be available, but there are some regions that are really quite being left behind, and they should be prioritized. And if you prioritize them, you even be prioritizing my village, because Soga is one of those regions that is not doing well. Thank you so much.
Yes.
And as I said, we have some copies of the report, summary report, for about, I think, 100 participants. And those who want it, we can get it from the table.
Yes, thank you very much indeed, Professor. A round of applause, ladies and gentlemen, to Professor for that incredible presentation. In the interest of time, I would encourage for colleagues who might be having some, a bit of questions to the professor so that we can do the interactions during the lunch break. We will be now delving into our next critical session, and I'm very sure you will like it. We are going to look at triple elimination. And I would like to invite the moderator for this session, and who is none other than Dr. Linda Chisache. Dr. Linda Chisache. A little bit about Dr. Linda. Dr. Linda Chisache is a medical doctor, a public health specialist with over 15 years experience in working at different levels of the health sector. She has vast experience in supporting HIV programming, including HIV testing, care and treatment, and PMTCT. She previously supported scale-up of HTS services in private sector in Uganda and has worked as monitoring and evaluating officer for the HIV program at the Ministry of Health. She is presently coordinating the implementation of the PMTCT program at the Ministry of Health, Uganda. Ladies and gentlemen, our round of applause, Dr. Linda Chisache, as she takes the podium, take us through the next plenary session. You're most welcome indeed, Dr.
Thank you, JP. And thank you to all the organizers of this conference and those that have so far run us through the program since the beginning of the conference to where we are. We now move into a session on the elimination of vertical transmission of infections. And this comes just after the PS had spoken and told us how integration is how we have to move, and integrate we must. So the program for elimination of vertical infections is really integrated on the maternal and child health platform. And, all the implementation at the different level is really hinged on making sure that the maternal and child health platform is really working well. For babies to be born free of these infections, it's really critical, as we were reminded by the newborn team, that all the care starts by giving the quality and right care to the mother, ensuring that they attend antenatal care early so that they are able to be tested and they get all the services needed, ensuring that they continue to attend all the 8 antenatal care visits, ensuring safe delivery as well as proper postpartum care. Uganda is one of the 22 global plan countries which still show the highest burden of these infections, not only in the mothers and the adult population, but we still have the highest number of new infections, both for HIV, syphilis, hepatitis B, among children. Despite the many years of implementing PMTCT for HIV, new infections still remain above the 5% global elimination target. We also know that over 95% of chronic hepatitis infections result from people who get infections prenatally. And these are more likely to progress into complicated liver issues, including cirrhosis and hepatocellular carcinoma. Syphilis is a very old disease that has been around for many years. I think in Buganda, it actually used to be referred to as Oburwadde bwa Bazira. It is a very easy to manage infection, especially in pregnant women. However, despite the fact that we know what to do, we have not really done it the way we should be doing it. It results in really devastating effects for the newborn, including neonatal deaths, prematurity, low birth weight, and other congenital issues. At the recently concluded Triple Elimination Conference in Africa, participants re-emphasized the importance of integration, strengthening the maternal and child health platform for delivery of all services that are on that platform. We were challenged as Africa to promote research and innovation so that we have African-led solutions to our problems. We were also challenged to advocate for manufacturing and diagnostics and medicines on the continent so that we don't have to wait for logistics coming from outside Africa. A call to action was signed by the ministers that resolved to renew the efforts to ensure that we all achieve elimination of these 3 infections. This session, therefore, is hinged on all that. We have very expert panelists at all levels, from academia to programmers, to civil society, to the district leadership, and to facility leadership. The session is going to start with a keynote address that will be given by Dr. Dithan Chiraga, and I will invite Dithan to come up. Dithan is the Executive Director of the Baylor Foundation. He's a public health physician with over 20 years of experience in technical leadership and management of complex health programs in developing countries, including post-conflict nations. His leadership and expertise include quality of care service delivery, public-private partnership for health sector development, and development of standards for public and private sector. Dr. Dithan will take us through the journey of triple elimination as a country. Something probably that should have been spoken by Ministry of Health, but it's also good to step aside and listen to how other people are seeing the programming. This session was also sponsored by the Baylor team, and so we are very grateful to them. Our second panelist is Professor Philippa Musoke. Professor, you can also come up. She's an emeritus professor of pediatrics and child health at Makerere University and has been executive director and PI for the Makerere University and Johns Hopkins University research collaboration. She participated in most of the researches that actually led to the development of the WHO prevention of mother-to-child transmission guidelines. And her areas of interest include PMTCT, pediatric HIV, TB for remote limited settings. Our third panelist is Dr. Edward Bitarakwate, the country director for Elizabeth Glaser. Elizabeth Glaser was the very first partner for the prevention of mother-to-child transmission programming in Uganda, way many years ago. Dr. Edward has been the country programs and technical director for the Elizabeth Glaser Pediatric AIDS Foundation. He is a pediatrician and public health specialist with over 20 years of practice, both clinical and community, and holds a master's degree in public health. Our fourth panelist is Sister Patience Oburu, the acting ADHO of Tororo district. Sister Oburu has also works in the Actual Health Center and has recently taken up duties to manage as assistant DHO for Tororo. Our other panelist is Ms. Flavia Chomokama, the executive director of Nafofanu. Flavia is a gender equality activist and advocate. Flavia has lived with HIV since 1994 and is very, very passionate about women and girls' rights and ensuring that no more new infections happen in children. The last panelist is Sister Annette, coming from an implementer's angle. Sister Annette, you're welcome. So we shall immediately delve into the keynote address by Dr. Dithan. Dr. Dithan.
Thank you so much. Good afternoon, everyone. I had a slight panic over the break time. I was whispering to Professor Philippa Musoke when I wasn't seeing and she wasn't responding to my WhatsApp call, but I kind of got a bit of relief when I saw Professor Annette Nachimuli, and I knew she could have become a short notice substitute. But it's a pleasure joining everyone for this very critical session. First, I want to recognize and thank the organizers of this very, very successful conference for a job well done. So I'm going to share a few thoughts, highlights that will serve as the preamble for the panel discussion today. And I know it's the last day. Last days, people tend to be a little bit switched on and off. In many ways, you are speaking to half the audience, and the other half is also chatting with their drivers, making appointments for the departure. So hopefully we can keep this more interesting. Just sharing our own thoughts, observations as the Bella Foundation Uganda in terms of the journey. And I wasn't taken through this session of moving. Yes. A little brief about the Bella Foundation Uganda. We are proud and privileged to be a strong partner to the Ministry of Health to ensure that we deliver high-quality integrated services to the population in the country. And I remember Dr. Henry Mwebesa on the first day said that as Ugandans, we don't normally celebrate our successes. We tend to focus a lot on the gaps. But as the Bella Foundation Uganda, we are so proud of the great work that we've done over the last 20 years. If, for example, you visited some of the infrastructure that we've set up in many parts of the country, you'll be so impressed with the centers of excellence, the quality of the newborn facilities that we've put up in a number of district hospitals, health center force, most recently in Bolisa Hospital, Changwari, and Bwera Hospital. Really top-notch, highly functional centers that have been constructed. Also, we have a very comprehensive coverage across the country. Those that had rumors at the start of the year that we had been closed, I hate to disappoint you, we are still functional to a point where we've actually increased our coverage through the country. So we cover a lot of districts, working closely with the local governments, the districts, and we really appreciate the support and the successes that we continue to enjoy. We've actually taken up a few programs that were terminated as a result of the cuts in the US government funding in the country. Yes, in terms of the burden for HIV, syphilis, and hepatitis B, those three maps speak to the burden of these three diseases that really affect us, affect a lot of mothers, pregnant women, and just three critical observations from those three maps. We see that there are regional variations in the burden of the three diseases, which calls for targeted interventions to address the disparities. But also we notice that there's a synergistic impact for the three diseases, which leads to worsened health outcomes. We see increases in disease transmission, heightened risk for mother-to-child transmission, but critically, the similarity that we see for the critical interventions necessary to prevent transmission for the three infections does favor an integrated approach while addressing these critical diseases. Now, in terms of Uganda's triple elimination journey, we've had a lot of lessons we've had to learn as we developed policies, as we changed the policies, the regimens that we provided for the last over 20 years. If you remember those that were around starting as early as 96, where we had the Petra study that investigated the short course ARV regimens to prevent mother-to-child HIV-1 transmission. Those studies then led to other studies. They led to pilots. We evolved into the option A at 14 weeks. Later on, we adopted the option B in pregnancy. We had phased rollout of these different policies. Eventually, we had the HIV and syphilis dual assay that was evaluated, found to be highly sensitive and specific. That was then piloted in a number of sites. It's then adopted. Eventually, 2019 is where we had the Free to Shine triple elimination initiative that was launched. So we launched the hepatitis B virus PMTCD program at that time. In 2020, we launched the triple elimination plan. And then, obviously, 2022, we introduced hepatitis B birth dose that was added to routine immunization. So the process has involved a lot of science, has involved a lot of research, policy development, and it has also involved integrating different aspects of these programs, strengthening community approaches, so that we can move to the position that we are at this stage. When you look at, in terms of all ages, new HIV infection trends in Uganda, over the last, from 2010 to 2024, you look at all ages, you look at vertical transmission, and the percentage contribution of vertical transmission to new HIV infections in the country. Deeper data analysis, and that has been shared in the course of this meeting. We see that first, we have 4 regions that contribute close to 50% of new HIV infections, especially for the 0 to 4 years. And these have been mentioned as South Buganda, North Buganda, Toro, and the Kole regions. But in terms of districts, we know that Kampala and Wakiso have the highest burden for HIV within the country. But also when you critically analyze this data, we see a bit of stagnation of vertical transmission, which we think is attributable to the synergistic impact of the triple burden. And that calls for innovative, it calls for proactive efforts to eliminate these 3 diseases. In terms of HIV vertical transmission trends, if you look at mother-to-child transmission rate at 6 weeks, we see a good positive decline in the transmission rates from as high as 11.8% in 2010 to the current 2.3 rate at 6 weeks. But also when you look at final transmission rates, including the breastfeeding period, as well as the vertical transmission rates, we see a slow decline, and that speaks to a lot of the efforts, a lot of the support, and a lot of the investments that have been geared towards this work. Now, when you look at progress over the past decade in dual and triple elimination, when it comes to testing at ANC from 2016 to 2024, that graph shows you the trends. It shows you when testing for different diseases was introduced. The aim, of course, is to ensure that all the pregnant women who show up at ANC do receive timely and comprehensive testing services, including provider-initiated testing and counseling for HIV, for syphilis, as well as hepatitis B during the first trimester. But 2020 is when we really saw the introduction of hepatitis B virus testing at the majority of these ANC clinics. Previously, this service wasn't provided, and the trend has been going up, albeit maybe not optimally. Now, in terms of treatment, for the 3 infections at ANC, fairly similar trend. The idea is that we provide timely administration of appropriate treatment for the 3 diseases, for people having maternal syphilis, provide lifelong ARVs for pregnant and breastfeeding women living with HIV, as well as antiviral prophylaxis for pregnant women with hepatitis B virus. But still, you see 2020 is where we have the attempt to provide treatment at ANC for the 3 diseases with the introduction of hepatitis B treatment in 2020, starting at 21% of those that were tested and required that treatment, with a trend that is progressively also going up. A little bit on the policies and frameworks. We really appreciate the Ministry of Health that has developed a lot of these policies, the guidelines. The guidelines are really available. They are based on research, they are based on the learning, they are based on the science. We have a lot of job aids. And the critical thing for us, of course, is to translate a lot of these guidelines into actual practice. Then data science, yes, we've also used data science to inform a lot of the programming, and we've given different scenarios there where we looked at the PMTCT impact evaluation that was done in 2019, where we're able to look at mother-to-child transmission. We compared, for example, transmission rates between adolescent girls and young women, which we found to be much higher, those between 15 and 24 years, compared to 1.4% in the older age group. We compared transmission rates for those on ART and those not on ART, those suppressed, those not virally suppressed, those that attended ANC in first trimester compared to others in the third trimester. We looked at those on ART treatment, gender-based violence. We also looked at PMTC retention evaluation in 2020 that spoke to the most adopted interventions. For example, appointment tracking systems were highly adopted at 98%, birth cohort monitoring, but also that particular study examined the least adopted interventions. So we've used a lot of this data science to focus the resources, to focus the different interventions. I also wanted to speak to WHO's triple elimination framework. It is anchored on 3 strategic pillars. Pillar 1 looks at early ANC and continuity, gender-based violence, STI screening and management, male involvement. The second pillar looks at family planning, preconception care services. The third pillar looks at delivery under skilled care, labor management, protocols to reduce mother-to-child transmission. The fourth pillar is anchored on immunization, family health practices, as well as male involvement. And the goal is to achieve the elimination targets highlighted under each pillar. Call to action. As I conclude, I'll just read this verbatim. The first one, of course, is to ask the government to significantly increase frontline investments. We want to efficiently integrate healthcare service delivery, supply chain management systems, lab networks, and e-data systems across disease states, human resources for health absorption to Government of Uganda payroll. We want to fund the community extension workers model for integrated community-based services. We want to leverage laboratory capacity at lab hubs and point of care for integrated diagnostics. The second one, of course, is to government to significantly increase domestic and public financing for frontline investments. We want to leverage some of the resources available at district level, regional referral hospitals for HIV/AIDS, for example. If we can leverage a bit of that for triple elimination, mobilize additional resources through public-private partnerships. All together with Government of Uganda, renew our commitment to a generation free of HIV, syphilis, and hepatitis. Thank you all, and I want to hand over to the moderator.
Thank you very much, Dithan, for that presentation. You reminded us that we still have over 4,700 infections, new children coming out HIV positive. As we keep saying, the number seems a number until it affects you. I think that's a big number to be coming out every year after 25 years of HIV implementation. You showed us the regions which seem to have the highest burden, where more emphasis needs to be put. You also reminded us that adolescent girls and young women, which is something that has run almost throughout this conference. Almost everything that is not working well is adolescent girls and young women. They are the ones with the highest maternal mortality. Now they are the ones with the highest number of infections, and they are the ones whose children are also coming out with high number of new infections. You also reminded us about the presidential directive, the US presidential directive that came early this year, and how it shook not only Uganda, but all countries. We are very grateful that Baylor is still around and is still supporting implementation. And because of that, you also stressed the fact that the government of Uganda needs to step up and take charge of supporting programming across. So thank you, Distan. So our first panelist is going to be Professor Philippa, and we want to hear from you, looking at how triple elimination has evolved over time, even with the persistent challenges which have been spoken to, especially the health system challenges, staffing and logistics, and also the fact that infections are still there. And being with academia that has really shaped evidence-based programming and policy, what is your assessment of academia involvement in shaping policy and implementation, not only for triple elimination, but for safe motherhood as a whole? And how can this be optimized for us to be able to achieve all the targets that we've talked about since the beginning of this meeting?
Hello. Thank you very much, Dr. Linda. I want to thank the organizers for asking me to join this panel. And thank you, Dr. Chiraga, for the excellent overview about elimination of mother-to-child transmission. I think, as most of you know, in 2000, we had the great landmark clinical trial of HivNet 012. And 25 years later, unfortunately, we're still having mother-to-child transmission. So in terms of academia, in response to your question, I think academia has been really at the root of trying to understand how we can prevent mother-to-child transmission of HIV and also triple elimination, not only for HIV, but also other infections and other diseases. Academia comes up with ideas and says, what is the research question and how do we answer it in our population? So to just give an example, when we did the study HivNet 012, the West, or the US and France, had already done the study ACTG 076, and they were able to reduce mother-to-child transmission by 60%. But the intervention was not feasible for us in developing countries. So that's why the HivNet 012 study was done, because it was a single dose to the mother, single dose to the infant, mother at the onset of labor and delivery for the baby. And that intervention was feasible for the developing world. And as we saw, the whole world, the developing world, was able to implement that intervention. And WHO, it informed guidelines, national as well as international. So we've come a long way now. We do triple therapy, but that study is very important because it showed that you can actually conduct a study in a low-resource setting, a relevant study that can be implemented globally. And I think that's what we have to learn from academia. We have to identify our main challenges, which are many, and try to say which are the priorities. Uganda actually has research priorities. How do we as academia focus not on the West's decisions because of funding, but for us as Ugandans, academia, how do we ensure that we prioritize those issues, those challenges for our populations and the health of our mothers and our children? I also want to say that for those earlier researchers who were not involving the population, and now it's clear that the community needs to be involved right from the beginning, and that you need to ensure that they understand what the research is about and the benefit of the research. And so qualitative studies are now components of many of the clinical trials. So academia needs to also take that into account and say we're not just going to do our clinical trials, publish our papers, be promoted, but actually ensure that the community understands what we're doing and they can actually inform whether what we're doing will be scalable. And then lastly, because I know there are others, is that implementation science is a big thing now. We do clinical trials. They're great on paper. They're great in terms of publications, but the community is not able to be involved, and the Ministry of Health is not able to adapt. So we now need to, after our clinical trials, do implementation science so that we can actually implement the successful interventions, and see what's preventing them from happening. Why is it in this day and age we still have 4,000 babies infected with HIV? I think it's unacceptable in Uganda. We did the initial trials, we did subsequent trials with triple therapy, and we know what to do. So the question is, how do we partner with the Ministry of Health and academia and do implementation science? Those sites that are not doing well, how do we partner with them to learn from the sites that are doing so well, like Baylor? Thank you very much.
Thank you, Professor Philippa. I think reminds me of the recent paper that I think was saying something about scientists getting out of publication and providing us with more solutions. With all the issues that we've discussed in these 4 days, we hope to have more information from the scientists for implementation in the next 1 year. So for Dr. Edward, for a long time, PMTCT services have been hinged on development partner support, both at national level and implementation. And the partners have been really instrumental in the achievements that the country has registered so far. What lessons can be drawn from these partnerships? And with the current changes in funding landscape, how best can the country position itself for sustainability, public leadership and ownership of the program, as well as accountability to enable the country to reach the WHO validation targets?
Good. If the PS hadn't spoken earlier, I thought I was going to breach a controversial subject. But that said, I'd like to congratulate NASMEC for a very successful 3-day conference. And Dr. Linda for sitting me alongside my teacher. One of the things we've learned from the partnerships is that being part of a global community of practice brings good things to any society. The partnerships brought funding, but they also brought knowledge, brought new practices. The so-called north to south collaboration and transfer of knowledge that was quickly followed by south to south. And within that south to south, we also learned that peer learning amongst ourselves in the health space contributed to the successes Dr. Dithan showed. We've been able to, on the side of HIV, on the side of maternal and child health indicators, we've seen that we've been able to arrest and reverse the negative trends. And it says a lot to what we can do together. So the partnerships have helped us achieve. If you look at the foundational elements that have brought us here, they're not going to go away. They're with us. It just needs a strong resolve for us to sustain the gains, pun unintended, but to also run that last mile. We've heard over the last few days that all the low-hanging fruit has been picked. And I think the question is why? We know what to do. When I look at a room full of people, I know that there is a resolve to run that last mile, but we need to understand what we need to do in order to cover that. So I think for me, the partnerships have been very beneficial. When I look at a lot of the program leaders at the Ministry of Health now, a lot of them have grown through these partnerships, and you see it in the quality of our strategies, our policies, and the quality of debate. We've learned how to do granular data analysis, how to use epidemiologic data to target our interventions. We've also learned how to determine workforce needs. to know who is needed where because of disease burden. We've learned advanced programming. We've learned how to implement these programs that are not only life-saving, but also contribute to human capital development. We know what it costs from the financing that has led us to where we are. To a point that we now know that business management, even in the public sector, is critical if we are to achieve the desired health outcomes in our populations, and the role of leadership. So I think the partnerships from the global level have brought us to where we are. But, they also have their downsides. Partnerships can lead to a dependency. If someone helps you for too long, one may forget that the primary responsibility to continue is with us. We've seen that the partnerships at times can be contentious. They need to balance what the global partnerships require with what the country needs. We've seen that. But we also saw that partnerships at times can be very fast-paced. We learned how to implement programs at scale and very fast. Too fast for us to adopt. Uganda is good at innovating, but very slow at institutionalizing what we've learned. Was that because of a very fast pace? Do we need to shift gears with a reduction in funding? If one wants to gain momentum, at times one needs to shift a car's gear from gear number 5 to gear number 3 to gain momentum. We need to be realistic with what we can achieve, but determine what is pivotal. What are those things we must critically look at? We've had decades of millions of dollars going into health information, but we are struggling to digitize. Why? So I think there are critical questions we need to ask, but most fundamentally, we've seen what the global partnerships can bring. But what about our local partnerships? The Ministry of Health is responsible for policy, strategy, standards. But it only manages, I think, less than 90% of health service delivery in this country. Where is the Ministry of Local Government here? They should be here. Do we know that the Ministry of Local Government has up to 13 measures of performance in the health sector? But we don't even reflect them in our annual health sector performance review. The point I'm making is that we now need to learn from those global partnerships to strengthen our internal local partnerships. We've been talking about performance management. How are you going to manage the performance of a workforce you don't own, you don't lead? It's the Ministry of Local Government, not Ministry of Health. How are we going to manage leakage of commodities when from the center there's a district internal audit function under internal auditor general? The point I'm making is that for us to run the last mile, we need to look internally and optimize those internal stakeholders. Ministry of Education and Sports, Ministry of Gender, Labor and Social Development, Ministry of Finance, Planning and Economic Development. But we have a Ministry of ICT. We have NITA Uganda, we have the UCC, and we are struggling to digitize. So in a nutshell, I think what we've learned in partnering with the global community, we can take and strengthen and deepen our partnerships at the multi-sectoral level, and of course with our communities. We are thinking integration, but there's no better example of integration in the health sector like EMTCT and Triple Elimination did. We embedded it within sexual and reproductive health from the day one. Thank you very much.
Thank you very much, Edward. He's brought back the importance of the multi-sectoral collaboration and partnership, and also taking advantage of what we have locally in order to implement better. For Sister Patience, maternal and child health services have seen many innovations in the past few years. Dr. JP was just talking about the local maternity and neonatal systems, and these have really led to a lot of improvement in the indicators, as we saw from the presentation of Dr. Mugahi. So how do we tap into these for triple elimination, make sure that we ride along there, and make sure that we are also able to hit our targets? Additionally, what is the role of the districts in ensuring that not only triple elimination, but other infections in general are seen as a responsibility and owned by the district health team in implementation, so that we can be able to implement quality services and also ensure sustainability?
Thank you. As district local governments, we can tap into the integration of services like ANC and PNC care services, treatment and preventive services into the existing maternal and child health services, through HTS into routine outreaches, HTS incorporation into family planning outreaches. We can also empower district health teams through trainings, resource allocation for supervisions, and mentorship on peer-to-peer to bring on board the newly recruited health workers. As a district local government, we can also ensure commodity availability and security through empowering of the supply chain issues to prevent stockouts of diagnostics and commodities through redistribution within and outside the districts. Sustainability of financing amidst the dwindling donor funding can be addressed through private-public partnership and lobbying for additional funding and resources to support the triple elimination. Community engagement is yet another source to tap in from the different levels of community health workers, ranging from VHTs, community health workers, health assistants, to create awareness and demand generation at the local levels. Strengthening data system, data compilation, analysis, and utilization at the implementation levels to inform programming. We can also tap into accountability through the client satisfaction surveys, addressing the challenges of health workers and holding them accountable for their actions. There is yet a new program under MOH, the Self-Care Project, where the local governments can tap into the DMPA self-injection to improve the 4 prongs on prevention of unintended pregnancies, thereby improving the maternal outcomes. As district leaders, we can also do resource mobilization and tapping into the RDC's airtime for demand creation and awareness at the local levels. Task shifting can also be tapped in through the expansion of roles of health workers, ranging from VHTs, community health workers, and health inspectors, to create awareness on HIV, syphilis, and hepatitis B. As local governments, we can also lobby through the ministry to have at least a functional fridge at every administrative unit, increasing access to immunization services as seen on the prevention of vaccine-preventable diseases. A case in this, hepatitis B, ranging from the birth dose and the subsequent. Yes. As local governments, we can also tap into POC by clustering administrative units to the nearest point of care to access diagnostics and early diagnosis of HIV infection in the newborn. Prevention and treatment innovations like test and treat for HIV infection, single pill for HIV, and the other single pill for hepatitis B treatment on diagnosis. Timely hepatitis B birth dose vaccination and continued with subsequent doses. Over to you.
Thank you, Sister Patience. Key that she has said is making sure we look at the client satisfaction survey, get the actions in there, and also accountability by the local district, as well as resource mobilization. So for Sister Annette, earlier this year, we received the news of the stop work order from the United States President. And since then, Minister of Health has emphasized integration as the key modality to support continuity of services. We would like to hear from you as an implementer. How have you taken integration? What is happening at the facility level? What are the voices from the health workers and the patients as well?
Thank you very much, Doctor. By the names of Annette Kabanyaka, working with Kabarole District, attached to Chijura Health Center 3. And since the year started, when the year started and the government and our donor aid was cut off, we learned to work as a team. There was good cooperation and coordination between providers, which enabled us to continue offering the service. Also, the DHT and other leaders with some partners, it has also helped to continue offering the services to our clients because there has not been any stop of staff of offerings in service delivery. We've been having regular targeted review meetings whereby we do weekly data reviews, and for each facility, every week, each facility sends in their report, the EPMTCT report, whereby we see if there is any poor performance per week, we discuss the way forward and what to do as a team. That is being spearheaded by the ADHO, Kabarole District, which has worked. Because every week we present our data, We see where there are challenges and we come out with solutions. And since we are working as a team, with MCH, we are understaffed, but all providers and the facility, they are all knowledgeable in service provision. So we work together and mentor each other, and we've been able to continue offering services in an integrated way. Also, what I've also learned is on good leadership and planning. With good leadership, we've been able to ensure there is continuous service delivery even without the donor aid. Because for Kabale district, whenever they starts, facility in charges sit with their departmental heads to plan for the little PHC that we get, and each department is represented. We present indicators and activities that we need to perform in that specific year in order to achieve, and that has helped us to continue offering services whereby we do outreach services, we do home visits, we do in-reach services in health center tools where they have no midwives, to ensure that all our clients receive services at all corners of the community. We try to minimize missed opportunities, because in some, like in Kabarole district, in health center tools, there are no midwives, and sometimes the people offering services, they are not knowledgeable in PMTCT. At least the nearby health center 3 is in position to go to that health center 2 and offer a comprehensive care package to those clients. And in relation to integration of service, with MCH, we've been doing service integration. And whenever our clients come, we do offer a comprehensive care package. And that comprehensive care package includes the triple elimination of HIV, hepatitis, and syphilis, whereby all the services are being offered at the same entry point, that is MCH. We do the testing and the treatment at that same point. We even involve the male partners in order to totally eliminate transmission of mother to child of those diseases. And that has helped us to continuously keep the graph of elimination going down, because we've been able to even if when the donor aid pulled out, at least we've been continuing to provide the service, and there has not been a big decline in achieving targets.
Thank you, Sister Annette.
Then the client's response. For clients, of course, they do appreciate the services we are offering. I know most of the clients, when they come, more especially mothers, they expect to get a variety of service. They come with different needs, and we make sure that we've given all the services needed. And for example, those MCH services, we have antenatal, postnatal, family planning, delivery, high-risk mother identification, treatment, and referral. We've been able to offer that, and clients are appreciating. And what has the challenges clients have faced is on the long waiting time, because you find it is the same provider giving all the comprehensive care package at the same entry point. But we've tried to talk to our clients to be patient. As long as you've explained everything to the clients, these patients have been very patient with us, because they know they will not be moving, going back to home, then coming back to another clinic day, because we offer all services throughout the week. Whether the client comes on weekend or whenever, at any time the client walks in the facility, is able to receive whatever service they want. Though there is that long wait, because you have very many clients, and you have to do what? To look at each and every client. I think that's all for now. Thank you very much.
Thank you very much. She stresses use of data for planning and programming, teamwork, and leadership as a key driver of implementation. Thank you very much. And it's also good to hear that MCH has already been integrated, and so the rest of ministry can learn from the MCH platform on how to better implement integration of service delivery. So lastly, Flavia, the role of community and networks of people living with HIV has been documented over time, and their support to service delivery is undeniable. Community-led monitoring has been key in improving service quality for patients. In view of the funding challenges and the fact that these have mostly affected community, how do we avoid losing the gains in this era, and how do we implement community-led monitoring now when they choose, as we've had, is the mainstay of integrated community service delivery at ministry at the moment? What remains the role of the CSOs and networks of people with high risk of the triple diseases, and how do they position themselves now in this prevailing environment?
Thank you very much, Dr. Linda, for inviting me and the entire organizing committee. I am Flavia Chomkama once again, and I work for the National Forum of People Living with HIV. But what is very paramount for me to say now is that the entire workshop has been talking about them, and today I'm representing the them you've been talking about. And I would like to say that the them has not sunk very well in our vocabulary. The them have not really been appreciated and recognized as mutual partners in ensuring that we have better health and ensure that we attain the health outcomes, the maternal and child health outcomes for this country. And just to say that we continue to ask them to continue to request to be on this table whenever conferences like these ones happen. And so we would like to implore, before I speak for them and give my story, that we continue to appreciate that the them we are talking about are the ones who are appreciating and receiving those services we are delivering, that those policies you are developing are to ensure that the them are able to access services to ensure that we have better health targets and also improve the livelihoods and lives of people in Uganda. So I am Flavia Chomkama, and I live with HIV, tested 1994. And at that time, the Prevention of Mother-to-Child Transmission project I was one of those very first one who was on PMTCT-A at that time. And I delivered a baby who is now 30 years. I had previously delivered others who are now deceased. The first 3 are deceased. The set of twins in 89, another one of 94 is also deceased. By that time, we didn't know anything much about HIV. And it is after the one of 93 who passed on 94 that in 95 I was in Mulago and we enrolled on the PMTCT program. So what I'm driving at is that at that time, in 1995, and I think those are the results that Executive Director Baylor was talking about, are those results of 96 that showed efficacy in ensuring that mothers, if given prevention of mother-to-child transmission treatment, they would be able to deliver healthy babies, but also save the lives of the mothers. So that said, communities are very, very important, and I am one of those communities and the recipients of care in this country. And we would like to share with every one of us the challenge of the recent shrinking funding. And we are caught in the middle of the shrinking funds and the integration web. And how has this happened? As communities, our role is to ensure that we mobilize our peers to come and demand and utilize services. And the second bit we do is to do treatment literacy. And for us as people who have been through PMTCT or EMTCT programming, we do know how we have been able to manage, and we are able to encourage our fellows, our fellow mothers, through the mentor mothers, the mentor fathers, the YAPs. I think these are names you already know. And we also ensure that we provide psychosocial support, particularly for those who have a face to lose, for those who are still worried about disclosing whether it is the HIV, the hepatitis, or syphilis status to their partners or spouses. But we also ensure that where we have provided psychosocial support and the communities are willing to uptake the services, we hold them by the hands and we take them to the facility, or we make a call to the VHT, we make a call to the midwife, and we say, we have this person, even if it is at 1 a.m., we pick people by their voices, by their worries, we pick them by the challenges they are facing and link them to services. And so that said, we'd like to say that communities are doing a public health role, a public service role that is not paid for by government. That fortunately, the partner, the implementing partner, the donor, has shown this government and us that it is a very worthwhile community to work with to ensure that we attain the gains. So when we refer, we don't stop there. People are initiated into care. And we deliberately and passionately, because we've been there, we encourage continued adherence to treatment, not even treatment, continued seeking support, counseling, and other social services to ensure that we have healthy mothers and we deliver healthy babies. And therefore, as a community of people who are affected and vulnerable and also providing that kind of support, we have, over the years, generated support groups. And these support groups are in our communities. Over the years, we have been overwhelmed as families, as support groups, and the donor has provided investment to ensure that we do that role and enhance and lighten the work of the health facility. And we have done it diligently. But over the last few years, we realized that we are now, we were doing mapping for the Ministry of Health Community Department 2 weeks ago. And when we went to the districts, we found that all those who had money, and the money has been cut, and they had been coming from Kampala to the districts, have vanished. Who is there? Our systems and structures, if I can use the one of people living with HIV, they are still there. At the district, they are working without resources. At the sub-county, they are working without resources. At the facility, in the community, they continue to do this work without even being paid. Even when a number of them could not be taken on as VHT, as CHOOS, they continue to facilitate and support utilization of services. So we are there, we are on ground. We are the one most static community system that exists in Uganda that has stood 30 years, and we need to build onto it. And I always say, let us integrate and not disintegrate. Or rather, let us not disintegrate to integrate. We already have a structure or structures of communities that already are known to work. How do we ensure that we consistently utilize these structures to build and integrate whatever else we would like to have? Because we didn't want to find a place where they are saying we don't want people living with HIV in this system because we have closed the health facilities for HIV and TB, and therefore we need new people. No. Integration is saying work and strengthen the system. So I'm glad to say that with the community, with the Prevention of Mother-Child Transmission Department, Prevention Department, we have been working closely. And we have ensured that whenever there is an opportunity for training, Dr. Linda calls us to say, who do you have in that district? Who can be on the training program? Who can spread the word? And we have done this diligently. But also we need to realize that communities are the day and night watchmen and women of prevention of mother to child. So we will always say what is working. We will always say where there is stockouts. And for instance, a week ago, in Buyende, we have not had pediatric treatment, ARVs. So we liaise with ministries quickly, very fast, and we inform, and then they also liaise with the teams at the region to ensure that these are delivered. Right now, I have got a message from the north. There is talk out of third line, and I have already, in this room, connected with the Pharmacy Department of Ministry of Health, and I'm also going to liaise with JCRC to see, do you have the medication? Our structures are formidable, they are available, they are immobile, and they are here to stay. We are not refusing that the government cannot afford to meet our needs and our remuneration and allowances, but we continue to say that we are committed to continuously mobilize and ensure that the demand is there. Because for me, it's unacceptable that 30 years ago, I was on a project that was seen to be efficable, and we are still having 4,700 babies born to HIV. I delivered, my daughter is 27, my last born. She is HIV negative, but she's going to get HIV and deliver a baby. Why did I even belabor to be on that project? Why did we? But we shall continue to ask those questions, to highlight what is working, to highlight what is not working, with or without money. But we cannot do much unless we are facilitated. And that's why we are saying, in the current changes in the financing architecture for health, we are requesting and asking that the government takes on the role to facilitate community systems to do the work we've been doing where the donor has left. We shall continue to be on various committees. We have our own Lydia here, who is one of our chief whips in the civil society. She sits on the regional triple elimination committee. They continue to push the agenda there. We have Jackie Katana, who's on the World Bank Global Financing Facility. She's pushing for monies to come to communities so that we do our role to monitor, to share what is working and what's not working, to ensure that the community systems that are grappling like government is, because for us, this hastened integration, we don't blame it on government. It's because it was a crisis. If somebody says, I'm going away, what do we do? And I'll just end this with a story of the Ruero Triangle. When the guns were, when there was a lot of gunshots happening, a story is told of a mother who ran carrying something on the back thinking it is the child. When they reached the other end where there were no gunshots, they realized they had carried a dog. And so, of course, definitely the others who remained behind brought the baby, but in haste, we can always carry a dog and forget the baby. So we are saying, let us continue to be part of the integration framework on which we are. We are on the advisory committee, we are on task force, and we are partners in developing the programming. We are part of the mentorships, and our role is to continue to highlight the issue of human rights, the issue of preventing stockouts, the issue of stigma reduction and ensuring we provide person-centered services. we shall continue to say that the specs is small, that when I come to pick my medication, I'm not sick, I need to get my treatment and go, my refill and go, without lining up for the entire day. And we shall continue to document these stories so that we are able to use them and inform the integration processes, particularly the fact that we need to have more community engagement, because the facilities are there, the medicine is there, the doctors are there, even if they are limited. But what is going to help us attain our targets is to ensure that them you are talking about, us, are actually utilizing those services, and that the adolescent young girls and young women who are of reproductive age, who are a third newly infected last year, get the support to live longer, but also deliver HIV, syphilis, hepatitis-free children. I thank you.
Thank you so much, Flavia. We commit as Ministry of Health to make sure that when we run, we shall not forget the baby. We shall carry the baby along with the hoe. And we hear your cry, and we'll continue to engage you as much as possible. As we come to the end of the panel, I want to ask each of the panelists, from the discussion that we've had from the first day, when we talked about the mega improvements in the maternal health indicators, but with some still lagging behind, we have not yet achieved the targets for maternal mortality, and the biggest contribution is from adolescent girls and young women. We saw that postnatal care is still a challenge. Newborn care is also still a challenge, especially in the view of equipment. And now we've heard from the side of the infectious diseases that HIV is still a big burden. Syphilis, despite the fact that we know what to do, is also still a big burden. And the same thing with hepatitis B. Just one key takeaway to give to Ministry of Health, the organizers of the conference, that shouldn't be left out of the report as they compile. We shall start with Sister Annette and come, and then Dithan will, collate all that call to action and, give the final say for the session. One key takeaway, recommendation to Ministry of Health. I've not heard.
Thank you very much, Dr. Linda. I would like to request the Ministry of Health to look into the issue of funding. At least they should increase on the PHC fund, since we no longer have the donors to support in funding those EMTCT activities, so that we can continue conducting outreach, home visits, and in-reach services. And another thing, also, the ministry, we need to look at the issue of drug supply. Sometimes NMS supplies drugs with short expiry. For example, the last delivery, they brought Nevirapine syrup with remaining 1 month to expire. And I think there are some facilities right now with a stock out. They need to look into that. And on the issue of staffing, especially for MCH, we are understaffed. We need at least more recruitment of midwives to support in continuous provision of PMTCT services. Also, we've been working with VHTs and peers, like the peer mothers, the AGYW mentors. I would like if the government should continue supporting them. For those people, what I know, they need little motivation. And even with the cutoff of funds,
those people have been continuing offering services because those people were selected from the local setting. Up to now, they are still serving, but we need to retain them so that we continue offering services better for those people that have been helping us in following up clients and community level because they know all corners of the community. And these clients know them and they believe in them more than us. I wish if the government should also take up that and support the community health workers, like the peer mothers, the adolescent and young women mentors, the expert clients who have been supporting the facilities and the VHTs. Thank you very much.
Thank you, Sister Annette. The team tells me that Sister Annette has actually spoken to all their recommendations because she actually picked out more than one. We have quite a number of questions, but I don't think we have the time to speak to all of them. I think we, will answer them while we meet at lunchtime. But I'm going to ask Dr. Dithan to just wrap up our session, including, key takeaways from the session.
Thank you so much. First, to thank moderator Dr. Linda. I think she's done an excellent job, as well as the panelists. A lot has been said, but just to re-echo, there was a statement, a word that the PS repeated several times when she was speaking to us, when she said that we cannot go back. And I know she was making a lot of that reference to the TBAs, but it speaks to the great work that all of us have done over the last so many years, that amidst all these funding challenges, changing landscape, we cannot afford to go back. We have enough, we have the capacity, we have the science, we have the evidence, so we cannot afford to become complacent. We're on track for a number of these indicators to pretty much eradicate these diseases by 2030. So we cannot go back. For me, that's one of the critical messages. The second one and the last one is we also need to promote a lot of self-care. We are talking about decentralizing services further, which is a good thing, taking doctors, nurses, recruiting additional cadres, but also the population is rising at the same time. So we need to promote a lot of this self-care. We need to encourage the communities, the population to own their health. This week, we talked about this self-care, program, the app that was launched through which the population can access critical information, they can access referral information, they can call in to a provider if they need certain information. So we need to promote a lot of those innovations. Digitalization is also a critical one for us, and we need to embrace digitalization. Thank you so much.
Thank you so much to the panel. Please give them another round of applause. I want to hand over back to Dr. JP.
Ladies and gentlemen, another round of applause to that very, very wonderful panel. And I think at the end of the day, it's the learning that we go back with and how we apply that learning in our routine practice to cause change, so that when we come back again on the 21st to the 23rd of October 2026, we are reflecting and asking ourselves if what we discussed on the 22nd to 24th October 2025 has been implemented. It's a progressive journey, but from the energy I'm getting in the room, there is intention. And so we have to carry that intention forward. Now, allow me just to announce a few lost items. I have a driving license here for Emron Joseph, please. It will be very important you pick it from me. And there is it looks like a data bank, please. And I've been also told someone lost, please. These are very important items. You don't have to leave in this place. Now, it's time for lunch. And I think the one exciting thing is that, and I want to thank Dr. Linda, you've really saved us some good time. This is the only day where we've gone for lunch on time, but thank you. After lunch, we will have parallel sessions. And the first parallel session will be a Safe Motherhood Forum on sexual and gender-based violence. That will be in the Renzori Hall here. The second parallel session will be Beyond Teenage Pregnancy, a holistic approach to adolescent health. That will be led by Maristops Uganda. The first one will be led by AMREF. And the second one will be led by Maristops Uganda. And that will be in Acacia Hall. Then the third parallel session for the day is Harnessing Multisectoral Engagement, which will be led by World Vision. And that will be in Ebony Hall. And the fourth parallel session will be on Making Quality Antenatal Care a Reality. And that will be in Mahogany Hall, and that will be led by UNICEF. And the fifth parallel session will be on Tackling Infections and Emerging Threats, and that will be led by the Ministry of Health. And that will be the Assistant Commissioner, Dr. Michael Mwanga. Now, once we've completed our parallel sessions, we expect to end all the parallel sessions not later than 1640, so that we return and close the 3 days. It's been really an amazing 3 days. The closing ceremony will start at exactly 1640. So the moderators of the respective sessions make sure that by 1640 we are done, because we are going for lunch quite timely. Now, once we've finished the closing ceremony, which will run until about 1730, we shall have a 30 minutes break for people to have a final tour of the stalls. And we shall start our awards. Now, we had, over the years, we've received requests for members to attend the awards, and that request has been granted. So we shall have the awards here, and any person can come and witness the colleagues that have outperformed, all have contributed a little more than the rest of us. So that will start at exactly 6, and we shall be in this same hall. Our award ceremony will be in the same hall. So we shall convene here at exactly 6. We shall be rolling the awards ceremony. Now, after the awards ceremony, we have a small thank you, but it's basically representative. So we couldn't take everyone, but just representative. Of 300 of us, we will have a small thank you in the restaurant up there. 300, representative. So if you receive that small invitation to represent the rest at that small thank you, please, that will be going on in the restaurant up there. And without any further ado, allow me, before we break off, first, I want to appreciate the partners. They have been running on the screens, but I think it's very important as we draw towards the close. And we're going to re-echo this because we're in a very difficult year of the stop work order, but the partners got themselves together to ensure that we have over 1,000 people in this room. And I want to say thank you. I want to say thank you. Thank you, thank you, thank you. Our platinum sponsors, UNFPA, Save the Children, Baylor Uganda. Our gold sponsor, IPAS Africa Alliance, Elmer Philanthropies, AMREF. Our silver sponsors, Self-Care, Japaigo, Clinton Health Access Initiative, UNICEF, PSI, the Global Financing Facility of the World Bank, Maristops, and World Vision. Our bronze sponsors, Stanbic Bank, DKT, Living Goods, the Embassy of Denmark, Bank of Uganda, and Seed Global Health. And those that contributed, PATH, the Macquarie University Centre of Excellence for Maternal and Child Health, Pathfinder, the UK Foreign Commonwealth and Development Office, and NAMA Wellness. And then our exhibitors, WHO, SEHAD, Adara, Vitamin Angels, Faith for Family Health, VAYU, the Hatch Technologies, Sinapi, Mother to Mother, Reproductive Health Uganda, LifeNet International, Nakasero Hospital, Kachet Pharmaceuticals, Nico-san, without your incredible support, we wouldn't have been here, and they all deserve a round of applause, ladies and gentlemen. And now that we all know our next Safe Motherhood Conference, 21st to 23rd of October 2026, I'm sure the budgets would speak to that as well, isn't it, colleagues? Thank you very much indeed. Now, let's proceed for lunch. Please, Secretariat, let's open this door widely so that we don't have any challenge our delegates walking out. If you go through this door, you use these stairs. If you go through that door, you use the other staircase. I thank you very, very much indeed.
Every newborn deserves the best start to life. However, in Uganda, despite more births occurring in health facilities, many still don't survive past their first month of life. According to the Uganda Demographic and Health Survey, 22 newborns die every 1,000 live births. Each loss represents a family shattered, a system failing its most vulnerable citizens, and a reality we must confront. Despite national efforts, newborn deaths continue to account for nearly half of under 5 deaths in Uganda. To reduce the alarming rate of newborn deaths and improve care for 120,000 small and sick borns, a coalition of partnerships, namely Makerere University School of Public Health, Baylor Foundation Uganda, Adara Development Uganda, Zambia Hospital and Ministry of Health, with support from Elmer Philanthropies, launched the Uganda Newborn Program in 2022.
So the Uganda Newborn Program is work that building on a lot of work we've been doing over the last almost one and a half decades. The background is, as you know, we are just a few years to the end of the SDGs, or the Sustainable Development Goals. But the target is ambitious, and yet Uganda is not doing very well. We've improved a bit, but still lots to be done. The approach that we are taking builds on evidence we generated in Eastern Uganda with support of Elmer Philanthropies and others, which showed that one of the best ways to effectively scale up and do sustainable maternal newborn care is to use a regional approach. In the regional approach, you map all the facilities that are within the network, and you don't improve in one facility only, but you do improvement across the different facilities in the region. The idea is that if every facility is improved, then referral becomes easier, but also management of mothers and newborn within the network.
Under this program, huge strides have been made in 20 high-burden districts and 36 health facilities across Western, Kampala, and North Central regions of Uganda.
We've seen tremendous achievements. We've seen with these NICUs that have been constructed, with supporting the staff, with supporting the districts with the supplies, we've seen an increasing number of newborn admissions in the newborn care units. From the previous quarters, we've seen a large number of admissions, and actually, we've seen these babies survive. Over 90% of these babies that are admitted in the newborn care units, they have survived, and that's the goal of this project. We've seen an improvement of staff utilizing the data in the newborn care units, and we think with increased support, they would actually go a long way to improve the management and improve and reducing the mortality in the both regions, in Rwenzori and Bunyoro. We had around 60 mothers and babies who were transferred with very good outcomes. From the time of inception of this project, we've been carrying out mentorships for the staff that work in maternity and newborn care units. Those are the nurses and the doctors. And we've actually mentored these staff in the neuroresuscitation and emergency obstetrics, that is how to do cesarean section, how to manage preeclampsia, how to manage PPH, and we've seen knowledge of this stuff above 80%.
Yes, we have seen some improvement in the survival rates because the lowest birth weight we have managed in this facility. We have managed the 900 grams baby, and it survived. We followed up the baby and we got good outcome. The baby is okay and currently alive. The previous quarter, that is October, November, December, we had 69 admissions. Out of the 69 admissions in that quarter, we had one death, only one death.
We had been stagnant for almost 20 years at 27 deaths per 1,000 live births. But in 2022, the last situation analysis, we went to 22 per 1,000 live births.
In addition to revamping many newborn care units, the program has supported construction of newborn care units in Chegegwa, Bulisa, Masindi Hospital, and Changwali Health Center for, among others. Another innovation that has been scaled up through the program is the home-to-hospital model aimed at supporting mothers and their newborn babies after hospital discharge.
The hospital-to-home program is designed to help the high-risk infants in the hospital and after discharge home. The goal of the H2H program is to help them survive and thrive through follow-up. The mothers are visited on scheduled visits and at 6 months, and then at 9 and 12 months, these community health workers go back and visit these babies to identify the development.
It is yours. Please come and pick it. Henry. Could we start playing the videos as we wait for people in the room to make the numbers?
Every newborn deserves the best start to life. However, in Uganda, despite more births occurring in health facilities, many still don't survive past their first month of life. According to the Uganda Demographic and Health Survey, 22 newborns die every 1,000 live births. Each loss represents a family shattered, a system failing its most vulnerable citizens, and a reality we must confront. Despite national efforts, newborn deaths continue to account for nearly half of under 5 deaths in Uganda. To reduce the alarming rate of newborn deaths and improve care for 120,000 small and sick borns, a coalition of partnerships, namely Makerere University School of Public Health, Baylor Foundation Uganda, Adara Development Uganda, Zambia Hospital and Ministry of Health, with support from Elma Philanthropies, launched the Uganda Newborn Program in 2022.
Good afternoon. We would like to go towards beginning today's session. Unfortunately, we've lost 30 minutes. So I want to call all those who are seated in this room, but you are seated behind, to come in front so that we can start. I'd also like to request the conference organizers to try and drive the traffic so that we start, because this room also has pressure on it because of the closing ceremony that we anticipate. So kindly call your colleagues, just come and settle in so that we can start. There's just a few technology issues. Can we have this monitor on? Yeah, this central monitor, if it can get on, then we should be able to start. I would also like to request that perhaps we test some of the presentations that are there so that we can proceed with today's session. There's supposed to be some videos running. Could you kindly run those? Because we may not have a separate time slot to run them. And let's target to really start at 2:40 p.m. In order to catch the time that we have. So could we also, the IT team, could you also test this gadget, the prompter, so that we make sure it's working? So would really like to start at 2:40. The only thing that I haven't seen is testing the slides and with this prompter. So can we have that done?
Over the past 4 years, we have worked relentlessly to address sexual and reproductive health rights, SRHR, and as I reflect on the journey of Amref Health Africa's Heroes for Gender Transformative Action program, I am filled with pride and hope. Over the past 4 years, we have worked relentlessly to address sexual and reproductive health rights, SRHR, and sexual and gender-based violence, SGBV, in 9 high-burden districts across Uganda: Kalangala, Iganga, Namaingo, Bujiri, Budaka, Mbale, Mayuge, Kwen, and Bukwo. Back in 2019, the statistics were alarming. 1 in 4 girls aged 15 to 19 was either pregnant or had already given birth. Nearly 24% of girls were married before the age of 18. Access to SRHR services remained limited, leaving many young people vulnerable. Determined to make a difference, we launched a program guided by World Health Organization's best practices and health and human rights framework. Since then, we have reached over 500,000 young people with comprehensive sexuality education through structured curricula like Journeys Plus and Program Y. Beyond schools, we have engaged over 10,000 out-of-school youth through community dialogues and medical outreaches. But education alone, not enough. Strengthening health has been at the core of work. In partnership with 65 health facilities, we have trained 1,500 health workers on basic emergency obstetric care, BMOC, customer care, and inclusivity. Additionally, over 500 community leaders have been equipped with leadership and accountability skills to champion SRHR
thank
and
you.
gender equality.
So I'd like to take this opportunity to welcome all of you to this para session 1, which is concerning eliminating gender-based violence for safe motherhood. This afternoon, we are really tackling a very important matter that needs a multi-sectoral approach to address and making sure that it is tackled holistically. We have indeed a very good panel, and I'll be your moderator. I'm Dr. Patrick Agurusi. I'm the country manager for Amref Health Africa in Uganda. I want to take this opportunity to thank all of you for coming. As you may be aware, Sustainable Development Goal 5 aims at reducing gender inequality and empowering women, girls, and whole societies to have an essential foundation for a peaceful, inclusive, and sustainable development. The National Development Plan for itself, for Uganda, recognizes that gender equality and women's empowerment is central to accelerating socioeconomic transformation. And safe motherhood is really part and parcel of this whole agenda. So this afternoon, we have a very interesting panel that will try to expose the root causes, the solutions that we will work on together. The panel with you will have a deep conversation on how we need to address these challenges and how we need to work together. I'm also pleased that within this forum, we also have a top religious leader who will also give us perhaps the religious perspective. So without much ado, I would like to take the opportunity to invite our panelists to come and grace this function and also actually present on the different areas that we'll be discussing. First, on the podium, I'd like to invite Madame Juliana Lukuzi from UNFPA. Please come and take your seat right here. Second, I would like to invite Madame Judith Adokorach from the Netherlands Embassy in Uganda. I also would like to invite Madame Angela Nakafero, Commissioner for Gender and Women's Affairs at the Ministry of Gender and Labor Social Development. I would like to invite Dr. Irene Mwenyango, the Acting Commissioner for Adolescent Health at the Ministry of Health. Okay, as we wait for her, and Henry, please follow up. I would like to invite Ms. Fatia Kanyange. She's the Executive Director at SEHAD. I would like to invite Mr. Henry Semakula from the Ministry of Education. We are happy to have you. And I'd also like to invite Madame Harriet Nekesa, the Community Development Officer of Umbali. Please come and also join us to share with us those experiences. So the agenda for this afternoon is that we'll receive a keynote address from UNFPA, and then we shall go through several questions based on what we prepared to discuss these topics, and thereafter we shall have a panel discussion and conclude with engagement with you in the plenary. So you are very welcome, and it's now my singular honor to invite Madam Juliana to come and take the podium and give us the keynote address.
Oh, okay. Thank you, Patrick, our moderator, and good afternoon, ladies and gentlemen. I know that you're not loud enough. We've just eaten. Good afternoon, ladies and gentlemen. That is better. And as Patrick says, I'm Juliana from UNFPA. My role at UNFPA, they call me, I'm the team lead for sexual reproductive health. But the first title starts with what we call integrated sexual and reproductive health and rights. When you look at the issues of rights, that's where we now get to think about the whole issue of GBV. I know when it comes to gender-based violence, some of us who work in maternity ward, I think we just want to go there, see a pregnant woman deliver, we are happy. As a midwife, I've been just like most of us midwives. You go to the labor ward, you hardly think about the psychological component of the woman. This woman who is coming in labor ward, yes, she's looking healthy, but is she happy where she's coming from? Did she get pregnant because she wanted to get pregnant? So today we want to talk about the silent issue when it comes to women who are pregnant, the whole issue of gender-based violence. The first thing that we need to think about in SRHR, we want to teach our midwives, those doctors, those paramedics who are in the labor ward, that when you're looking at a woman, we need to go beyond the pregnancy. And we need to think, did this woman get pregnant because she wanted to get pregnant? So when it comes to gender-based violence, and just in setting the stage, I want to emphasize one thing, that behind every statistic is a woman, a family, and a future. And when it comes to safe motherhood, we must remember that it's both a public health and a human rights issue, and it's very imperative that we need to remember that. But what we need to also remember that every year, more than 1,500 Ugandan women and adolescent girls die from preventable maternal causes. Yet for many that pass through this motherhood, it doesn't usually begin with choice, but with violence. Some are pregnant because they were coerced. I know in our culture, we kind of debate that nobody can force anybody to have sexual intercourse, but it happens. So that we need to remember that some of the women that we have in our neighborhood, they came there because they were violated. They didn't want to get pregnant. So what we need to think about as healthcare providers, especially midwives, is, and also those in other sectors, that it's important that we need to strengthen the multi-sector collaboration and the mutual accountability that go beyond the health sector when we are dealing with pregnant women. So when a woman is safe, we need to remember that when a woman is safe, respected, and healthy, she gives birth not only to a child, but to hope. But in our setting, there are some women who experience safe motherhood after being violated. So the question we might ask yourself is, how can a woman experience safe motherhood when her autonomy, safety, and dignity are compromised long before she enters the maternity ward? For us, we're on the receiving end. We're receiving somebody who we think she got pregnant when she was happy. But we need to ask ourselves, this question, there are some women who comes there after they have been violated. So we want to talk about these issues today. And for some of us, maybe this concept might be new, but to most of us, it might not be new. When you talk about GBV, it's not only those who are physically hurt. There are some who come there because they are emotionally hurt, and some even economically abused. You can imagine a woman coming to a labor ward with nothing for the baby. You might think that they are poor, but some, they come there with nothing for the baby, not because they are poor, they can't afford. Somebody, a husband, a partner, let them go to the labor ward without giving them anything. They'll say, go and figure it out. It's your issue. Or they are too drunk, they want to use the money for alcohol, they can't provide for the family. That's economic abuse that the pregnant women feels. When it comes to safe motherhood, for us, we want to make sure that every pregnancy is wanted, every birth is safe, and every woman survives. It becomes a challenge for women to survive and for women to have safe birth when they have been violated. And what we want to talk about, and I'm glad looking at the panel here, we have Commissioner Angela from the gender. I was telling that Commissioner Angela, you're coming here on the last day. We have been talking about these issues. We wanted to talk about the multi-sectoral approach to safe motherhood because we want our colleagues from gender to also be with us. Then we're looking at our colleagues. It's unfortunate. I don't know if there's anybody from the justice system here. There's nobody from the justice system because when it comes to safe motherhood, issues of GBV, our colleagues from gender justice system, they ought to be here. Local government sectors, education is here, so we are happy we have all these people who are here. Because what is important is that safe motherhood demands that the health system, the justice system, and the education system, the gender system, we move in a lockstep. When all these work together, the prevention, the protection, and empowerment of a woman really flows naturally, and you can really have a woman that delivers a baby who is happy, and also a mother who is happy, and they can also grow healthy. Moving forward, I just want to highlight the price of inaction when it comes to issues of GBV. Inaction is not just unjust, it is unaffordable. I want to highlight the numbers that we use. 56% of Ugandan women have faced physical or sexual violence. This is a lot. Most of them are not documented, unfortunately. And this is another issue that we need to think about. And because they are not documented, those of us in the labor ward who are the receiving end of a pregnant woman, we never think that some of the women who came there are coming after being violated, or physically or otherwise. 25% of girls are pregnant before age 19. Yes, some of them might be consensual, but some of them, they have been coerced in the process. And this is the gender-based violence that we are talking about. 31 trillion Uganda shillings is lost annually due to GBV and its ripple effects. The ripple effects, you might have some women who go into postpartum depression. Depression requires medications. When you look at the stock status of the Ministry of Health, you see that medications, when it comes to, to manage mental health, they are not always there. And people have to go to the grocery to find them. Some, they stay at home without going to work. These are the effects that we are looking at. And we talk about 189 maternal deaths, women that die during childbirth. Our target, we talked about it the first day, our target is 70. But just to mention that some of these women die because they were violated. Can you imagine you want to go and deliver, somebody is telling you, there's no money, I have no money, yet he was drunk yesterday, and they were not able to provide for the women. As a result, the woman delays to go to the facility, she has no money to get transport. These are the women that we are losing, these are dying. It's very expensive. And their lost resources could build 1,000 maternity wards, train 2,000 midwives that we are looking for, and supply 10 million contraceptives. So we are just saying, because of the cost of inaction, we are losing so much money. And these are the issues that we want to look at it. And behind this, you can see that GBV is one of the causes. I just want to share that, this socio-ecological model that shows that everyone has a role to play when it comes to issues of GBV. GBV is not caused by gender-based violence, it's not caused by an individual alone. It's reinforced by institutions, by communities, by systems that tolerate inequality. I want to start with the individual. If we can't empower a woman, girls, giving them education, giving them the knowledge, giving them the economic empowerment, these women will be disempowered. That's why sometimes you find a 16-year-old getting pregnant. That's violence. This is a minor. And the cost of inaction is what we see in our communities. So GBV will be caused by those people who did not allow this individual to get the right education. You look at the whole issue of institutions. There are so many institutions. We have talked about the education sector. We are looking at the justice system. When they hear that a woman had problems, we didn't go there early. We end up contributing to this. We are looking at the budgets where we didn't put adequate resources to educate the girl child, to give the right information, even the right information to the health sector. These are the issues that contribute to this ecosystem that causes GBV. Then you're also looking at our society. There are so many things that we look at, which really we must make sure that as a system, as a household, as communities, we need to be able to talk about the issues that are happening around us. Sometimes we put a blind eye because it's not us who are causing it. So eliminating GBV, it really requires across layers of the social system, from empowering individuals to enforcing national accountability. If we can't do that, we'll see so many ripple effects that are happening in our community. Moving on, I want to look at the multi-sector collaboration that there is one vision, but with many systems. When you look at the health sector, for example, you look at the quality of care. As midwives, sometimes as doctors, we are not trained about issues of GBV, how to spot it, how to give, even to give for prevention, to give advice to pregnant women that because you're pregnant, you might face this. Youth-friendly health services that tell the young girl how to identify when they are in trouble. So within the health sector, one of the things that we want is to make sure that we integrate our services. GBV screening and survival center must be there in our antenatal clinic, in postnatal clinic, and even in maternity wards. It's not only for those who are in maternity wards. Let's start it in antenatal care. Imagine somebody getting pregnant this year, 2025, 2026, they're there, 2027. It should be an alarm. Are you getting pregnant because you want to, or somebody is forcing you into the situation? Very important, and we need to look into this. We are looking at the whole issue of justice and governance system, accountability and law. We must enforce GBV and child marriage laws. We don't want 16-year-olds to get pregnant. Let's spread the message. We have had programs talking about it. It's very important that we continue about these issues. In our systems, the gender programs shouldn't just talk about it at central level. Are we talking about these issues at district level, at sub-regional level? Even in the PDM level, we have community health workers, VHTs. Do they have this knowledge? The education system, let's empower that girl child. Let's prevent girls, let's keep girls in school so that, we also strengthen sexuality education. I know it's a tricky issue to talk about sexuality education, but it's very important. Let's address school-related issues. Safe motherhood is not the work of the health sector alone. Everyone must come in the system, the justice, education, to make sure that we talk about these levels. If all these three levels are talking about it, the women can survive, the families will thrive, and communities will prosper. Collaboration is very important, and collaboration without accountability is charity, and collaboration collaboration is transformation. So let's be transformational in the process of addressing GBV, especially when it comes to safe motherhood. When all is said and done, we'll see that there's no single ministry that can end GBV. That's why we're talking about collaboration. Let's build on the national GBV policies, the strategies that are there, the path platform, so that we plan together, budget together, accountability. The NPD4 has already set the stage there, so that the social sector is talking together to make sure that we address all these issues. Your success is linked to her survival. Then how do we move from here if we want safe motherhood and we build on safe systems? Let's invest in prevention. Let's reframe safe motherhood as a national development goal, not a health target, and make sure we empower the frontline workers, the midwives, the VHTs, to make sure they are all champions in safe motherhood. I've seen the clergy here, which is very good. The community is here. Let's all talk about it so that when it talks about safe motherhood, we shouldn't just look at a woman should be pregnant and be healthy. Are they happy? Did they really want to get pregnant? And also, let's use data to drive budgets and accountabilities. Maybe the finance minister might be saying GBV is not important. Can we use data that will show them why we are spending so much on 16-year-olds with complications, so much with women who get to be violated? Let's measure what matters and add GBV indicators in our maternal death dashboard. It will be very important, otherwise we'll lose it. Also ensure domestic financing to progress, to make sure that we make progress whenever we're reaching out to our partners. Finance it smartly. Domestic financing, let's not just wait for the donors. I know we have our donor here. The donors can give us, but just up to a certain point. As a country, let's make sure that it's there within our system. If we do that, we'll end up having every pregnancy which is wanted, every childbirth will be safe, and there will be no GBV. And at UNFPA, we talk about 3 zeros. We can do that if we all work together. And as I end, I want to just highlight a few areas where, as UNFPA, we have worked to make sure that we integrate GBV with SRHR, with safe motherhood. We are running in Busoga region a project on Together for SRH, where we have integrated SRH, GBV, and HIV services. The Ministry of Health is talking about integration. We don't want to go in silos, but go together so that you have a midwife that knows about HIV, that knows about family planning, youth, all those things. I know we are complaining our health service providers that we are bombarded, but let's be intentional. Let's have all this knowledge so that when you are meeting somebody, all those aspects need to be included. I also know that we have a project in the same Busoga region on where we're empowering youth to prevent violence. And one thing that we have learned working with CARE is to put in a component of economic empowerment. Because the women who are not empowered, who are not economically empowered, it's really difficult to say no and to really take, to be empowered and to say no and to get the right services. And also the support on data system, it's very important. If you don't have data, you can't convince anybody what you're doing. And I'm just showing you what the Ministry of Youth, the Ministry of Gender, Ministry of Health, they have various documents that they are using, which are key national and sector documents that we must be aware of. What I'm talking about, it's there. There are guidelines, there are frameworks, they have been launched. We are supposed to be using them. If you're not using them as a frontline worker, please find out where you can have the health sector gender mainstreaming strategy, where the national gender policy is, where the integration framework is, where all these frameworks are. You need to have them. Demand for a one slide, which you can use for you to understand how you integrate the services. If we do this, we can have safe motherhood. We are going to have women who are healthy, with healthy pregnancy, healthy children, and we can have a healthy nation, because it's only these women who are healthy who can help in making Uganda a better place to live. Thank you very much. Oh, is this yours?
Thank you so much, Juliana, really for setting the scene. And you made very interesting remarks about everybody having a role to play, and that's the socio-ecological model. You also looked at the cost of inaction, where when we fail to act, what actually happens. These are the deaths and the unwanted pregnancies that we see. We also talked about the missed opportunities that we should have had to intervene, and we are missing them everywhere in our system. And so we need to be able to respond and utilize those opportunities. Of course, collaboration and accountability, as well as investment, so that we can have every pregnancy wanted and every pregnancy healthy and with a better outcome. So thank you so much for setting that scene, and that is leading us into now the plenary session. I want to start with you, Madam Nekesa, to paint for us a picture. There's a 9-year-old girl happy in a primary school somewhere in Mbale, where you come from. What are those things that are likely to make her have an unsafe pregnancy when she grows up into womanhood? Could you paint for us that picture?
Thank you so much. Nekesa Harriet is my name, and I'm born and raised in Mbale district. When we talk of Mbale, for those who have been there, Mbale is so beautiful.
No, it's okay.
But there are also other unbeautiful things in Mbale. I don't want to hide my head in the sand and not talk about them, but I will talk about them to bring out the picture. But before I do that, I appreciate the organizers. I thank God that I'm here. Actually, I'm happy, I'm humbled that I'm in front of you and sitting here with my commissioner. I feel big, I feel excited, I feel humbled. I don't know how to explain it. I thank God for that, and I thank God for Heroes program that has held my hand and moved with me all along. Thank you so much. Mbale is characterized by its hilly. The terrain is hilly, in that even if they have made the roads, most of the times, the roads, when it rains so heavily, you discover that the roads have blocked. Like a young girl has gone to school, or we have gone to the field, and when we are returning, you discover that the blocks or stones have rolled on the roads, and you cannot access the other side of the road. You have heard of floods, to mention but a few. Those are some of the natural challenges we have in Mbale. So I want you to imagine that picture for that girl at school. The challenges we have talked about add on those natural calamities in Mbale. I'll start by talking about my experience. Yes, the question says a girl at school, but I was once a girl at school and young in Mbale, in rural Mbale. I got married in the year 2006. I pray that my video may be played to show what I'm talking about and what it means to be abused or violated, so that we relate gender-based violence to safe motherhood. I request that my video may be played. I got married in 2006 at a very early age, and I was very excited because I had got Mr. Charming. I thought I had got it all. I had a job. I had just gotten a job. I had education. I had just graduated from Makerere University from Mbale, and now you've graduated from Makerere University. And here I was getting wedded to a young man at an early age. I was very excited. But the excitement did not take so long. It didn't take so long because I was abused during courtship, while in marriage, and because community, because our norms, because our culture had taught us or had taught me that when you get married, you stay there and you be strong. You stay there, you cling on. I had to wait. I had seen my mother. She's still married to my father. So I wanted to be like her and so many others. And who knows, at the back of my mind, I also thought it's normal. I was abused emotionally. Sometimes when we talk of the 50%, we think that it happens to the rural woman. I was educated, I was from a good family, and I was a CDO who had to advocate for other women. But here I was being abused. I was abused emotionally, called all sorts of names. I was not supposed to have friends because my husband by then, whichever girlfriend I would get, he would fall in love with that one. So I just hated myself and also hated the friends. I was alone. And actually, emotional pain was too painful compared to the other pains that I've experienced, because emotional pain, you go through it alone. Economically, my ATM was controlled by my husband. I thought, back in my mind, I thought, if I give him this ATM, maybe he will respect me or love me more. So I gave him my ATM and he would control my money and make all the decisions in the home. I thought I would be a good wife, but instead I was labeled as the worst wife. Sexually, I was denied conjugal rights. Most of the times you tell me I've had it all with my friends. I have had it all with people who are better than you. And I was just there. No attachment, no what. He labeled me as you're too dry, you're stressed, you don't have money, your man has been controlled by another person, you're going through too much. And during sex, someone expects you to perform 100%. So I was labeled as a dry pan. Physically, that's what you're seeing. All forms of physical violence, I saw them. I experienced it. And not only alone when I talk of physical violence, also with my children. I have one of my children here. They know my story and I talk about it freely. I have prepared them to hear it because if I don't, I know they can hear it through social media. I have my daughter here who one time was beaten with a belt. So the violence did not only happen to me, but also happened to our children, together with my children. I was beaten, pushed, kicked so many times, to the extent that I thought that I'd lost my uterus one time. I suffered from endless UTIs. UTI after UTI, I don't know, I suffered from UTIs. I thank God it ended at UTIs. I almost lost my mind while I was still in that marriage. How does this connect to what the moderator talked about? There is a very strong relationship between GBV, or domestic violence, that the one I'm talking about, and safe motherhood. One, if me, a mother, I'm tortured, if me, a mother, I'm going through the pain I'm always in tears, I'll not have time for my children. I would definitely not pay attention to my children. No, it's not possible. It's not. Most of the times we become so rude to our children. Most of the times we deny our children so many things. The society around us isolates these children. I remember one time, one of my child was contesting for becoming a leader in school. And they told this child that, how can you become a leader when your father cut your mother? For you can't represent us. So some people's character is that selfish, and it affects us. And when it's affecting us, we are not going to advise our children on reproductive health. We are not going to advise our children on menstruation. We are not going to play our role as mothers. But what about the children who are seeing it, who are facing it? It pushes them out. These are push factors. Children go out, they look for love because you're not providing them with an enabling environment. So a child will look for love elsewhere. And this child is so young and is looking for love elsewhere, will end up getting unwanted pregnancy. Remember, we are saying a woman should get a child at the right age and the right time, and when the person is ready to have that child. But because of domestic violence, the child can go and look for love elsewhere. The people around me, some of the issues we experienced as a family, they took care. Most of my family members were taking care of me, and at the result, our family income was so low, and moreover, I had to pay so much. Like you seen, all my bones were shattered. I have metals in my hands and even my bone. So it was so expensive, of which my mother, my father, my brother, everybody was around me. I literally could not do anything for myself for 1 year, but I was hospitalized for 2 years in Kumi Hospital, Onino, and I appreciate Kumi Hospital and all the doctors who worked on me.
Sorry, I'll have to come in here because of the challenge of time.
Sorry?
I'll have to come in here because of the challenge of time. But we thank you for sharing your personal experience and really the role of inaction by the family. Maybe could you just in a minute just say what do you think should be done differently so that young girls are really well prepared, protected, so that they can have a safe motherhood? Just in a minute, please.
Okay. There are several interventions, but above all, the overall one is you need to do something. I need to do something. Let's stop the blame. Because when we look at living my experience, when you look at this primary child, there are so many perceptions, negative perceptions around this primary girl. So we need to do something. If you're a CDO, talk to the community, create community awareness. If you're in health, stop the rude language. Because most of the times our children, our girls complain that when we go there, they treat us harshly. They ask us questions which are not good. Why did you do it? When they're examining us, there is this question which they normally ask, why are you fearing? Why the other thing entered you? Why do you fear my hand? So asking a child such questions makes this girl who is pregnant go away. So we need capacity building for the nurses, not only to do with skills, not only to do with the technical issues, but also these skills of attitude. We need to deal with people's character and attitude. We also need to empower the community, empower the women, empower the girls. I thank God that with Ministry of Gender, we have WEP, YLOP, PWD. There are grants that support women, but we need those specific grants for this girl who has gotten pregnant at an early age, so that the competition reduces. Because when you talk of WEP, any woman can qualify. But if we have a grant for only those girls who have gotten pregnant at an early age, then we can really support them and to also support their children.
Okay, thank you very much, Madam Nekesa, for sharing your personal story. It's a really very difficult one, but we're also grateful that you are here. And yes, let's applaud her for being very brave. So I'll now come to you, Mr. Semakula. Mr. Semakula, when girls grow up, they go to school, and as Minister of Education, you are responsible for shaping the knowledge, the attitudes, and behaviors of individuals as we grow into adulthood. So could you kindly tell us where do you see this missing? Because when we grow up and become adults, we become violent, we create unsafe motherhood. So what do you see that your ministry could do to really improve on this situation? Because this is the vehicle that we have that is supposed to change attitudes, behaviors, and indeed shape our culture as a people. Over to you, Mr. Semakula.
Thank you very much. Ladies and gentlemen, good afternoon. You all must have heard that the question was a mouthful. The answer must similarly be a mouthful. But before I get into the answers she has actually asked me to give, just a brief mention of what I heard from the keynote speech. The keynote speaker mentioned that many times women go to the maternity ward and then they are castigated by the midwives and they are not treated well. The treatment is even more annoying and more sad when it comes to young people. We have had young people who have been in school and gotten pregnant and gotten to the level of going to the hospital, and the treatment they get there is so bad. But I just want to highlight one of the reasons why those girls must really be listened to properly. Many times, of course, they didn't like the rape. They didn't like the pregnancy. It is also possible that it came from rape. And of all rapists, the rapist could even be an uncle, or even a father, or even a boyfriend. Now, when you begin just castigating like that, accusing the girl of being in the wrong, you are actually causing more trouble to her. And this young girl may not have simply gotten pregnant, but she would also have gotten an infection. Beyond the infection, she would have been pushed out of school. It is only until late that the Ministry of Education is coming up with a guideline of re-entry into school. But in the past, the unwritten norm has been that wherever the school identifies a pregnant girl, the penalty is going home. Yes, it may include home even these days, but she may go home with hope that she can come back sometime. But it is also true that when she became pregnant and she was forced out of school, she went into a very hostile community. You know how communities label these young mothers. They'll call them all sorts of names. They begin referring to their home as the home of spoiled children, the home of parents who don't care. They begin referring to the girl as the sinner, the evil one. We've even had religious leaders do the same, taking these girls that have gotten pregnant at some early level as actually outcasts. It is also true and very likely that even when this girl returned to school and the rest of the colleagues learned that she was pregnant, they also ridiculed her. They give them all sorts of names. You are not a Nalongo, but they call you a Nalongo just to annoy you. They call you Mama Prosi, all sorts of funny names they can. They call you an outlayer. They call you Jaja. Now, all these are challenges this girl could be going through. So it is not really good that when they come to the hospital now to get that service, they are again castigated. As an educationist, I also want to confirm from the speech of the keynote speaker that indeed education is very important when it comes to matters of safe motherhood. We know that these children, these girls are young today, but we keep calling them the leaders of tomorrow. They are not only going to be leaders, but they'll also be mothers of tomorrow. They'll also be fathers of tomorrow. So for us in education, we're interested in giving them the information that will make them good fathers and good mothers, although we have to give it to them in a dose that is appropriate. You will not find us teaching nursery kids about menstruation. You will not find us teaching P2 students about courtship. We only do it according to age appropriateness. The speaker was also keen to say that it is tricky to talk about sexuality education. Just to assure her that there's no problem, as long as you use the right name for it. The challenge we've had in the country here is that when we embrace this type of education, it came with a very powerful name that confused many people. Actually, at the Ministry of Education, we refused to accept the name comprehensive, and we simply moved on to accept sexuality education. Even then, we learned that there are people who are not friendly with that name. So we actually made efforts to begin reviewing the framework to rename, but also to think of the new content that should come in that package. So no worries, the ministry embraces any information that supports young people as far as their growth and development is concerned. We are actually reviewing the framework led by the Honorable Minister of Education and Mama She is leading the review together with the Minister of Health, together with the Minister of Gender and their permanent secretaries, together with the Minister of Ethics, but also very closely related to the Interreligious Council. You realize that majority of our schools in this country are actually founded by the church or the Muslim leadership, and so for whatever we do, we consult them. And finally, coming from the presentation is the issue of, no, I think this one has come from my sister here. She was saying Mbale is a place of calamities, and indeed that made me remember that while the girls in Mbale may suffer from the landslides and others, even other young Ugandan girls are suffering from many other physical challenges where they are. We've had, for example, floods in Kasese. They led to closure of schools. Sometimes students were forced into a lockdown again, even beyond the COVID lockdown. Many of them were girls, and when they go home, you know what follows when they are not in school. So we've had girls in Kasese experience that. We've seen the Ebola experience, the Mpox and all that. So it is true that where there are calamities, children are affected, but the girls are even affected more because when they get home, there is normally trouble. As a ministry, we have embraced the idea of allowing teenage mothers to return to school. But that has also not been well received in some circles. There are people who think we have actually spoiled them, that we are going to spoil other girls as well. But for us, we believe that an educated woman actually leads to an educated community. We also believe that when a girl is not educated, you are pushing her direct into the cycle of poverty. Because then when she starts without a job, with a husband who has run away because he fears to be imprisoned, then which type of world are you sending her in? Now, very quickly to the question. I don't even remember the question, but at least I remember the answers that I prepared. Answer number one, as Minister of Education, we see the challenge of gender-based violence. What are we doing about it? We know that gender-based violence starts at many levels. And in many cases in Africa here, it even begins from the home. So we have left what to do in the home to the Minister of Gender. And for us, we are more interested in what to do at school. So at school, we have put up senior women teachers, we have put up senior men teachers, we have put up counselors. We have tried to ensure that we retrain the teachers who still think in terms of caning and knocking the head and sending children to go for water, to the fact that there are alternatives to corporal punishment, which are even better ways of disciplining than using violence. When you talk to the child, when you call the parent, when you demote the child from being a prefect to becoming a commoner, when you deny them a simple privilege like going to play at break time, that could be good enough to put them back their senses than hitting their heads, than caning them, and so on and so forth. Working with UNICEF, we even came up with a full booklet that can guide these teachers on those possible alternatives. And we have also often cautioned the teachers. The violence you display to the children may also get back to you. I have personally seen children waking up to box the teacher to the complete shame of the teacher. You have been using the cane, the child gets exhausted. I hope you people know what happens when you chase a rat and it fails to get where to run to. What does it do? It jumps on you. So we've seen children who are really squeezed in violence getting back to the teacher. And at the end of the day, the teacher is ashamed. We have seen teachers beating children badly to the extent that they've called them mental health challenges. We have seen some teachers beating children whose destination they don't know. But at the end of the day, the child you tortured in school is now the ED of SEHAD. The child you tortured in school is now the CEO of MTN. You also want your children to get jobs and all that, and you can't get there. So we keep telling them about so many of these. But the other thing we are also doing as a ministry...
In 2 minutes, could you conclude in 2 minutes?
Okay. Okay, I'll wind it up for now by mentioning that we've developed quite a number of guidelines to support our teachers on handling violence against children in schools. We, I told you, are reviewing the framework, and part of the big content in the framework is actually concerning gender-based violence. We have come up with guidelines on re-entry, on reporting, tracking, and response to violence. We have guided teachers with so many messages on the talking compounds, and so on and so forth. Let me just cut it at that for now. Otherwise, I can speak until the cows come home.
But thank you so much for really highlighting the positive direction that the Ministry of Education is taking. We are really excited about even the back to school policy. It was very, very helpful. Madam Nakafero, Mr. Semakula from Ministry of Education said that the things that happen in the home, they have left it for the Ministry of Gender. So your ministry is at the center of really addressing and tackling gender inequalities in society. The youth, the men, women, families. So what is missing? You walked this through. What is missing? What can we bring on board and tackle this differently?
Thank you very much, Patrick. I would also like to thank the keynote speaker and the panelists for the areas that they've so far covered. Really, I would want to focus my discussion around 3 areas. First and foremost, we need to shift our value system. Yes, as a country, we have positive laws and policies. Henry has elaborated on so many programs that are being implemented in the right direction. However, we've not been able to shift our value system in harmony with our laws and policies. The laws are very clear in terms of promoting equality and empowerment of women and girls, but we still have social norms, negative social norms, values and practices that continue to discriminate against women and girls. My colleagues have already talked about many, but I would want to talk about child marriage. And this is one of the elephants in the room when we talk about safe motherhood. You find in our case, girls are subjected to defilement, even as early as 5 years. When it comes to puberty, definitely these girls find themselves pregnant at a very tender age, even when their reproductive system is not ready to carry another baby. And the cultural practices dictate that once a girl gets pregnant, then she definitely has to go for child marriage. So along that cycle, there's a lot of discrimination against these girls, to an extent that they're missing out on quite a number of enjoying their rights. Right to education is one of them. Right to protection. Instead of parents and communities protecting these girls, we hand them over to the person who defiled them for marriage. So they're not protected against the defilers or the violators of their rights. And of course, they find themselves drawn into a web of roles and responsibilities that they are not prepared for. So we really have to do quite a lot in terms of shifting all these value systems that continue to discriminate against women and girls. Female genital mutilation is a very good example, where these girls are mutilated, and on mutilation, they're then forced into child marriage, and the cycle starts. There's still a lot of discrimination against women and girls, and once we don't promote equality and empowerment of women, even our laws and policies, we are not able to implement them. So first and foremost, ladies and gentlemen, we need to pay particular attention on ensuring that our value system, our practices, the social norms that we celebrate, embrace equality and empowerment of women. That also brings me to the issue of parenting. We have serious gaps in parenting. We find ourselves, our children are not getting the best in terms of their lives. There's quite a lot in terms of neglecting their roles and responsibilities, neglecting their fundamental human rights, and quite a lot along the way, they find themselves really very vulnerable to all forms of discrimination and violence. So we need to parent, we need to strengthen our families to be able to provide a very conducive environment for our children, our boys and girls, to be able to grow in a nurturing environment. Henry has already talked about the life skills. Sexuality is an area that demands quite a lot of attention. Young people have to learn to know what it takes to engage into sexual-related relationships. But also, as of age, you also need to learn to not to subject these young people to unnecessary sexual relationships. So sexuality education still remains a cornerstone for us in terms of ensuring that the girls especially are prepared to navigate the challenges they go through when they reach puberty, and of course when unavailable circumstances of defilement, they're subjected to all forms of violence. That also brings me to the next point of promoting positive masculinity. Uganda, like any other country, we like it or not, men and boys are still very powerful, still entitled, and with a lot of privileges. We are yearning for a situation where men and boys can reach an extent of utilizing the power they have to protect the girls and women. So we need to nurture boys into gentlemen such that we are able to see that power that men still have being utilized for a good cause. It does not entitle you to subject a girl to defilement even when you can. So we need to use that power to say no to defilement, to say no to other forms of violence, and of course ensuring that we utilize the resources at our disposal to promote women and girls' rights. That also brings me to women and girls' agency. The laws are very clear. No violence against women and girls. We also find ourselves as women that we accept some of these negative practices to continue. I would want to talk about female genital mutilation. In communities that are practicing female genital mutilation, it's basically the mothers, the senior women that are really brainwashing the girls to accept to undertake female genital mutilation. All the surgeons are women. So as women, we also need to be very deliberate, take advantage of the enabling laws and policies to push for our human rights. Because we are, by nature, we are equal human beings. Funding is the last one. We've been implementing programs on GBV prevention and response, but because funding is limited, we find ourselves, our scope in terms of the numbers of districts, in terms of the areas of focus are also very limited. So as a country, we need to invest into serious investments into GBV prevention and response across the life cycle. Thank you very much.
Yeah, thank you so much, Madam Nakafero, for those very discrete areas that you've shared on parenting, on life skills, positive masculinity. Very, very good points. Now, the manifestations of violence normally end up in the health system. You find a woman with complications and she has been beaten, there are injuries, there is rape, and they'll come to the health system. Dr. Irene, could you tell us what exactly is missing that we should do to reduce the burden of gender-based violence on the health system? And what are your suggestions on how we can really bring in these interventions? Over to you.
Yes, thank you very much, the moderator. And I also want to add my voice to appreciate the keynote speaker. Like you've rightly said, things happen in the schools, in the community, and they end up with the health system. Before I begin, I just want to say that we are all aware that the young girls who become pregnant, that is violation. The fistula that results is a complication. The mortalities from the young girls are high. And when we look at the data, especially around the young girls and women, we see Bugishu, Busoga, Toro are really burdened in terms of GBV and specifically with our adolescents. But like it has all been said, no one single sector can do it alone. We are not short of frameworks, we're not short of policies, we are not short of laws. As the health sector, I'll categorize the shortfalls or the gaps that exist in terms of addressing gender-based violence and therefore affecting the safe motherhood. I'll categorize them into three. We have issues around capacity, procedure, and workforce. When it gets to capacity, there is inadequate training, and in here, you'll find a health worker who is faced with this young girl, and probably there may not be a high index of suspicion. This young girl comes in with symptoms that may not point to gender-based violence. Unless the health worker is well equipped and they can probe further, that's when they can appreciate that probably the reason why this young girl or woman is seeking services is because of GBV. Secondly, in terms of capacity, even disclosing, we know that our health workers may not be well prepared to communicate the findings. I'll start with the procedures that are needed to undertake once they suspect that this child or girl or young woman has been violated. So in there, we are seeing capacity gaps in terms of training, how they handle these young women and girls, the issue of being judgmental. One of the speakers said, you might not know the circumstance under which this young girl or woman had been violated. When it comes to the procedure, there are a lot of procedural hurdles. Survivors come in because of the processes and the procedure that are spelled out. They are sent back to police to pick forms. We have that P3 form. Remember this back and forth movement of the survivor. It causes challenges, and it may lead to these young girls and women to run away or not even report back to the facility. And not only does that happen, it also finds a health worker who has this long line, the workload and the time. So they have to walk through these processes to see that the forms are filled, the survivor is examined, and sometimes there is no compliance. And this affects the health sector as well as the clients who come to seek services. Then information, there's lack of information on, this now comes to the side of the clients and the survivors. They may not be aware of the referral pathway, and so is the provider. The provider gets stranded. They don't know where to refer this survivor. There are no linkages, and probably that is one of the gaps that has been observed in terms of managing GBV. So I cannot ever emphasize the issue of resources. We have the GBV kit. Sometimes we get stockouts, sometimes in the forms, and this prompts under-table costs that are not clearly spelled out. A health worker, in a bid to address and manage, they'll look for ways of getting money from the client. So what are the opportunities, or what is it that the health sector is aiming in terms of finding solutions? We are now aware of the integration strategy that is in the development, and we want to look at a person as a patient, not as a disease or not as a condition. So we are emphasizing the whole facility or government approach. In here we have to bring on board other sectors, but also a facility should have this whole approach in terms of responding to GBV and all other conditions. We need to bring non-legal and legal actors together. That is all, the whole facility approach. And we need to package. Our packages of maternal, adolescent health should be inclusive of gender-based violence management. Like I mentioned, the laws and policies do exist. However, they also have some bit of gaps here and there, especially around the consent. So this is an aspect that we need to look into. The other innovations, how do we get the providers, the duty bearers accountable? We are now implementing the Teenage Surveillance and Response Platform. And this draws different sectors to understand the challenges these adolescents and young people are facing. However, whereas this innovation is good, there are still issues around coordination that we are facing, even amongst the different departments and and agencies. But I would like to bring to the attention of the members here present that the accountability framework has enabled all players accountable, and there is a lot of awareness creation that has come up. So the young people, the adolescents, the women are now more informed about these emerging issues, and this accountability framework has kick-started in the high burden regions. Then capacity building is another area. We are incorporating in whatever trainings and capacity building efforts we are undertaking. We are embedding in modules around GBV, informing our health workers of the pathway, because this has been a challenge. And we have disseminated the referral and linkage pathways. Lastly is the community, and I think it was talked about by one of the panelists. How do we get the community on board? Remember, those who are violated come from a community, and we need to empower the community in terms of psychosocial support so that they can support these young girls, the women who are violated, to appreciate and get back into the community well integrated. At this point, I want to appreciate the partners that have supported in putting all these documents, ensuring that we build capacity and availing some of the commodities, and enabling the redistribution of some of these, for example, the GBV kits where they are missing. Thank you very much. I beg to stop here.
Thank you, Doctor, for sharing the gaps you see and the opportunities that we have. We've been running what we call the Heroes for Gender Transformation program in Busoga and Bugisu, and we've been able to demonstrate through a hotspot model how sectors can work together. You locate a survivor care center near the health facility, close to the police, and then you're able to even make people aware. So I would like to offer that at a good opportunity, we can really share this with you. Madam Fatia, Uganda is praised for having very good policies. And just like the Ministry of Education, Health, and Gender, they have spoken, our library is very good. But the challenge is implementing them. So in your experience as SEHAD, how have you managed to ensure that the policies, guidelines we have, and the laws that she has just talked about are actually implemented?
Thank you so much, moderator, and thank you the speakers that have come before me. That's an interesting question, because yes, we indeed know that we have good policies. I want to add laws. I would like to add laws that are not necessarily implemented. As we have heard from our colleagues from the government, yes, there is some implementation taking place, but we still have a problem. I want to, as Nekesa was sharing her story, and also Juliana was sharing the numbers, I was asking myself a question, which we should all ask. Was Nekesa protected by the laws we have in place and the policies or not? That question is easy to answer. She was not. Was she protected by the system? Could we have prevented GBV, the scale of GBV that happened to her? Maybe, because she said she's a mother, so that means she went through a healthcare facility somewhere What if a healthcare worker there had brought it up? Are you well at home? Is everything okay? Maybe she would have brought it up earlier with the healthcare providers and something would have been done. Even our workplaces, I actually like detecting GBV at work. I normally pick on indicators and I follow through, perhaps because one of my background is social work. But I think these are places, workplaces, healthcare facilities, everywhere we are, we should be able to detect and support, because either we prevent or we catch it early. But I want to go back to the question of policies and laws. We do have good laws. In fact, the legal instruments we have are many. We have the Domestic Violence Act, we have the Prohibition of FGM Act, we have the Penal Code Act, we have the Prevention of Trafficking Act. We have them and they are supported by policies. But why is it that we have Nekesa going through what she went through? We have the numbers still coming through. When you look at police crime reports, the violations, especially GBV and specifically defilement, each year, including 2024, we have more than 10,000 girls defiled. They are boys as well. They are very few, but still they are there. But we have a very big number of girls. And in fact, even when you look at police crime report for 2024, we have more than 1,000. The number of children aged 0 to 8 that are defiled are now higher than 1,000. And if you look at the statistics, the number is increasing. And I keep asking ourselves, we are saying we cannot talk about these issues of sexuality with children of that age, but their first encounters are being sexual violence from adults and people who are supposed to protect them. So is the Child Protection Act protecting the children from the sexual violence? I think those are, for me, are important questions. But if we are to go, and we also have the data. Police crime report each year, Juliana has shared the data. The data, behind the data are people like Nyekesa. So we actually have the information, but what is happening? Why are we not getting where we want to be in terms of eliminating gender-based violence? I think for me, number one, budget allocation. I'm surprised that the commissioners did not talk about budget. They are trying to do what they are trying to do, but we all know that they do not have sufficient budget to implement the policies. Implementation of the policy is not national level awareness. Gender-based violence is happening at the grassroots, at family level. How is it that the families and the communities do not know about the laws? Indeed, they do not know. From the work we do every day at SEHAD, of sensitizing and creating awareness, legal empowerment for communities to know their rights, most of them do not know. And when they do not know, then they cannot also protect themselves. They cannot also access justice when their rights are when their rights are violated. So I think for me the budget issue is very important. And it makes me remember yesterday I was at the East African Mental Health Summit, where the commissioner from the ministry was saying, Ministry of Health in charge, was saying, we have the mental health policy. And all the healthcare workers seated in the audience, we are saying, where is it? That means that the policies are not being rolled out to benefit the people, to protect the people. And one of the reasons that this is not being done is because such critical issues, gender-based violence, mental health, are not usually in annual national budgets, are regarded as unfunded priorities. So we recognize them that they are priorities, but they remain unfunded, which is very dangerous for our country. It's unfortunate that Ministry of Finance is never in these spaces. We do invite them actually, but they are never in the spaces. Perhaps it is the ministries here that know the extent of the issue that need to sit Ministry of Finance and indicate and demonstrate the extent of the problem, for them to appreciate and allocate financing for implementing policies. Implementing policies means implementing the strategies that are in those policies. It also means going down to orient everybody, healthcare workers, communities, religious leaders, cultural leaders, and so on their roles and responsibilities, for them to be able to actually take part. But communities do not know. The school owners, the school communities do not know about the policies and the laws. We appreciate that the ministries are doing their best, but we know they are constrained by budget. So everything about implementation is hinged onto the budgets that are not allocated. Everything is, I want to share some of our work. We do a lot of access to justice, and every time the police person is number two, the problem number two is enforcement of the policies, especially the laws in particular. Police, when we work with them, they are telling you, I do not have fuel to go and investigate the case for the person, for the woman to access justice. And indeed, they do not have the fuel. But also at police, there is the issue of corruption. And we need to also hold them accountable. 2 weeks ago, somebody called me, somebody I know working in one of the civil society organizations, telling me, I'm supporting a 14-year-old in school. She's supposed to be sitting for primary 7, but her teacher defiled her and she's pregnant right now. And I've gone to police, and we are trying to do our best for the teacher to be arrested. But in fact, the policeman told the mother that is being helped for this girl to go to school that, the teacher, this incident that happened to your daughter could change your entire life because this family is willing to give you 20 million shillings. Can you imagine? This is the police who is supposed to enforce the laws and to make sure that these policies are actually benefiting the people. Telling the woman, the mother who is vulnerable, and already somebody else is helping to pay fees for her daughter who is impregnated, that you know what, this could change your life. The 20 million that they will give you is going to change your life. So I think also holding the enforcers accountable to their actions becomes very important there. But indeed, the enforcement, who are the enforcers? The police, the healthcare workers, but also the healthcare workers sometimes or many times do not know what is in the policies. They do not know what is in the laws. So these ministries we see here need to be capacitated and facilitated to go down to make sure that healthcare workers know what is in the policies and in the laws, and for the communities to know their own rights, that they have the right to actually go and report. They have the right to hold duty bearers accountable. I think for me that's very important in terms of implementing policies and laws. The other one is capacity building. I think Dr. Irene has also talked about it and many others. Capacity building for the existing structures on laws and policies, including government structures, including religious structures. The religious leaders and institutions need to know what is in our policies and what is in our laws and the rights of people. And they can cascade that and prevent GBV as well as participate in in the response. The cultural institutions. The cultural institutions, I know we have, at SEHAD, we have collaborated with Buganda government to give awareness, create awareness on health rights, GBV and other SRHR issues to the annual Women's Convention, which brings together more than 2,000 women from every part of Buganda in one place. And I remember that about 2 years ago when we did that, and Katikiro was there, the women requested, can you also help us with the men? And I want to tell you, it's just 2-3 years down the line, Buganda now has Buganda Men's Convention, where they are being sensitized about issues of SRHR. So I think these are also spaces where even these ministries can go and make sure that people know, even men know about these issues, the policies and the rights. I think that's another one that I wanted to talk about. Also, I want to talk about the formulation of policies. When I listened to my dear friend, Mr. Semakula, he mentioned the people who are involved, who are currently involved in revising the framework, the sexuality framework. I was waiting to hear whether the justice system is there. Because the justice system will know the human rights-based approach and ensure that, yes, our policies and laws are informed by our culture and social values, but that should be balanced with human rights. So we need to make sure that the Ministry of Justice is also involved when these policy frameworks are being developed, because they can also help to ensure that our policies are not only based on our social and cultural values, but they also take into consideration the human rights of people. And I want to, I know you want me to stop, I'll stop in a minute. So I think for me, one of those other things is that we all know that when the Ministry of Education produced the revised guidelines to enable re-entry of teenagers back into schools, there was a lot of contestation. But who holds the power for implementation of policies? Whose power is it? We are taking ourselves into a confusion. For me, to that extent, it was as if the government does not have the power, yet it has the power and mandate to ensure that policies and laws are implemented. But then we see our commissioners also saying they were contested. And so what happened? Should we just leave it like that? Or is it just a cover-up that the government is not allocating funding to ensure that the schools can accept these girls back into schools? Again, enforcement. What if we said the schools can close and have examples of schools that close if they refuse girls to go back to schools? We know that we have members of parliament, we have ministers that were once teenage mothers, but were given a chance, and now they are ministers, they are leaders of our country. And why are we denying the same to the young people of today who constitute the future of Uganda? So I think those are really my thoughts. I have so many thoughts, but I know we do not have time. But I think one of the things for implementation of policies would be to take examples from the movement and the actions we've taken to eradicate HIV/AIDS. The mass awareness, the mass movement, also the immunization, that mass awareness on immunization. Can we apply it to GBV? Can we even not make it just a women's issue? It's a whole population issue. But the backbone is financing for those interventions. I'll stop there for now.
Now, thank you very much, especially for that last point on mass movement to eliminate GBV. I think it's a unique suggestion which we need to look at, and we combine it with other mass things, immunization and so on. Madam Judith, you've heard all the panelists, and you happen to wear the hat of a development partner. What do you see as missing in the fight against gender-based violence?
Thank you, and thank you everyone for listening. I know it's coming to the end of the day and people are tired, but I think in our reflection on what are we not doing well in eliminating causes of GBV, it's very important for us to recognize that, first of all, freedom from violence is a human right. And for every Ugandan, that's a constitutional right. So we are talking about violation of rights of especially women and girls. And of course, men and boys are also suffering. But because of the social construct in which we live, it's just unexpected and unimaginable that a man can report that I'm also being beaten. But of course, the conversation tends to be so skewed towards women and girls because the heavy burden lies on them. And we know that the statistics are quite low when we look at, the number of men and boys who suffer. So in my conversation, I want to reemphasize that we are talking about a rights issue. And then secondly, if we really talk about causes of GBV, then we have to look at the people perpetrating GBV. And I think for the behavioral scientists, you can agree that it's a behavior, right? Nobody, these are things that it's a person doing to another person. It's an execution of a behavior. So if we are really going to be talking of eliminating GBV, we have to go down to the behavior that we are seeing manifest in the forms of GBV. And we also need to appreciate that it's a behavior that is so much anchored on what people have seen for decades. People have seen this since they were born. That's what they have been seeing. That's what they have been hearing. And they have been nurtured in a culture that has reinforced a couple of value systems, a couple of attitudes, and they have just seen this happening. If a young boy sees the father beating the mother, what do you expect? Apples will give birth to apple, I guess, right? So as we discuss how we can eliminate or what we are not doing well to eliminate, let's just, the moderator gave us the ecological model, but at the center of all this is the individual. And if we can raise Ugandans who have a behavior that is very positive and supportive, we shall be a very long way in solving this problem. So coming from that, school of thought, recognizing that we are handling a behavioral problem. And if we are to handle this, we are also recognizing that gender roles and expectation is playing a very strong role in fueling this behavior. I mean, if you tell a boy men are tough, men never shy out, what do you expect? That's what the child is going to grow knowing. Men are tough, men will have the final say, and I have the final word. You get it? So let's really go deep and look at this as a behavioral issue we are dealing with, fueled, perpetuated by the environment, and this is about the social norms that everyone has been talking about, the kind of gender roles, gender expectations, the kind of power dynamics that society raises us to think, a man is more powerful than a woman, and the use of power abuse is acceptable. That's how men are. I mean, in some circles, that's what they'll say. That's how men are, and you see. So coming from that, we see that if the norms of a community is harmful, then of course that will breed adoption and execution of behaviors that will continue perpetuating gender-based violence. It's even worse if there is impunity to these harmful behaviors. It's like the circle will continue. So listening to what the earlier speakers have said, it's also about how do we shift, how do we change, how do we help people to build new behaviors that are anchored on more positive and equal power relations, equal respect between two genders, raising people with a lens of equality is I think what Commissioner Angela said. And coming from that then, I would say, as we are really continuing to tackle this problem, a combination approach is very important. You can't do one piece of the coin and say it works. It's a complex problem that needs a combination of interventions. While we are going to do behavioral change interventions with the men, with the boys, with the women, with the elders, it also has to go hand in hand with strong, as mentioned, with a very strong implementation of the laws that exist. I mean, behavior changes in many ways. Some people will adapt new behaviors because they have been convinced this is the right way to go. But some people will adapt new behaviors when they face the law. So that's why effective implementation of these protective laws against GBV is very important. So we need that combination of approach in tackling the root causes of GBV. And when we talk of a combinational approach, I think, as other speakers already mentioned, it also goes into, are we investing enough in GBV? When the keynote speaker talked about what this is costing the nation, I asked myself, if we compare that to what we are actually investing to prevent, because what she gave us is just the cost we are incurring, the loss we make, and the cost we incur to respond to the damages from a health sector perspective, for example. But if we looked at what we are investing to prevent, it's a very interesting thing for us to also, I think, look at. So combination approaches is very important, but I also still do believe if we looked at mapping of budgets that are happening, whether it's budgeting from government or budgeting from partners, very honestly, investment in GBV work is still very small. And at the same time, even when we look at what is being invested, when we talk GBV, we have to talk of the prevention we need to do, but also the response we need to put in place when it happens. And I think sometimes in our conversations, in our planning, we miss the balance. But we really need to invest in both arms of this work. We need to invest in prevention, but we also need to invest in the response. The challenge is that the prevention work, which we will harvest more if we do very good behavior and social change programs. The challenge with it is that these are things that will not give you immediate tangible results, tangible outcome. And even when you talk to the donors, they're like, we want quick results. But I'm telling you, behavior and social norms change is something that it's actually very expensive. It's very costly. And secondly, it doesn't give you the quick returns you want to see. So sometimes it's actually not very appetizing to many funders. So I think we need to continue to have a balanced investments in both prevention and response. And secondly, it's also about, the time frame of our programming matters. I think we've seen projects which are like 6 months, GBV prevention and response, and you're like, are you sure? 6 months you're eliminating? So I think the other thing we need to think of going forward as we design the work around GBV prevention and response, it's also about, how much time we spend, like our programming and our funding period needs to be long enough. And I know that for many development partners and for the civil society, normally we have, funding frames like 4 years. I think for us, we can talk some 4 years, but I think for government, but indeed for government and for Angela and Semakula, this should be your long-term investments. So from NDP 4 now to NDP 10 one day, this needs to remain a strong component of the national development agenda. And lastly, I think also we should have a very smart way of scaling the work we do. We've been doing a lot, and there are quite some best practices happening that can be scaled. And one of the core partner we see in scaling the good things that we learn out of our investments is government. So I think we really need that mechanism that allows us to have that good platforms for sharing the lessons, and government being able to take this up and mainstream it in their regular programming with government. I think we see PDM coming, but there are so many missed opportunities for integrating very good work within PDM based on what all our partners have been doing on what works, what changes behavior, what kind of content have you been doing? So I think that's also something that we really need to think of, and especially now that external financing is going down, it's something that I would really interest our colleagues from the government to think about it. How do you harvest the good practices, harvesting what works? And I have to be honest, in this work, sometimes some of the things we do don't work. But we are so afraid to say this doesn't work. And sometimes, unfortunately, we've repeatedly done what doesn't work. We've wasted money in repeating to do what doesn't work. So I think being able to have that mechanism for rolling what works and not wasting time and money on what does not work is very important. This is really what I can share. Thank you.
Thank you, Judith, for that very excellent presentation. And you've given us another perspective of what we really need to be doing as a country, working together under different sectors, telling ourselves the truth that behavior change takes time, but also not wasting time and money on what does not work. Very good messages among the several that you've given us. Ladies and gentlemen, we are really just on the dot of time. And our intention had been that if you had come earlier and we started at 2, there would be enough time really to interact and discuss. So we've also seen some questions on Slido. For instance, I'm seeing a question here. Somebody's asking, what are NGOs doing to help address, I think, or support sexually abused girls? There are quite a number of models, and there are very many NGOs here. I would want to recognize together with us, of course, there's been Sehad here, there's Mifumi here, Amref, and several others. So I'd want to request that as we try to wind up and we have some networking time, you can also get to know what are some of these interventions. Please kindly scan that barcode. We may post some of the responses to those questions there because we do not have sufficient time to actually take many questions and respond to them in the plenary. So I'd like to take this opportunity to request you to please clap for our presenters. And while this was going on, I took a few notes, and there are some points that perhaps we can get as take-homes, but we shall also provide a session report and try to follow up on some of the good information that we have received here. The first take-home point is that freedom from violence is a human right, and that should be our drive to really make sure that we fight gender-based violence for mothers, but also for the whole of society. 2, that we need to tackle a shift. We need to tackle these negative norms and values and really try to make sure we have a whole of society shift in our norms and values, that the norms and values we bear and we live by should be, we should relieve our society from violence. The third take-home message is that everybody here and outside has a role, at home, as an individual, as an institution, on the policies and the government. Each one of us has a role. The other is that we need to take the integrated approach to leverage existing resources, but also try to have a domestic investment in really fighting gender-based violence. The sixth area is that the response to gender-based violence is a package. It's not just one single, small intervention that would really achieve the fight against gender-based violence. It's a combination of interventions which are evidence-based and data-driven. There is also a proposal that much as the way we deal with mass interventions, be it immunization, be it maybe responses to outbreaks, we really need to have a mass movement that addresses gender-based violence in this country. We also need to have results-based action so that we only invest in things that give us results. The ninth and second last is that the fight against gender-based violence needs to be a long-term national development-oriented intervention. We cannot just do piecemeal things. So the ministries that are here need to work together because you are the ones who are driving the interventions of the country, including linking gender-based violence interventions to the national development agenda. And I think the last one I got is that let's not waste time on things that do not work. Let's be bold and tell ourselves that such and such an intervention doesn't work, and we leave it. So I want to really thank our panelists, and really please clap for them again. And also, I would like to recognize all our partners who supported us, first from AMREF to CODAID to MIFUMI to SEHAD, UNFPA, and the Netherlands Embassy in Uganda, and others, and all of you. We know you are our partners in this response, and so we recognize all of you for that. So I want to ask the panelists that this is the end. We stand there for a group photo, and then we shall close this session. Thank you very much. We look forward to working with you in the different spaces where we shall meet as we address this matter. So may I invite Madame Juliana, I know you left us a bit, but please come back, and we shall take this group photo and close the session. I want to wish you a very nice close of the conference and also a good weekend as you take some rest from tomorrow. Thank you.
As I reflect on the journey of AMREF Health Africa's Heroes for Gender Transformative Action program, I am filled with pride and hope. Over the past 4 years, we have worked relentlessly to address sexual and reproductive health rights (SRHR) and sexual and gender-based violence (SGBV) in 9 high-burden districts across Uganda: Kalangala, Iganga, Namaingo, Bujiri, Budaka, Mbale, Mayuge, Kwen, and Bukwo. Back in 2019, the statistics were alarming. 1 in 4 girls aged 15 to 19 was either pregnant or had already given birth. Nearly 24% of girls were married before the age of 18. Access to SRHR services remained limited, leaving many young people vulnerable. Determined to make a difference, we launched a program guided by World Health Organization's best practices and health and human rights framework. Since then, we have reached over 500,000 young people with comprehensive sexuality education through structured curricula like Journeys Plus and Program Y. Beyond schools, we have engaged over 10,000 out-of-school youth through community dialogues and medical outreaches. But education alone not enough. Strengthening health has been at the core of work. In partnership with 65 health facilities, we have trained 1,500 health workers on basic emergency obstetric care, BMOC, customer care, and inclusivity. Additionally, over 500 community leaders have been equipped with leadership and accountability skills to champion SRHR and gender equality. A key in our approach has been results-based financing, RBF, an incentive-driven model that rewards health facilities for improving access to antenatal care, skilled birth attendance, and family planning. Through RBF, we have created youth-friendly health corners, procured essential neonatal equipment, fenced health facilities for security, and even provided incentives such as internet access for health workers. This approach has fostered a culture of accountability, ensuring sustainable improvements in service delivery. Another milestone has been digitalization of the supply chain. With an investment of 160 million Uganda shillings in ICT equipment, we have enhanced real-time reporting and stock management. This has significantly reduced drug stockouts and improved service efficiency, ensuring young people receive the care they need when they need it. The results speak for themselves. By 2023, teenage pregnancies had dropped to 22% from 25%, and child marriage had reduced by 15%. The uptake of SRHR services among young people increased by 13%. These numbers are more than statistics. They represent lives changed, futures reclaimed, and a generation empowered. As we look ahead, our commitment is unwavering. We believe that every young person deserves access to quality SRHR services and education. With the continued support of our partners, we will persist in our mission because the health, dignity, and future of young people in Uganda depend on it. Thank you. As I reflect on the journey of Amref Health Africa's Heroes for Gender Transformative Action program, I am filled with pride and hope. Over the past 4 years,
Hello.
Thank you, our entertainment team. Yes. Ladies and gentlemen, the time has come for us to close down the 3 days of very powerful discussions that we've had. I'm going to invite the Commissioner, Reproductive Health, to step in for the Director General in taking over presiding over the closing ceremony. Thank you. The entertainment group, just have one additional round, please, as we mobilize other members from other groups to join us. Team Scientific, let's ensure that all our, please give us the vibe as we encourage our colleagues.
I'm listen, oh man, I'm listen. I'm listen, oh man, I'm listen. I'm listen, oh man. I'm listen, oh man. I'm listen, oh man. I'm listen,
Yes, 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 yes. Thank you, thank you, thank you, thank you. Thank you, thank you. A big round of applause for our entertainers. Just like my colleague had just mentioned, every good thing comes to an end. And today, tonight, we are summing up our very, very well spent 3 days here. And as we always say, in Safe Motherhood, we don't waste time. We're expecting a few guests to join us, but we have a couple of them here. And without wasting a lot of time, allow me appreciate each one of you. And I hope there's no breakaway session still going on. Allow me appreciate each one of you for your contributions, for your participations in this very important conference, the 5th National Safe Motherhood Conference. Can we put our hands together and appreciate ourselves? Our closing program is going to run as follows. We are going to receive a report of the key insights and actionable recommendations of the 5th National Safe Motherhood Conference 2025, and that will be presented by Dr. John Paul Bagala, Associate Consultant, Obstetrics and Gynecology, and also the Acting Assistant Commissioner, Reproductive and Infant Health. Thereafter, I will invite a few people on the stage who will be making declarations on behalf of their different organizations. We shall have a declaration from the voices of the young people and adolescents arising out of their pre-conference activities. We shall have, and each of them will be very timely, we shall have a voice from the CSOs. civil society organizations, and that will also take us only 5 minutes. We shall have remarks from the World Bank, representative of the World Bank in Uganda. I can see Dr. Rogers is already here. We shall have remarks from our chair, deputy chair of the Health Service Commission. We shall have remarks from Your Excellency, the Ambassador of the Netherlands, and remarks from Your Excellency, the Ambassador of Iceland. So it will be a short activity and well-timed. So I now take the honor to invite the team that has worked tirelessly to put together all the recommendations, all the insights, all the new ideas that are coming through from the different breakaway sessions, from the plenary, to step over here and give us a summary of what has transpired in the last 3 days. Dr. John Paul Parker, over to you.
Thank you very much indeed, Commissioner. Ladies and gentlemen, we are very, very delighted to have had you with us for the past 3 days to synthesize and renew our commitment to improve the care for mothers, babies, children, the adolescent, and ensure that we avert preventable mortality for mothers and babies, and ensure that every mother has the opportunity to live as she brings life to this world, but also every baby to have an opportunity to live and thrive. For the past 3 days that we've had the discussions, we've gone through a number of focus areas, and in only 6 slides, we've synthesized critical issues that have come through the discussion. And these have been sieved from the parallel sessions, the plenary sessions that we've had, and the 5 parallel sessions that have happened. The report for the 5th National Safe Motherhood Conference, a comprehensive report, will be shared. But what I'm going to present to you, which is a synopsis of that report, guides on what we are going to put our focus on over the next 1 year before we reconvene in 2026. The key focus areas, we are looking at revolutionizing the health workforce, integrating and financing resilient health systems, empowering communities, and leveraging data and innovation for accountability. Under the focus area on revolutionizing the health workforce, we've agreed to emphasize and enforce site-based EMOC mentorships and cascade continuous low-dose, high-frequency and facility-based mentorships to ensure that we close the skill gaps that are existent among us frontline healthcare workers. This critical point came forward during the presentation of the MPDSR report, where it was emphasized that we are seeing a number of mothers losing life following performance of cesarean section. So we've agreed that it's very important for us to cascade the emergence obstetric and newborn care mentorships. And that is inclusive of the specific skill set mentorships, for example, the essential training in operative obstetrics. Secondly, we've also agreed to scale the professionalized community health extension workers model nationally with clear terms, their packages, and to have them well facilitated. This came out very, very strongly in the plenary session, the high-level presentation that was made on the second day by the Commissioner for Health Promotion. We've also agreed to hire, recruit, and train the critical health workers, including doctors, neonatal nurses, anesthetists, and midwives. And I think over the course of the 3 days, the aspect of recruiting this critical cadre has come out very, very strongly across the various discussions that we've had. In the focus area of integrating and financing a resilient healthcare system, we've agreed to decentralized life-saving and low-cost technology. Over the course of the 3 days, we've been subjected to life-saving and low-cost technology, which we need to scale up, which we need to cascade across the various levels of care. We've also agreed to ring-fence domestic financing to address our local gaps. And this came out very, very strongly in the opening ceremony, but also in the course of discussion. We've appreciated the narrowing donor funding landscape, and we've agreed that we need to look internally more. Thirdly, we've also agreed to fast-track the National Health Insurance Scheme with a full maternal and newborn health package. I think all of us in this room agree that this is an issue that is far delayed, and we need to ensure that it's expedited. Under that focus area, we've also agreed to ensure consistent supply chain management and security of essential commodities and equipment. If you unpack that particular point, it's speaking to how do we ensure that a mother who presents at any facility, at any level of care, the critical commodities that are going to care for that mother and ensure that she's alive should be made available. Under the focus area on empowering communities, we've agreed that we need to launch a national culture campaign that will enable us to engage culture and religious leaders to lead dialogues and shift harmful norms. We all appreciate and have appreciated over the 3 days that the aspect of cultural engagement speaks and is at the center of the multi-sector engagement, which has been the theme of the 3 days that we've been here. We've also agreed to have stakeholders renew their commitments to enhance moral, cultural, and ethical strength in the fight against maternal and newborn deaths. And we've also agreed to integrate services at the village level. We want to leverage the existing government mechanisms like the parish development model and ensure that we are riding along those and leave no mother behind. Within the focus area on leveraging data and innovation for accountability, we've agreed to make data reviews non-negotiable, to institutionalize routine maternal perinatal death surveillance and response across all facilities and level of care. I think we all agree that at national level, we've nailed that aspect. But we need now to see ourselves in the respective local maternity and neonatal systems, in the respective districts and lower facilities, that the MPDSR mechanism is quite strong. We've agreed to create public accountability dashboards where we have real-time sharing of key indicators to inform real-time interventions. If we have a facility, a CMOC facility, without blood transfusion services, we must be able to flag that particular facility and have that particular gap addressed. If a particular health center cannot perform cesarean sections, and yet it's supposed to perform cesarean sections, that must be flagged in real time. And the cause for that gap must be addressed at national level, way down to the lower level facilities. We've agreed to establish an innovation adoption pathway that creates, which is part of a national framework for piloting, validating, and scaling up successful innovations. Over the course of the 3 days, we've appreciated, and within the prior sessions, the valuable innovations that have been presented. We don't want those to end at just being presented. We want to go further and have them translated into life-saving practices. And we've also agreed to strengthen academia and make academia and research institutions as part of the informative processes that inform both policy and practice. And I'm very happy that we have academic representatives in this room to ensure that we take that forward. Ladies and gentlemen, that has been a synopsis of the discussions that we've had over the course of the past 3 days, and the final report will be shared with you to ensure that we hold ourselves accountable when it comes to October 2026. I thank you very much indeed.
Another big round of applause for Dr. John Paul Bagala. I want to thank him for putting this together, and I know he has captured everything. As we move to the last part of this occasion, I want to invite, I want to begin by our very important group, the CSOs. I know we had a lot of trouble. Maybe before we go to that, I've been reminded, and I think it is very important, that we introduce the team that has been very, very engaged in putting this together, and that's the organizing team. Wherever you are, kindly step forward and we clap for you. You've been running up and down. I know you're still running up and down. As they step forward, please. Now, for now, you keep where you are. I will call you to have a photo moment, but let's clap for them. Let's clap for them. Thank you very much. You've done a commendable job. And I must say that every year, Safe Motherhood Conference gets better, and better. I'm trying to buy time. The Director General is on his way. But in the meantime, he has allowed us to proceed. And allow me at this time to invite the representative of the young people and the adolescents. As I earlier mentioned, that the young people had their conference on the 21st of October before the Safe Motherhood Conference, and which we termed as the pre-conference activity. The young people are a very critical component of safe motherhood, not only because they are potential mothers, but ours have also started reproductive life, and we are not very happy about it. We want to hear what they have to say. The young people constitute, as they come forward, the young people constitute 50.5%. Young people less than 18 years constitute 50.5% of our population. Join me in welcoming the Assistant Commissioner, Dr. Irene Mwenyango, to take their seat, who is a very pragmatic young person, and she'll be telling us who she is. Also, allow me at this time invite a representative of the civil society organizations They were right here at the beginning. They made a statement made by their chair, Ramka. Civil society organizations are very critical for our service delivery because they provide for us the social accountability. They are the extra eye that looks at what we are delivering, where we are not doing well. They hold duty bearers accountable. They provide us that extra feedback on what we are supposed to do, and we also, in a way, hold them accountable. We have been working with them, and there's a special platform called the Ramka N and the Elderly. We had forgotten the elderly, but now we have them. The elderly, if you're above 65, we are planning for you. And the one representing them is probably also above 65, Dr. Lydia Mongerera, formerly director with Mama's Club, coordinator of the CSOs at HIPAC. She has spent more than 10 years at HIPAC, a member of the Ramka CSOs group, member of the WHO EMTCT Afro Regional Validation Exercise. Join me to welcome Dr. Lydia Mongerera. She's a very young adolescent. Also, in a special way, allow me invite the representative of the World Bank. The World Bank, put your hands together and we welcome Dr. Rogers Ayiku. The World Bank is a bank without a house. It's the only bank without a house, but they provide us money. Part of our journey for the last 5 years, we received funding support and technical support from the World Bank under the AMCHI project. Part of the institutionalization of the funding support to the health facilities was spearheaded by Dr. Rogers Ayiku. I want to credit him for that, and Dr. Rogers Mulindwa. Part of the improved infrastructure that we are launching in our districts was part of the AMCHIP and UCREP projects, and the Ministry of Health, Reproductive Health Department, has a special place of the platform GFF, Global Financing Facility Country Platform, where the World Bank participates, and we are co-creating together how we can get to the last mile. How do we get to hundreds? How do we get 100 in coverage and 100 in quality of care? We want to appreciate you. I want also, in a special way, to invite our special guest this evening, the Deputy Head of Mission, Head of Cooperation, Embassy of the Kingdom of Netherlands, and this is none other than Bowen Jan Smeding. Thank you for being amidst us and joining us this evening at the official close. Join me in welcoming him on the stage. You're welcome. I hope I've pronounced the name very well. My apologies if there was an omission. I also want, in a special way, to invite the head of mission of the Embassy of Iceland. For fear of butchering this name, the name is Hugo. But I know she's my friend. We met in Namusindwa. Thank you very much, and you're welcome, Her Excellency, and we appreciate you for being here with us. She will announce the name. It's genuinely a difficult one. Lastly, I hope I've not left anyone there. Lastly, allow me invite the representative of the religious group. Bishop, probably the only bishop we've had for the last 3 days. Bishop Amos Agaba, a champion of safe motherhood. A clergy, a very committed man. We want to appreciate you, want to thank you for the support, and request that you kindly join the podium as we make statements at the the closure of the 5th National Safe Motherhood Conference. After these guests, we shall have a message from a representative of the minister that will be delivered by our Deputy Chair of the Health Service Commission. She does not need to be here, but she will come and give us a brief message after. I want to begin with the young people. We are eager to hear from you. And I'm not going to allow you to sit. I want everyone to see you. We are making you the leader of tomorrow. I know you want to say you are the leaders of today. But I'm happy to adjust this for you. We are all in support of you and eagerly waiting to listen from you. Thank you very much, and you are welcome, Madam Her Excellency, representing the 50.5 million Ugandans. And that is close to more than 22 million people. Step forward. You want to introduce her? Please come.
Yes, thank you very much, Commissioner, our distinguished guests, protocols observed. Good evening. Like introduced, I'm Irene Mwenyango, and I work as an Assistant Commissioner, Adolescent and School Health. I'll straight away let this congregation know that on the 21st of this month, we had the pre-youth conference under the theme, Strengthening Multisectoral Approaches to Improve Adolescent Health and Well-Being, an event that was graced by the Permanent Secretary, Ministry of Gender, Labor and Social Development. And we had a keynote address from the Executive Director of National Planning Authority. During this event, we were reminded that there is need for meaningful progress in adolescent health if we engage young people and adolescents meaningfully. At this point, allow me to thank all the stakeholders that supported us to ensure that the event happened successfully, and those that supported the young people to participate in the event. I would like to invite our young person who participated during this event to share the outcome statement or the communique that we agreed upon, representing all the adolescents from the various regions and districts. And this is none other than Gabada Lucy. She's a senior 3 student from Air Force Army Senior Secondary School in Entebbe. Please join me to welcome Lucy.
Good evening, everyone. You know, it's such an honor for me to be here among all students, all adolescents. It's really such an honor. Thank you very much for having me here. Okay, my name is Gumba Dalwanzo Lucy, and I study from Air Force Army Secondary School. And I'm going to present to you a comic from adolescents and young people of Uganda. I'm going to add my voice to others So, on 21st of October 2025, we as young adolescents, we met here. We were from various districts. We met here to come and learn some new things and also share some of the problems which we face. And some of the problems which we face, we see about 1,000 girls get pregnant every single day. This is just not a number. It's a cycle of poverty, illiteracy, and poor health outcomes that needs to stop now. I said now. Okay. And also, over 8,000 adolescents tested positive for HIV this year. This is unacceptable and unfortunate. And on top of this, we are fighting mental health issues, gender-based violence, and harmful cultural norms that limit our potential as young adolescents and young adults. We are just not problems to be fixed, ladies and gentlemen. That's why we attended our conference, we presented different poems, different skits, as a testimony to you, to prove that we are ready to be partners, but not guests. Our wins and tools, we appreciate the progress that the government has made. The government has set up adolescent health committees in 62 districts. Teenage pregnancy surveillance and response system initiated and scaled it up to 31 high-burden districts, increased the number of districts with children reference groups. And also, this is the thing which I love most, the government made it easier for adolescent mothers to go back to school through providing guidelines for entry. And also linking schools to facilities, conducting community outreaches to improve access to services, availing toll-free lines and call centers to provide accurate age-appropriate information. Ladies and gentlemen, really the government is doing something great. To top on that, also during that day, the ministry also launched 3 major documents that will further guide implementation for adolescent health. And the first thing is the National Adolescent Health Costed Implementation Plan, which is from 2025 to 2030, and the Teenage Pregnancy Surveillance and Response Framework, the Annual Adolescent Health Report. And also as young people, since the new curriculum emphasizes us to be creative, we also showcased some brilliant ideas. We had peer-led HIV prevention models, mobile apps for getting the right information, and projects that are making us get money as young people. And also the big lesson I learned. Do you want to listen? Peer support and teamwork works. For real, no man is an island, so we need each other's support, and I really like that. That was the biggest lesson. And also to dive in more on our commitments and non-negotiable demands, we had diverse stakeholders from police, cultural leaders, ministries, district head teachers, COAs, NGOs, name it. Then to the government, ministries, districts, partners, religious and cultural leaders, fight child marriage and gender-based violence. Don't just let the laws, enforce the laws themselves, and expand youth-friendly services and put mental health, life skills, sexuality education into schools and communities, ensuring that all adolescents like me and young people across everywhere receive this access. And community leaders and religious leaders, please, I beg you, you must champion the fight against harmful practices like female genital mutilation with alternative rites of passage in Sabay and Karamoja. You should also promote open and honest family dialogues. And I'm going to talk like the commitment as young people we made. We commit to being the peer educators, as I'm doing, the community advocates, and the mental health champions in our communities. We promise to be responsible and constructively engaged with leaders, mobilize fellow peers for services and opportunities in our communities. And for us all here, we must work together and use data to scale up solutions. Our immediate goal is to stop 1,000 daily adolescent pregnancies and make sure all young people, including those with disabilities, get fair access to services. The future of Uganda's adolescents and young people depends on what you do right now. Let's stop talking. Yes, let's stop talking, start mobilizing the funds and start acting. Empower us, the adolescents and young people, to realize our full potential. So this is the end of my manifesto, but as a young person, I wanted to leave you my poem. I really love poetry so much. It's one of the tools which I use during assemblies to educate my peers, because we are a population of 2,000 students. So I'm going to present for you my poem. When I whistle, when I speak, when I act, when I dance and swim to the rhythm of change, I rise. In my society, our society, there is this reality we stride in, a melody and tragedy that soars within, here and everywhere. With wings wide and can smile in the current tide, where dreams are left to bleed dry, where young seeds fed and cry, where madness thrive, FGM and GBV survive, clinging to young, innocent, tender souls, stranded and hard and sin, trapped in doom amid this society. My whistle begins. 10, 9, 8, 6, 7, 4, 5, 4, 3, 2. Let my whistle be your whistle, because there is power in a lion's roar. Tough enough to withstand the storms in our society. Tough enough to withstand the bullets that trigger the young adolescent. There is light to guide the lost that echo in your silence. You are not just voices. You are remedies to bring healing to my broken society, our broken society. Together, let's fight for the adolescents, for their dreams still unspoken, for the hope that refuses to drown. Let us rule with courage in this cure. Smile with pride in every corner, for change begins when we choose to whisper. Now, whisper. Thank you.
Wow, 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 wow. Another big hand of applause for a young person. She has ably said they don't want to be guests, they are partners. I think you have heard the others. They don't want to be guests, they are partners. Message is clear, the poem is clear. Thank you so much. Wonderful. We have a lot of talent. So allow me make this brief correction. I had omitted the chair of the Health Development Partners. Kindly, Madame Lunguzi, representing UNFPA, step forward to occupy the seat for Health Development Partners. And we clap for her. She's very passionate. Can take this side. Your seat is over here. As where the young person was submitting, we were joined by our Director General, Health Services, Dr. Charles Solaro, you're welcome, and thank you very much for being here again. We're also joined by the Under Secretary, Minister of Health, Mr. Kenneth Achiri. He's also here once again. He was here at the beginning. Also at the start, our PPH ambassador, Charlotte Kainerugaba, also joined us this evening. She's a very good supporter of midwives. And she told me that she had a gift for the best midwife in the country. So the best midwife at the award ceremony will get something from Charlotte. We now move to a representative of the civil society organization, another Dolson. Join me, put our hands together, and we welcome Dr. Lydia Mongerera. I had earlier given her brief. Dr. Mongerera, since for you, you are very few, so we shall reduce the time. Over to you.
Dr. Mgahi. Thank you so much. And it's very difficult sometimes to talk after such an inspiring talk that this young girl has given, but she has given us the picture. I'm going to be talking on behalf of civil society. I know I wear many hats, but here I'm representing RAMNAC, which is our platform. We have a civil society platform. I also represent civil society because I'm the founding director of Mama's Club, which I founded 25 years ago, grassroots mother networks, and that was done. But I also coordinate civil society on the Health Policy Advisory Committee of the Ministry of Health. I think I'm trying to summarize. To summarize it, I will say that we are really appreciative of the government and Ministry of Health for always involving us. We represent civil society on almost all the platforms in the Ministry of Health, and we are very grateful. We want to thank Dr. Mgahi and the Reproductive Health Department. I've been a member of the Maternal Health Cluster since I think I joined HIPAC many years ago. So we are engaged and we are involved. What we want to talk about, just a few points. Strengthening community systems. That's very important for us to strengthen community systems and also integrators be involved in the integration process which is taking place. We want to make sure our participation as civil society is at all levels. And that is very important for us. We want to also talk about financing. We want to make sure financial systems, which include what we've been waiting for, the National Health Insurance. We've been waiting for the National Health Insurance Scheme, which is not yet in place, but we want to make sure that all finance systems and civil society is engaged. And as I mentioned earlier, engagement and involvement means planning, programming, implementation, monitoring, and evaluation. We also want to talk about the commodities because they affect us. Our people are in the districts, and we want to make sure there's a smooth flow of commodities. Talking about HR, the issue of midwives. For us, we know very well, with safe motherhood, reproductive health, we need the midwives. The midwives are the most important people to us. They are the core of safe motherhood. At the same time, we welcome the community health extension workers. We know that community health extension workers from long ago. I was actually met them many years ago in Addis Ababa, many years ago when Ethiopia had started that system. But besides that, we want to be sure that there are other community structures on the ground. We know very well that CHOOS will work with the mother mentors, they work with the YAPs, and other people who are on the ground, who are already existing, who are there, including the VHTs. We want to talk about accountability systems. We want to talk about mutual accountability. When we talk about accountability, it must be mutual. And of course, we've got tools also which we are involved in, the community-led monitoring system, which we started and is still in place, where we go and monitor in the communities the quality of services, and we have that feedback mechanism. So we want the government to recognize that. We also want to talk about other programs which we know, of course, including the involvement. I was so happy to hear that people are talking about male involvement, because we know now that we need to involve men, we need to involve the fathers, and that's true. We want to talk about our commitment, and we want to commit ourselves to this partnership between civil society and the government and the Ministry of Health. We've been involved, but we want to recommit and mobilize our communities for safe motherhood. Safe motherhood is very dear to all of us, and we want to recommit ourselves. But remember, as we recommit, there must be resources, and we continue to call for domestic financing, because we know very well we cannot continue relying on external donors. So this is what we are saying as society. I was given 3 minutes only. Of course, Dr. Mugahi, you cheated my time, but I will accept it. Thank you so much. And thank you so much that there's a number of civil society organizations who are here. And thank you for always involving us in the Safe Motherhood Conference. We promise that we shall always be here. But of course, I really wanted to close by recognizing my civil society members. Jackie has been steering us. Jackie Turner, stand up. She's been steering us as civil society. We have Flavia, who's also been steering us. And I think, and of course, Patia has been speaking here. She's also a member of civil society. There are many others, and I want to appreciate all of you and recognize you. Thank you very much.
Another big round of applause for Dr. Lydia. Thank you very much, Lydia, for representing the CSOs and the great work that you do along with Jackie. We really appreciate you. Keep us in check. There's nothing you can do without being checked, so we really appreciate that. DG, well, you're aware, and when you're on your way here, I assumed your shoes. I'm trying to fit in, but I'm requesting that you leave me in Entebbe Uwoma for a few minutes. This was supposed to be chaired by yourself, and I'm moving on well. I want now to invite the only bishop who has been here amidst us. He prayed for us. He has been meditating for us. Every night he meditates for the mothers, even the fathers. Safe motherhood is not about mothers alone, also the fathers. So hopefully next year we shall talk about survival of, yes. Your Excellency, you're most welcome. This has been a very special conference. As Her Excellency takes her seat, I think you can see the number of our bilateral friends who have been able to attend this conference. It shows you the importance of this very engagement. I now take the honor of inviting Bishop Amos Magezi to make commitments on behalf of the religious fraternity.
Good evening, everyone. Amos Magezi is my name. It's true I am serving as the incumbent bishop of the Diocese of Northwestern Kole in Ibanda, but I'm here to represent Faith for Family Health Initiative, where I am also serving as a board member, and I chair programs and policy. And I'm a champion of family planning. And I would like to mention two things here. Some people misquote the scripture and they say, well, there is no need for family planning because God said, multiply and fill the earth. But let me be honest with you, that is very true because the word of God is truth, but it's not only one couple that will multiply and fill the earth. And so we need to understand the interpretation of the scripture when it is saying multiply and fill the earth. But also on family planning, I am encouraging men. There is a tendency of men running away from family planning and they leave it for women. But guess what? When a woman gets pregnant, we'll wait for 9 months to produce only one child. But what will happen if a man keeps going around to many women? How many children will be born in 9 months? I mean, how many women will be pregnant in 9 months? Now, that's the scientific you need science to interpret that, but you also can understand as a layman like me to understand that there is a need for men to go for family planning. I'm glad to be here in this conference, National Safe Motherhood Conference. And I would like to appreciate the Minister of Health for organizing this under the theme, Strengthening Multi-Sectoral Collaboration and Mutual Accountability for Safe Motherhood. When we were discussing, since the time we started, I remember on day one, they were saying, what can we fix as one thing, and then everything will be okay? To me, I kept quiet because you don't need to fix only one thing, and then everything will be okay. Let me give an example. If you have a car and you fix the tires, but the engine is not working, what will happen to that car? Where will it go? What happens if you fix the engine, only the engine, and there are no tires? What will happen to that car? Where will it go? So I think the wisdom is in the theme itself, strengthening multi-sectoral collaboration. It means that everyone is needed. Everyone needs to do what he's supposed to do, what she's supposed to do, in order that everything will come in place. So I must say thank you to the Minister of Health and all the partners for organizing this and for bringing this to our attention, because this is exactly what we need at this time. So as religious leaders, we are committed to this. When we are talking about doctrines, we'll be separated because Muslims have what they subscribe to, Catholics have something what they subscribe to. And so depending on everyone's faith, you will have what you will go and subscribe to as far as your doctrine is concerned. But when it comes to socio-economic and community engagement issues, everyone must come on board. And so I'm glad that I've been able to be part of this. And as Faith for Family Health Initiative, we have been in this for the last 5 years. I would like to mention that for the last 5 years, religious leaders have organized pre-Safe Motherhood Conference to commit and account. And last year, under auspices of Faith for Family Health Initiative, we launched an Interfaith Alliance as platform to continue engaging on safe motherhood. Now, today, one of the commitments that have been mentioned, for example, under the key actions, there was one which says, launch a national cultural campaign, engage culture and religious leaders to lead dialogues and shift harmful norms. I must be honest with you, if you bring us together, we are ready and committed to take the message because we have the platform, we have the pulpits, we have the groups of women, or groups of men, groups of youth. And speaking of the youth, I was able to spearhead the task of forming the legal framework of adolescents' health in Ibanda district. And so just know that we just need the information. We are ready to go, but you need to involve us and give us the information, and we'll be ready to go with it and for it. I would like to once again pledge our commitment to go and serve the communities because they need our service, and the only time we can do it is now, because leadership is for a reason and for a season. God bless you.
Thank you, Bishop. And indeed, safe motherhood is in the hands of God now. Seek first the kingdom of heaven, and all the rest will fall in line. We really want to appreciate the continued collaboration with the faith-based organizations, and they have a special platform for Ramka. They discuss how to translate messages, like the message he has mentioned, of it's not biblically correct that you give birth to any number of children. Healthy child spacing is godly. Looking after the children adequately is also godly. And I think we need to engage you more, and that is our pledge. Amidst us, as we also received the Her Excellency, the Ambassador of Sweden. Your Excellency, you're most welcome. She will be presiding over the next session, which is the awards. She's the chief guest at the awards. So, Your Excellency, thank you for honoring us and arriving on time. Chief guest, we also amidst us have a special group of people that I wanted to recognize. In the multisectoral spirit, we also have people from Ministry of Education. Ministry of Education represented by Mr. Semakula. Just clap for him because we just want to appreciate the multisectoral engagement, and they've been here. We also have amidst us a group of committed people called the coordinators of the NASMEC subcommittees. PPH, Dr. Samo Nonge, Professor Nachimuli, kindly stand up for recognition. If you are coordinator of a NASMEC, NASMEC is National Safe Motherhood Experts Subcommittee, we stand up and recognize you. We really want to appreciate you. Thank you very much. Thank you very much. In a special way, we don't want to forget our funders. Anyone who contributed, including energy and your mental power, please, we want to appreciate them and clap for them. We want to appreciate all the other UN agencies, WHO and UNICEF, because UNFPA is representing them here. Let's clap for WHO and UNICEF. Now, allow me at this point to invite the representative of the Health Development Partners. They plan with us, they provide us technical assistance, they give us resources, they tell us where resources are to deliver these packages. It's now my honor to invite Madame Juliana Lunguzi, representing the Chair of the Health Development Partners. You're welcome, Juliana.
Thank you very much, Dr. Mukai. I'm sitting here representing the Health Donor Group. UNFPA is chairing, but I need to recognize our co-chair, Sweden, and also co-chair, WHO, all the other development partners, the DG and your team at the Ministry of Health, including the Minister AI, and also recognize all the other partners who are here, our doctors, our midwives, our health workers, all protocols observed. With the Health Donor Development Partners, we want to really reaffirm our shared commitment to work with the government of Uganda and all stakeholders to ensure that no woman dies while giving birth. There's nothing pretty, as our clergy said, you stay 9 months hoping to go to labor ward to deliver a live birth. And not only do you see a baby dying, but including the mother. We want to commit that we want to see this coming to an end. Safe motherhood is not the responsibility of the health sector alone. We have seen this in this conference. It requires collaboration across education, finance, local government, justice, and community systems. So we are happy that our colleagues from education and other sectors are here, and also to give a big hand to our young girl. We can see hope in that girl. We therefore pledge to strengthen multi-sectoral coordination, align our investments behind one national plan, one budget, and one accountability framework. The ministry has stressed this, and as health development partners, we align to this. And we also want to promote transparency at every level, from national systems to the last mile. We do not want to leave anybody behind. And together, we will champion mutual accountability, invest in innovation, and support Uganda's leadership in building a future where every pregnancy is wanted, every childbirth is safe, and every woman's potential is fulfilled. If you want to make a good Uganda, it starts with a woman. And that woman in the labor ward, we want her to be happy. If they are happy, the families will be happy. I thank you very much.
Thank you, Juliana. The people of Mane don't talk a lot. Now, DG, I'm going to request you, we have started the group of donors. DG, my supervisor, I'm going to humbly request that you step forward. I will give you the protocols, and we are going to begin with World Bank, and then we follow with the Ambassador of Iceland, and then the chief guest for this closing ceremony is the Ambassador of the Netherlands. Our DG had more than 10 functions this evening. You know, he's a passionate Rotarian. He's a chief guest at another place, but he's able to come here at the Safe Motherhood Conference. I felt if he allows me to continue, but he should make some comments, and then we proceed. Thank you, DG.
Thank you, Dr. Richard. I have allowed you to continue. Our guest of honor, all our partners, I think let me stand already on the existing protocol, because, so first, my apologies for joining in late. And I imagine that if you are coming for the hour dinner, is this the dress code? There was no dress code which was given. But specifically, this afternoon, I have to join another group where today we commemorate the World Polio Day. So it gives me a pleasure to stand here. I think we've spoken about safe motherhood, but polio and safe motherhood are related because they provide a very comprehensive program for both women and newborn survival. So I want to take this opportunity. I am, apart from being the DG, I'm also a member of the Rotary Fraternity and the immediate past president of my club, RC Sunday. So allow me, in the spirit of integration, to share with you a word or two on this Polio Day, as we commemorate the safe motherhood. So today we join the rest of the world to commemorate the World Polio Day under the theme of End Polio, Every Child, Every Vaccine, Everywhere. So as we come to the close of the fifth National Safe Motherhood Conference, Awards and Expo, there has been a global progress towards eradicating polio a disease which has crippled millions but is now at the brink of extinction. The WHO estimates that vaccines prevent 2 to 3 million deaths every year, and vaccination remains one of the most cost-effective public health interventions. We use this day to reaffirm our collective resolve to reach every child, to counter misinformation, but also maintain high coverage. A polio-free Uganda and the world are within our reach. With unity, vigilance, sustained investment, we shall achieve it. I want to end by thanking all of you for all these contributions which you have made and your participation. I know it's late, and being here up to now is really a sign that of your commitment. Safe motherhood is for all of us, as you have heard, and all of us are part of the compact of safe motherhood. I want now to hand over to Dr. Richard Mugai to continue with the moderation. And please accord him all the support you would have given to me. Thank you very much.
Thank you, DG. A big round of applause. And for his commitment, really, and we appreciate that, because polio is also another area that we need to address. DG, we shall complete the rest. Thank you very much, DG, but we are also privileged that the Under-Secretary representing the Permanent Secretary is still here with us, and Ministry is fully represented with the other commissioners. Nursing is here, Commissioners Nursing, Assistant Commissioner AIDS Control Program, and all the other dignitaries are still here with us from Ministry of Health. Allow me, I've been allowed to invite the funders. Now allow me to invite my friend. I had earlier talked about him. The only thing that I strongly remember about Rogers is whoever is getting RBF at a health center for, the man behind it. He fought battles to institutionalize RBF in the mainstream government funding. Dr. Rogers Ayiko, representing the World Bank, and step forward and give your remarks.
Thank you very much, my brother Mugahi. Habari za jioni. Habari za jioni tena. Okay, good evening. Yeah, thank you very much. Rogers Ayiko is my name. I work with the World Bank as a senior health specialist. I'm not the country manager, just for avoidance of doubt. So I'm here stepping in for the country manager who would have wanted to be here, but she's still traveling from DC where she was attending the annual meetings. The chief guest, Your Excellency, is present, the leadership of the Ministry of Health, and all the senior government officials, development partners, ladies and gentlemen. I think before I read a few of the comments that the country manager said I should convey here, I want to also say that we belong to the Health Development Partners Group. So what the chairperson relayed, we align with it fully. So it is a privilege and honor to address you as we conclude this conference. In terms of reflections of what we've picked from this meeting, we have heard powerful stories, including from our daughter who was just here, a lot of innovations and insightful discussions. The urgent need for coordinated, integrated, client-centered solutions for safe motherhood has emerged as a central theme of this conference. Clearly, we recognize that Uganda has made remarkable advances in maternal and child health, but we have very big pressures, which we typically don't see from the health sector. The issue of demographics, the issue of macro-fiscal pressures, and the issues of epidemiological trends that are shifting. And very significantly the evolving health financing landscape, where potentially we could have lost about 25 to 35% of total health expenditure. So all the solutions that Bagala was reading here, we will have to implement them with about 35% less resources. I think that should be at the end of our mind. And then, of course, what that points to is that prioritization becomes like our number one word in everything we do. Planning, programming, policy, and everything. We must therefore act decisively, not only on the sector-specific recommendations, but also broader determinants of health, because that is where about 80% of the health problems come. Only through strengthened multi-sectoral collaboration and shared sense of accountability can we realize real change. On behalf of the World Bank, once again, and also the Global Financing Facility, represented by Grace seated down there and Scott, we want to express our sincere appreciation to all that have really moved this agenda of safe motherhood, and especially the frontline health workers who are taking thousands or hundreds of decisions every day to make our mothers get the best outcomes of healthcare. The World Bank and the GFF remain steadfast in its support of Uganda's development agenda. We look forward, maybe this is a form of commitment, we look forward to deepening our collaboration with the government and partners to achieve universal health coverage. And this is clearly because the World Bank president has committed to support at least 1.5 billion people across the world to access quality health services between now and 2030. And this almost translates to about 13 to 15 million for Uganda. So finally, may this conference serve as a springboard for robust and sustained action. May we leave not only inspired, but mobilized to do more, to do better, and to work together. I thank you.
Today I learned a new word, that the clapping can also be anemic. Now the clapping we are doing is hypoglycemic. It's not only anemic, but hypoglycemic. And when you combine anemia and hypoglycemia, we are in trouble. So for a donor, we need to clap hyperglycemically. So we are working on so much with the World Bank. We are cooking with Rogers and the team and Dr. Murindwa, and hope very soon we shall be serving you. Thank you, Dr. Rogers, for your tremendous support to the survival of mothers and the babies in Uganda. Before I invite another friend of mine, I have been revising the name and I'm going to try it this time. I want to recognize two of our safe motherhood champions amidst us here. They've been very instrumental and they've recently retired, but they've really done a lot of work for this country. And one of them is Dr. Olive Sentumbwe, the most senior docent. Yes, we love you, Olive. You've done a great job. The other one is Maria. Olive worked for WHO, and she's now retired, but not tired, and we still won't need her. Maria, UNFPA. Maria. Yes, thank you, Maria. A very senior and seasoned midwife, worked with UNFPA. She's part of the reason we started Safe Motherhood and all the combing of the villages, hard-to-reach areas. And we really appreciate you, and I think we shall appreciate you people more. It's now my time to invite someone I met in Namayingo. Namayingo, Your Excellency, the team from Namayingo was here. The head of mission of the Embassy of Iceland, she's very passionate about maternal and reproductive health. the government of Iceland has been supporting Uganda through UNFPA on the fistula control and repair mission. I don't have the numbers offhand of how many women the money from your taxpayers has been able to give back dignity. Colleagues, you know what it means when a woman moves around with a fistula. I was in Namayingo to see the number of women giving testimonies who had fistulas corrected by our surgeons with the support from the people of Iceland. We want to appreciate you and ask you that we want more to prevent them now. We want more resources to prevent them. I'll be reaching out to you and we discuss the prevention strategy, but we really appreciate the resources that you gave us to repair the fistulas, and it's my humble honor to invite Her Excellency, the Head of Mission, Hildegard, to come and address us. I have tried.
Did I try? So good, so good. Good evening. That was very good. You got my name very well. Undersecretary, commissioners, religious leaders, development partners, ladies and gentlemen, good evening. My name, to make your life easier, my name is Hilda. I'm the head of mission at the Embassy of Iceland. I'm sure you're all exhausted after 3 days of deliberations, so I promise to be as brief as I can. But allow me to congratulate the Ministry of Health and the organizers for bringing together such an impressive and diverse array of participants. The conference is indeed a reminder that safe motherhood is not a privilege, but a right for every woman. It is the very cornerstone of public health, gender equality, and sustainable development. And I'm sure that during these 3 days, we have all learned, reflected, and networked, and celebrated the progress achieved so far. Maternal health indicators have improved remarkably over the past few decades, thanks to the tireless efforts of healthcare workers, policymakers, and community champions. Indeed, clap, because many of you are in this room, so clap for yourselves, please. Yet we really must acknowledge the persistent challenges that remain: adolescent pregnancies, obstetric complications, gender-based violence, and limited access to reproductive health services. Now, I am confident that the government and all stakeholders will continue to explore innovative solutions to address these challenges, and I'm sure that they have been discussed thoroughly for the past 3 days. Now, Iceland is proud to stand with Uganda in this journey. And as a humble, small partner, please indulge me a bit, but through our partnerships with district local government and development partners, Iceland has so far, as Dr. mentioned, supported the UNFPA STOP program in Namayingo district, addressing obstetric fistula and empowering survivors through treatment, rehabilitation, and reintegration. A key component of this program, in addition to restoring dignity, is to contribute to safe motherhood by equipping health facilities and strengthening the skills of health workers to make pregnancies and deliveries as safe as possible. Now, through our partnership with UNICEF Uganda, Iceland has supported improvements in water and sanitation facilities at health centers in refugee hosting districts in West Nile. Similar interventions have also been implemented in health centers serving fishing communities in Iceland's partner districts along Lake Victoria, further contributing to safe motherhood. Iceland has also partnered with UNICEF to support adolescent mothers and their children in Chiogegwa and Kikube districts, expanding their access to education and skilling, childcare, and protection services. And we have collaborated with IPAS in Tororo district to expand access to reproductive health services and address the root causes of maternal mortality and gender-based violence. Please bear with me, I'm at my last point in my overview, but we are also proud to be part of the ambitious Heroes for Gender Transformative Action Program, led by the Embassy of the Netherlands, and we're very pleased and proud to be able to participate in that program. And Iceland's contribution enhances SRHR, GBV prevention, and WASH services for vulnerable communities in Kalangala district implemented by a consortium led by Amref Health Africa. And good to see Patrick here. Nice to see you. These contributions reflect the government of Iceland's deep commitment to equity, dignity, and the empowerment of women and girls. And we are truly grateful for all the partnerships. Now, as we near the close of the 5th National Safe Motherhood Conference, let us not lose momentum. I'm echoing what has already been said, but good messages need to be reinforced, and that is to strengthen partnerships across sectors and communities, invest in health systems that prioritize maternal, newborn, and adolescent health, amplify the voices of women, especially those in underserved regions of Uganda, and most importantly, hold each other accountable to the commitments that we have made over the last 3 days. As I thank you for your active participation, your shared insights, and your commitment towards ensuring that every woman gives birth safely and with dignity, I wish I could end with a poem like Lucy, but I'm just not that talented. So allow me to end with your core message from this important conference, and that is, we have the solutions, now it's time to implement them. I thank you all.
Thank you, Your Excellency. Juliana has offered to teach you a poem. But those of us who remember football, I joked with Her Excellency while in Namayingo that I only knew about Iceland when Iceland defeated England. A country with 40,000, Iceland is 400,000 people approximately, but beat England of 50 million people in football, World Cup. So they are a very determined population, and I really want to appreciate it. I think I told you that. So thank you, Your Excellency, for those wonderful remarks and for being a very good partner to the Ministry of Health and the government of Uganda. I want to invite the chief guest, but I can't manage to invite. I want to invite the chair of the Health Service Commission, Madam Christine Kakuru, to step forward, make a few remarks, and invite for us the chief guest. The name I will give it to you. Can you put our hands together and welcome? Christine is one of us, as she'll be explaining to us, passionate about safe motherhood, a mother herself. Today, I got to know that she's also a Nalongo. Do we have more Nalongos in the house? Yes, there's another Nalongo here. Thank you so much. Your Excellency, I didn't know you know the word Nalongo. Oh, wonderful.
Praise God. Good evening, everyone. I want to take this opportunity to first thank God Almighty, who has enabled us to go through these wonderful 3 productive days here. I kindly request you to join our hands and thank God. My name is Christine Kakuru, the Deputy Chairperson of the Health Service Commission. I'm here to represent the Chairperson of the Health Service Commission, none other than Dr. Henry Mwebesa. I'm glad that yesterday, but one, he was here to officiate and open officially the 5th National Safe Motherhood Conference. We want to thank him and recognize him in absentia, but well represented. Can we thank the chair? Allow me, before I proceed, recognize the Health Service Commission members who have managed to persevere to this time. Kindly stand up for recognition. When we started, we were all 7 members, including our chair, but today we have been blessed to have Dr. Nambiru to be with us and Madam Akum Janet Apai to be with us. The rest wouldn't manage to turn up But today, at least we have managed to be here since morning up to here. Why are we here? Because when we started and when we were discussing, among other pertinent bottlenecks contributing or as cornerstone of causing all these problems hindering safe motherhood was human resource. And when we talk about human resource, that is a very important but critical resource to manage in order to, facilitate or enhance the whole system of health. Allow me first to maybe highlight what it means and what it takes. When we talk about the health system, we need three things fundamentally. We need the inputs. Among the inputs, we have the human resource. And it is the very, very cornerstone of the health system. Without a human resource, the system can't stand. Mention it, it can be finance, infrastructure, ABCD, but the human resource is the cornerstone of health system. Then we can talk of the processes which we go through in our systems as clinical or healthcare systems. Then at the end of the day, we want to depend and lean on you, human resource, that we have the best desired output or outcomes as the satisfaction of our customers, that is the patient. Allow me, before I proceed, I also express my heartfelt appreciation to the organizing committee, Ministry of Health entire, but the team which has spearheaded this. Kindly let's add on our hand clap to thank you so much. Imagine how we came from day one up to today. What we are deliberating on is very crucial as far as the safe motherhood is concerned. My appreciation also goes to not discriminating, but respecting all health care providers, from the directors in your respective capacities up to the last, I can call him maybe the support staff, because those are the food soldiers on grassroots who are helping us to have the other beautiful results which we had here yesterday, the other day, and today, where we have improved greatly in all performance indicators almost. Irrespective of the challenges that we came across, but for me, I have a belief that once we identify those challenges that we got as bottlenecks, we can turn them into opportunities for improvement. When you are performing, you can't fail or run away from challenges, but we can turn those challenges into opportunities for improvement. Yes, they are there. Every accounting officer, you are responsible to handle or look around. The DHOs present here, the ADHOs, the doctors, the nurses in your respective capacities, I want to thank you because your being here in this room underscores our shared commitment as the recruiting agent on behalf of the government. We feel empowered when we see you here. We want to thank God for you. As the theme reads, strengthening multisectoral collaboration and mutual accountability for safe motherhood, it is not just a theme, but it is a call for action. And all of us, as we are here there, I believe and I'm contented that from here we are going to walk the talk. And by next year, we pledge together as combined efforts that we shall have more improved performance indicators, God willing. It resonates deeply with core mandate of our Health Service Commission, We have our mandates. Allow me put it clear so that when you see us here, you know where we end and where we stop. Health Service Commission, in its special mandate or capacity, as established by Constitution of the Republic of Uganda, our mandate clearly is just to appoint persons in different offices from the lower up to the top, according to our jurisdiction. And we also, after appointing you, we go through a long process of recruitment. After recruitment, we assign people, or we recommend different officers to be appointed at different levels. We recommend to the president for higher offices and others to the Ministry of Health to take also its mandate. We have to confirm people in service in those offices. We have the mandate to promote those people who are supposed to be promoted. We confirm and approve people who are going for study leave. We have a mandate to review the standing orders for the health workers. We have quarterly performance support supervision, where we have moved, at least most of the facilities you have seen us moving around, not only to recruit, but also to check and appreciate you. When we come to your facilities, we are not only coming to check the system, but coming to appreciate the work you are contributing to the entire country. We want to thank you and thank you. When you see us coming to you, our first aim is to appreciate you because you are there and you are contributing a lot. And then another mandate which I can't forget, when we appoint, we have also the mandate as a Health Service Commission to disappoint. Disappoint by disciplinary action. We take disciplinary for those people who are liable to be disciplined, those who can't abide by their expectations to work. So once we decide and then take an action, we can also remove the officer who was appointed in that office. Allow me to summarize. Our vision is a fully resourced health workforce that is responsive and effective. Our mission is to build a fundamentally strong and competent human resource base for efficient and health service delivery. So when they talk about all the other words, they talked mostly, like 80% was praising you. Health workers, we thank you so much. Endlessly, we thank you and we are humbled before you that you are doing a lot. But the other 20% where we have the gaps and where we have to stand and turn them into the opportunities to improve, together we can improve and go far. In line with our mission and our objective of this conference, I stand before you to make a firm commitment that from here, since we heard that the midwives, it ranked a very high toll there. When there are three things we work with, when the Ministry of Public Service has cleared you for appointing, you have your wage well saved, and then you have submitted and prioritized well according to the decisions and the action point we have gone with here. Our work will be made easy as Health Service Commission to recruit on spot that you have submitted for us rightly. So for us is to recruit according to our mission and vision. The moment you have a wage, you have a vacancy, it has been cleared, and then you submit rightly all the midwives. I think we shall do our due diligence according to the new structure, new staffing structure, and the scheme of service. We pledge to do our due diligence and serve you as it takes. The Health Service Commission is committed to prioritizing the recruitment as mentioned. We acknowledge the immense challenges. I've already talked about them. When we acknowledge those challenges as we walk around, we face daily with you the long hours you stand, the resource constraints, the emotional toll, please be reminded whenever you are there that we hear you, we see you, we pledge our continued support wherever we can as Health Service Commission. We will continue to operate with our integrity, professionalism, and transparency as we, work with you in partnership because we can't work alone. While we face those challenges, I think we see way forward as positive because we shall stand on them as a firm foundation to find solutions. Once a challenge is found, the solution will be found. In conclusion, I thank you once again for your dedication. Let us leave here reminded that safe motherhood is a business for us all. At all age category, it doesn't segregate. The Commission will play its part in strengthening the human resource. I encourage each one of us also to play our part to collaborate and hold each other's arm and be accountable. I've said all this for God and my country. Thank you for listening to me. The name is what? Allow me to take this singular honor and opportunity to invite the chief guest, Boa Jan Sweding, the deputy head of mission, head of cooperation. Kindly, sir, you are invited to talk to the House. Thank you.
Thank you very much, and I apologize for all these difficult names our parents have given us. Good evening. I stand on the protocol that has been expressed so eloquently already over the last 3 days, and I recognize the presence of all of you, because you have safe motherhood at heart. Thank you very much for that. The Netherlands at present is the chair of a group of development partners working on sexual reproductive health and rights. And I'm deeply honored and pleased to provide the closing remarks of this conference. I congratulate the Ministry of Health, the National Safe Motherhood Committee, and all partners involved for a successful delivery and conclusion of this 5th National Conference on Safe Motherhood. To all attendants, your presence made a difference, and your contribution through the last 3 days is very much valued. We view this as a demonstration of your unwavering commitment towards this great cause. It's extremely appreciated. The conference has brought us great insights to what could be done to strengthen multi-sectoral collaboration and mutual accountability for safe motherhood. And it is our hope that you leave inspired and that lessons and recommendations from these past 3 days leads to a new horizon for women and girls. And I'm very pleased to see that during the synopsis, and thanks to the Icelandic ambassador, we already have the theme for next year. We have the solutions. Time for action. And I think for the committee can that team on board. Through the 3 days of the conference, some messages kept resounding. And allow me to use this moment to mention some of the important ones. At first, safe motherhood is not only a women and girls matter. It's for men and boys too. A world that is safe for mothers is safe to all of us. We men, we boys, we have a responsibility to play. We cannot underscore the significance of involving men and boys in this journey to secure a Uganda where motherhood is safe and a joyous experience for every woman. It's important to keep the gender lens in all our efforts. Secondly, and I'm very pleased that partnership came across already during this closing event, while a strengthened multisectoral collaboration and mutual accountability is a potential game changer, strong leadership, both political and technical, at both national and subnational level, is the fuel needed to make this happen. Thank you very much, Ministry of Health. Thirdly, safe and healthy adolescence is a strong foundation for safe motherhood. The high occurrence of teenage pregnancies, child marriage, and rising cases of HIV new infections, especially among adolescent girls and young women, are indicators of an urgent need for a strong multisectoral collaboration and accountability for health and well-being of adolescents. And we all still remember the spoken words artist that we had this evening. Finally, while we explore options to secure increased funding for health, we need to deepen accountability for efficient use of available resources in every process and activity, including conferences and trainings we engage in to improve health and health outcomes. We should always choose the most cost-effective option and choose for value for money. Ladies and gentlemen, the conference has reminded us that safe motherhood is a right. We are the duty bearers and have the obligation to protect and fulfill this for every woman and girl in Uganda. When we fail in our duties, they carry the burden of our inaction. I call upon all of you in your respective capacity to play the role you can and make motherhood safe for every Ugandan woman. In the opening remarks, the chair of the Health Development Partners, colleague of our UNFPA colleague here, expressed the commitment to continued partnership and mutual accountability. At the end of this conference, I am pleased to reiterate this commitment. Before starting the well-deserved weekend for all of you, I would like to thank you once again, using a quote of Henry Ford. Coming together is a beginning. Keeping together is progress. Working together is success. I wish us all that success. Thank you very much.
Another big hand clap for the donor. As I earlier mentioned, the hand claps must be hyperglycemic. So a big hand clap for all the panelists. Your Excellency, I want to thank you. Team West Nile, the money you have for the SRH project comes from the government of Netherlands, from the great people of the Netherlands. They're also a kingdom of Netherlands. And we want to thank Judith, who is also amidst us. Judith, stand up and we clap for you. She has been the link between the Embassy of Netherlands and the Ministry of Health. Thank you so much, Judith. Now, friends, our distinguished panelists and chief guest, I want to request that we take a picture with the organizing committee. They have done so much. They've been to your offices for the support. Organizing committee, please. We want to end this session. If you can do it in 1 or 2 minutes, please step here. We are slightly behind time. We still have dinner and awards. And we shall do those in 30 minutes, both. Organizing committee, only those who are available. Our dear distinguished chief guest and your team, I request that we step here and have a picture. Organizing team, don't use this picture for alone because it has donors. Yes, the transition between the organizing, disclosing ceremony and you can use even the stairs. I don't know if it works. Some of us are above sea level, we can see tomorrow. Those who are above sea level, you go down. Thank you, Emma. Emmanuel is our PRO Minister of Health. We appreciate you for coming. We clap for this team. They've done a great job. Me, I'm above sea level. They will see me. Oh. Thank you, organizing committee. Our distinguished guests, you can take your seats, your former seats. We want to really appreciate you. Thank you, organizing committee. Next year, do better than this. I think we shall have even Zoom cameras and everything. We really appreciate. The cultural group, kindly manage the transition. We are allowing you only 5 minutes as we reorganize now to go into the awards. We have ticked off the conference with the summary of the events, the summary of the key points from the conference. We have now ticked off the closing ceremony. We are remaining with only the awards, and the chief guest for the awards is already here with us. I hope she's not looking at the time. The chief guest for the awards cultural team, Dr. Bagala, should just 5 minutes only and feel free to stand when the culture gets into your head or the dance gets into the culture. Feel free to stand. We are using this time to reorganize very quickly the team in charge of the awards. As routine, this is the only conference that you hold as the Department of Reproductive and Child Health. We combine everything: awards, dinner, conference. So next is the team that is handling the awards, led by Pamela and Dr. Andrew. And the cultural team, please, if you don't have music, me, I can begin my culture because I'm also a cultured man. I'm a minister in Toro Kingdom, so I can begin my culture. And cultural team, take over. Emmanuel Ainebiona, I want to invite you. Emmanuel Ainebiona, our doctor by association.
Thank you, the drama group. Thank you. Thank you. Thank you very much. Give them a round of applause. That was a commercial break. Good evening, everyone. At least say bonsoir to your neighbor. That is a French word for good evening. So you are welcome. This segment is the award ceremony that will be transitioning into dinner. And I have the honor and opportunity to invite Pamela, who is going to guide us through this award ceremony. Today I don't have much work to do. Pamela is going to lead us through this ceremony. Thank you. You're welcome.
Thank you very much, Emmanuel. Good evening, ladies and gentlemen. All protocol observed, we welcome you to the award ceremony for the National Safe Motherhood Conference 2025. Without a further ado, we are going to begin our program. We will begin with a word of prayer that I'll quickly give, and then we'll have the national anthem sung because our guest of honor was not here at the beginning of this function. Could we please stand up for a word of prayer? Father, we thank you for gathering us here again. We thank you for the gift of life. We thank you because you have appointed us to serve your people. We pray for wisdom, we pray for your grace and for your favor. And as we begin this ceremony, we ask of you to bless us and to bless everybody we are celebrating. And we pray that you be with us. In God's name I've prayed. Amen. So you're most welcome. We'll have the anthems already. DJ, please. We'll only have 3 anthems, the national anthem, the East African anthem, and the Buganda Kingdom anthem. Just one stanza.
Ekitiibwa kya Buganda kyavaaja naffe tukikuumenga.
Thank you very much. Before we could sit, I'm sorry, I'll make you stand again. In the past 1 year, we have lost some of our foot soldiers. Some of them have rested while at work in line with duty. Some of them have rested off duty. And we have also lost our mothers and babies in this motherhood journey. We would like to observe a special moment of silence for them, and we pray that their souls will be rested in peace. Yes, DJ, you are on the right slide. The next slide. These are some of those we have lost. We lost our own at the Ministry of Health. We lost some of those. We lost some midwives coming to attend this conference, and we pray that their souls will be rested in peace. Eternal rest grant unto them. May your perpetual light shine upon them. May they rest in peace. Amen. Kindly take your seats. We welcome you all to this 2025 awards dinner, and this evening we'll run through very fast. But before we go, I would like to take you briefly through how we came up with this. This was an initiative by our leader. I believe we all know how passionate our leader, Dr. Richard Mugahi, is about safe motherhood in Uganda, and he really would like to appreciate and recognize all his foot soldiers at all levels and all cadres. I believe over the years you have noticed that the trends keep changing. We keep including those that are directly involved in care, but we also know safe motherhood goes beyond just the midwife, the obstetrician. It includes the ambulance drivers, the VHTs, neonatologists and neonatal nurses. We also have adolescents. We have a whole different web of people we work with. So this year you'll notice some cadres have been added, but subsequently we'll keep on trying to ensure everyone is brought on board. So without a further ado, I will be requesting the following people to come and support us with awarding. Douglas Akibua. We are going to run through the different LMNSs and we'll be displaying those that went through. This will be read by Dr. Jacqueline Akello. LMNS coordinators, kindly be ready to move as fast as you can. You'll be receiving these certificates of recognition for all the winners across the different LMNSs. Thank you.
Went through the process. Voting, registration. Okay, thank you, Pam. I write on the existing protocol that was started on Wednesday. Let's welcome Dr. Kiwa. So the process of awards, just briefly, we sent out nomination links to the different LNMSs, and people nominated the people who were performing or excelling in their different regions. After that, the list was vetted by the committee, and then we had another link sent out for voting. And so from each LNMS, we have the overall winner, and then the rest who made it to the nomination link get certificates. So the first category we are reading are those who made it to the nomination link, and then the overall winner will be announced later. So that was the process. Although we also have other special categories that did not come through the LNMSs. So we have Busoga LNMS. Let's have the LNMS coordinator for Busoga, Dr. Agri Bameka. Then we have Yumbe LNMS, coordinated by Dr. Nzama Wilfred. And then we have Arua LNMS, coordinated by Dr. Fayo Victor. And then we have Kampala LNMS, coordinated by Dr. Nanzira Rachel. Let's have the 4. So I'll start with Kampala LNMS. The people getting the certificates, we have the obstetrician, Dr. John Wanyama from China, Uganda, Naguru Friendship Hospital. The medical officer who was nominated was Dr. Matthias Lugolobi from Kasangati Health Center 4. And the DHO who made it from Kampala LNMS was Stephen Mulindwa from Mukono District Local Government. And then the neonatal care nurse was Sister Claire Ahimbisiwe from Mulago Specialized Women and Neonatal Hospital. And then we have Sister Abigasi Nalugwa from Kawempe National Referral Hospital. And the anesthetic category from Kampala LMS was Farida Muhindo from Kawempe National Referral Hospital. I'm also from Kawempe. And the implementing partner who got it to the nomination list from Kampala Metropolitan was Save the Children. So we will also need a representative from Save the Children. So we'll ask Dr. Akiwa. I think you're also receiving on behalf of Save the Children. Okay, so we'll start with the IP. So let's start by awarding Kampala LNMS. Dr. Akiwa can handle. So we expect that the different LNMSs will also organize a ceremony to recognize the names that have been read. But when we send out nomination links, we expect better competition. You realize there are LNMSs that are getting 5 certificates, others getting 8. It totally depends on your participation as an LNMS. Okay. Next we shall have Yumbe LNMS certificates. Yumbe. Yumbe, can we have the names for Yumbe? The obstetrician, Dr. Wilfred, who is also the coordinator. The pediatrician, Dr. Mubarak Nasur. The midwife, Sister Sali Aikoru from Yumbe Regional Referral, from Koboko General Hospital. And the medical officer, Dr. Alex Dramadri from Midigo Health Center 4. The DHO, Dr. Dennis Oloya from Koboko. And then the neonatal care nurse, Christopher Waswa from Moyo General Hospital. And the implementing partner who won from Yumbe is IRC, International Rescue Committee. We appreciate you for the support. Okay. Let's have Arua. Arua.
I've been requested that the teams that you're reading that they have won, they can come here just and we clap for them because people would like to. It would be nice. I know it takes a little time as a way of appreciating you.
Okay, can we, as you prepare to come, let me read the remaining 2, but we'll have the teams come and take photos with our guest of honor. Okay, Arua LMS, the coordinator, Dr. Fayo Victor, was nominated as the obstetrician. The pediatrician, Dr. Anniku Gilbert from Arua Regional Referral. The midwife, Sister Julie Adokorach from Nebi General Hospital. My mentee, the ADHO Sister Jessica Draru from Maracha District Local Government. The neonatal care nurse, Sister Ngamita Jane, Arua Regional Referral. And the anesthesia, we had William Ochen from Omugo Health Center 4. Please prepare to come forward to take the photo. Arua LNMS did not nominate an implementing partner to be awarded. Okay. Next, we shall have Kampala LNMS list. I think I read Kampala already. Okay. For the photo. Busoga, oh yes. Busoga, the obstetrician was Dr. Susan Chizala. Pediatrician, Dr. Emmanuel Tenywa from Jinja Regional Referral Hospital. Midwife of the year from Busoga, Sister Veronica Sempa from Chidera Health Center 4. ADHO from Busoga Region, Moses Luja from Kamuli. Neonatal care nurse, Sister Mubarak from Jinja Regional Referral Hospital. And finally, the anesthetic officer of the year, Olivia Najuko from Nankandulo Health Center 4. Thank you so much for your participation. So can we have the different groups come forward? Kampala, LNMS, and all those who were awarded the certificates. Please, if you're around, come forward. Dr. Rachel and team, give them some music, DJ. Where are my Kampala people? If not, I will receive on your behalf. As Arua prepares, come forward if you're from Arua. Kampala. Arua team, move closer. Team Arua, please move to the stage. Okay. As Yumbe prepares. Yumbe, move closer. Thank you, Team Yumbe. Yumbe, move on stage. As Busoga prepares. Dr. Bameka and team, prepare to come forward. Busoga, move closer. Team Busoga, led by Dr. Bameka. Busoga, Dr. Chizala and team. So may I invite Rita to come and take us through the next category. I'll be reading the winners from Masaka LMNS. Gynecologist, we have Dr. Tony Mawanda. Pediatrician, we have Dr. Peace Nambusi. Midwife, we have Sister Sarah Nakajigo. Medical officer, we have Dr. Deo Gracious Kalinzi. Joel Harriers. ADHO, we have Sister Constancio Nachitio. DHO, we have Dr. Charles Matovu. Neonatal nurse, we have Sister Speciosa Amoit. And I'd like to invite the LMNS coordinator for Masaka to receive the certificates for the winners. Congratulations.
Masaka team, if you are here, please come forward so that we take the picture and you go back so that we don't have the... We need to save time. Dr. Senyondo and your team, step forward. Our chief guest kindly and our minister. Let's have a picture with the team Masaka. Apologies. And you'll be reading the next one for us.
The next group is Bunyoro, so Bunyoro team and your LMNS coordinator, be ready. Who will be awarding the next category is Miss Juliana Luguzi. Bunyoro winners, gynecologist Dr. Sebwami Leonardo, pediatrician Dr. Oburu Geoffrey Ofumbi, midwife Sister Kabasomi Penelope, ADHO Kugonza Susan, DHO Dr. Sabiti Edward, neonatal nurse Ayevale Immaculate, anesthetist Akusekera Unia. And as they're receiving their awards, Renzori LMNS. Your name, run.
Let me provide further guidance. We want to go through this very fast. If we are going to tell you, like now, after Bunyoro, we are announcing who? After Bunyoro is Rwenzori. After Rwenzori is Kayunga. We expect everyone to be in the hall. If we call your name and you're not here, we go on to another group. Thank you very much.
Renzori, Miss Juliana is saying? Yes. Renzori, gynecologist Dr. Martin Ouna, pediatrician Dr. Beatrice Chomgisha, midwife Kabasita Beatrice, ADHO Muhindo Zura, DHO Dr. Amon Bwambale, and neonatal nurse Bira Penina, IP Annabelle.
It's a celebration.
in case you're in the room. The next one is Kayunga. Kayunga, prepare to come, and I'll start reading the winner so that you prepare to come. Gynecologist from Kayunga, Dr. Susan Tusubira. Pediatrician, Dr. Gloria Nakalema. Medical Officer, Remy Ndianabo. ADHO, Florence Namuyanja Ziwa. Neonatal nurse, Rose Birabwa. Anesthesiologist, Okia Moses. Samali, you're next.
Don't walk, you don't try. You supposed to be jai. Kilo come, become person, matter, person we don't mind. But when I land softly on the sofa floor. So far, so good. Let me see you.
The next region is the Elgon region for gynecologist/obstetrician, Dr. Emmanuel Tusime. Pediatrician, Dr. Julian Abeso. Medical Officer, Dr. Susan Lunyolo. ADHO, Stephen Wanyala. DHO, Dr. Ephraim Nakoko. Neonatal Nurse, Sister Goreti Ayebale. Anesthesia, Thomas Boyo. And their implementing partner, Seed Global Health. Ankole region, get ready. I would like to invite Irene Athaire from Seed Global Health to come give out these awards, please. Miss Irene Athaire. From the Ankole region, the following people get ready. For gynecology and obstetrician, Dr. Fiona Asimwe. Pediatrician, Dr. Mike Chewalyanga. Midwife, Sister Francisco Akampa. Medical Officer, Dr. Albert Alinda. DHO, Dr. Peter Sebutinde. Neonatal Nurse, Bashira Tusime. Anesthesia, Ruth Charikunda. Irene Athaire from Seed Global, please come give out these awards. Next, we shall have Chigezi LMNS. Please get ready. For gynecologist, Dr. Patrick Komagumu. Midwife, Sister Devota Oyesiga. DHO, Dr. Gilbert Mateka. Neonatal nurse, Sister Komujuni Naebare. Anesthesia, Benny Kamagaju. Chigezi, LMNS. Next, we shall have the TESO LMNS. Please get ready. TESO region, gynecologist, Dr. Jackie Angwet. Pediatrician, Dr. Moses Ochora. Midwife, Sister Jen Akelo. Medical Officer, Dr. Annette Katsime. ADHO, Jude Olede. Neonatal Nurse, Sister Dickens. Anesthesia, Joseph Eriapu. Teso LMNS.
So the next set of awards we have Lango, Acholi, Karamoja, and then Mubende. And I don't know if Joy Batusa from Chai is here. I want to welcome you on stage to hand over the next set of certificates. If Joy is not here, then we can continue with the... Great, so we have the awardees from Lango, obstetrician and gynecologist. We have Dr. Ben Aiko. The pediatrician, we have Dr. Julie Ochol. The midwife is Stella Akite. Dr. James Olum as our medical officer in Lango. And then we have Semi Achiro, the ADHO. Dr. Jimmy Odongo from Amolatar as the ADHO. And then in Neonatal Care Nurse, we have James Opio. Our implementing partner from Lango is Kwam. Lango team, please come on board and we hand over this certificate. The Acholi team, please get ready. Come on board. So for Acholi, we have Dr. Geoffrey Akena as the gynecologist. Please step forward together with your LMNS coordinator. The pediatrician is Dr. Morris Okao from Ambrosoli Hospital, Kalongo. We have the medical officer as Dr. Job Aeku Michael. The ADHO is Sister Grace Anena from Gulu. Dr. Dennis Ochula, the DHO from Kitgum Municipality. We have the neonatal care nurse being Albert Okanya from Gulu Regional Referral. The anesthesia or the anesthetist is Francis Okech Ouma from Gulu Regional Referral. And the implementing partner is ABSI. Actually, team, please.
WHO kindly joined us forward. WHO.
Karamoja team, please get ready after this. The Karamoja LMNS. Karamoja. Karamoja. Yes, we have Dr. Arthur Sebuku as the gynecologist from Moroto Regional Referral. We have the pediatrician, Dr. Doreen Faith Longes. Midwife is Sister Fausta Aburu from Namendera Health Center 3. The ADHO is Sister Deborah Achia from Kotido. The neonatal care nurse is Sister Ruth Achom from Matany Hospital. The anesthesia or the anesthetist is Paul Nelson Maruk. The implementing partner there is also Kwam. That certificate is also included there for Karamoja. Please step forward. Mende. The Mende team, please get ready. Our gynecologist is Dr. Isagara Peter. The pediatrician is Dr. Immaculate Mirembe from the Regional Referral Hospital. Our medical officer is Dr. John Yahweh from Sekanyonyi Health Center 4. The ADHO from Mubende is Sister Sarah Naskombi. Have I got that right? The neonatal care nurse is Sister Anne Kakara from Mubende Regional Referral Hospital. And the anesthetist that took it from Mubende LMNS is James Wabuya. And the implementing partner is Alive. Mubende LMNS, please step forward. So I want to say congratulations to the different LMNS winners. those who have gotten certificates, you emerged as the best from your LMNSs, and I want to congratulate you so much. So the next set of awards are the special categories, and I would want to welcome with me back Dr. Jackie back on stage to take us through the best of the best from all the LMNSs to receive the plaques. Dr. Jackie.
Thank you, Dr. Emina. So the next category are those who emerged winners, and they're getting the awards for their LNMSs, and we have one per LNMS, and I would like to invite, I would like to invite Dr. Grace Mulindo from World Bank to award that category. So let's have the first LNMS, Tier 1, Outstanding Individual Organizations and Entities. Let's go to the first LNMS. Okay. Recognition for outstanding contribution to safe motherhood, Lango LNMS, and the winner is Nelson Loka. Nelson is an anesthetic officer at Anyeke Health Center 4 in Oyam District, stands out as a champion for safe motherhood in the Lango LNMS. With over 11 years of service, his work in obstetrics, anesthesia, and swift response to maternal and newborn emergencies have saved countless lives. Let's play for him, Yoleng. He comes from my region. Can we have Nelson's award, please? Lango LNMS. Okay, recognition for outstanding contribution to safe motherhood from Mubende LNMS. These are people who got the highest votes. Ruth Chazike. Ruth is passionate midwife with over 2 decades of service. Ruth, I will not be able to read the entire profile because you're able to read. It's the same person. Let's have the next LNMS. Okay, the winner from Teso LNMS is Dr. Joseph Emron, who is a medical officer and the acting medical superintendent of Katakri General Hospital. Dr. Emron.
Let's celebrate. There's a party going on right here. A celebration
from all
to
the
last throughout the year.
Yeah.
So bring your good times and your laughter too. We gon' celebrate your party with you. Come on now. Let's all celebrate and have a good time.
Okay, let's have the next. The winner from Kayunga LNMS. Kayunga LNMS. Grace Jessica Zungu, who is a nursing officer from Kayunga Regional Referral. Because of time, we are not reading their profile, the entire profile, but hoping you can read through.
It's a celebration.
So for all those who have received the awards, please come forward. We shall take a photo with the chief guest in your different categories. Okay, next we shall have the winner from Chigezi LNMS. Chigezi, Dr. Godfrey Amoti Wampire. Can we have some music as Dr. Godfrey comes? Please, if you've received a plaque, come nearer. We are going to take a picture with the guest of honor.
Let's all celebrate and have a good time. Yeah, yeah. Celebration. We gonna celebrate and have a good time. It's time.
And lastly, for the first 6, let's have Renzori LNMS. All those who have received the awards, please come closer. You're going to take a group photo here. Okay, for Renzori, Dr. John, no, not John Bosco. No, John Bosco is not Renzori. Renzori is supposed to be Dr. Herbert Nzeke, not Oriema Bosco. Dr. Herbert, I know him very well. You're most Renzori LNMS, let's
kuba niwe niyo shongare babaziro bamanyise nompamane mpapa sotija kwechangane bikuru syambe mazire nyihombo sikazobo bukwe pankandi barontswala ndahire wenda kwiruka wenda kuzana ningo kwegama onyete nkubanjire
Masaka LNMS, Sarah Harriet, Senior Anesthetic Officer. Can we have this after Sarah has received her award? Come and take the group photo, please. So may I request the first 6 who received the awards to come for the group photo with the chief guest? Please. Please play for us a song as they come. The first 6. Come dancing. It's not easy to get a Safe Motherhood award. DJ, please. The song is not for dancing. Add more vibe. When you're done with the photos, we have bags for you. We have award bags. So Professor
Professor Joseph Atwiamjisha, if he's not here, Professor Nachimulis, kindly step forward. Dangerous substitute.
These are the winners in the overall LMNS. Yes. Recognition for outstanding contribution to Safe Motherhood, Bunyoro LMNS. The winner is Dr. Lawrence Kamya. He's a dynamic Ugandan physician with 5 years experience, with a 5-year journey in Kakumiro district. Let's clap for him. Please clap as he's coming. Dr. Lawrence, don't go away afterwards. Stay a bit near so that we can take an overall photo. From Kampala Metropolitan LMNS, the overall winner is Prosi Nabweteme. She's an innovative midwife from Wakiso Health Center. Please clap for her. DJ. Give Sister Prosi some vibe.
I want to flex my love. I want to impress.
Please, let's clap for Sister Prosi. Yeah.
To a place she loves. I want to impress. And I want to carry my love away to a place she loves.
Sister Prosi, after don't go very far, keep a bit close for the general photo. Don't go very far. The next winner from Acholi LMNS, drum roll please, Rebecca Aliemo. Rebecca is a devoted midwife at Okinga Health Center 3 in Pada District. Let's clap for Rebecca. DJ please. Please stand here. Please don't go very far. Don't go very far. We are going to take an overall photo. The next, from Karamoja LMNS, our overall winner is Dr. Longiro Mark. Please, a big hand clap for Dr. Mark. Dr. Mark, congratulations. He is a frontline health worker and transformative leader advancing maternal and newborn health in Karamoja. He works at Nabila Tuk Health Center 4. Please, the hand clap for Dr. Mark.
I see this fine girl from my party, she wear yellow. Every other girl they do too much, but this girl mellow. Now in my fine situation, I go use they tell I'm mellow. Finally, I find way to talk.
From Elgon LMNS, the overall winner is Edith Akelo. A big hand clap for Edith Akelo. Edith is a devoted midwife from Busano Health Center 3, Mbale District, one of Uganda's most hard-to-reach communities. Let's give a big hand clap to Edith Akelo. Congratulations, Edith. Well done. Edith, don't go very far. The next winner from Ankole LMNS, drum roll please. Ankole LMNS, Sister Chemist Beatrice. A big hand clap for Beatrice. Is Beatrice around? No. Beatrice is, yes. Beatrice is Ediet Obuntungamo. A big hand clap for Beatrice. If Beatrice is not around, the LMNS coordinator, you can come and pick Beatrice's award. Or a partner from Ankole. The next award will be read by Vanessa. I would like to invite everyone that got an award to come and we take an overall photo as Vanessa reads the next winners.
all the awardees kindly step forward, and our chief guest will take a picture. Vanessa, prepare yourself for the next phase.
Yes, good evening. The next award category is for Busoga LMNS. Can you please have Mr. Kenneth Mtesa Sira from WHO to join us on the stage? The first awardee is Dr. Peter Diogo Nantamu, the DHO Ginger. Then we move to the next recognition is from Yumbe LMNS. Can we have Mr. Lulu Henry Leku, the ADHO Bajimani District? For Bunyoro LMNS, the next award category, we have Dr. Lawrence Kamia, a physician from Kakumiro District. He was awarded. Then we move to the special categories. Recognition for outstanding contribution to safe motherhood, adolescent health. We have Mr. John Stephen Asimwe, head teacher of Busiro Church of God Primary School. The next recognition award is for Best Data Officer for Blood Products, Mr. Kainamura Mbiro Innocent. Mr. Kainamura Mbiro Innocent. Here. The next recognition for outstanding contribution to safe motherhood, ambulance driver, Mr. Francis Chasima. Mr. Francis Chasima.
awardees come to the front for a group photo?
What's next? Thank you. A big hand clap for this team. Special awards. And I want also to mention that amidst us we have one of our own doctor who is also a musician, Mr. Kachumbala, Dr. Kachumbali. So he will be entertaining some of our special guests as we continue with the awards. Pamela, can we have the next?
Okay, ladies and gentlemen, we are going to now go to the next category of special awards. As these people come in, let's cheer them up. They deserve it. And I will invite Mr. Kenneth Akiri to come and hand over these special awards. So the first one will be recognition of outstanding contribution to safe motherhood, the corporate social responsibility. Ladies and gentlemen, our awardees for this year is URSB. As you all know, this is a statutory body championing commercial and intellectual property, and it has extended impact beyond business to now saving lives. A round of applause for URSB. Let's clap for them as they take on this award. If the music is nice, you can dance to it as they take the photo. Okay. The next group of awardee is the recognition for outstanding contribution to safe motherhood. ADH Clinic of the Year, Adolescent Health Clinic of the Year. Ladies and gentlemen, the Yumbe Regional Referral Hospital Adolescent and Youth Friendly Clinic. In just over 2 years, the clinic has transformed into a safe, vibrant space where young people find care, confidence, and community. Let's give a round of applause for them. Yumbe, DJ, play for them a song. LMNS coordinator with your team, Dr. Commissioner Dancing. Okay.
Girl, I'll be foolish if I don't let you indulge me.
Ladies and gentlemen, our next category of awardee is recognition for outstanding contribution to safe motherhood implementing partner. Let's welcome CHAI, Clinical Health Access Initiative, for the grateful work they've done in the last year when it comes to safe motherhood. Team from CHAI. Colleagues, as the DJ plays music, you can clap, you can stand up, and thank for them as well. Clap for them. They've done a great work. Okay, our next awardee is going to go to another implementing partner who has done outstanding work in the Rwenzori region, and that is none other than Enable. Through their support of We Care project funded by the Kingdom of Belgium, they've been able to penetrate Rwenzori region and have done tremendous work over the last year. So let's clap for them as they come to receive their award. Now we go to the best performing NASMEC subcommittee. This one does not mean others did not do well, but we've had excellent work from all our subcommittees in the last 1 year, but we could only have one that stood out. So allow me welcome the National Newborn Working Group. For the first time, they did tremendous work. They've trained over 100 healthcare workers in neonatal in-service training. They are soon to graduate the first cohort of neonatologists trained in Uganda. But also they've activated the regional LMNSs specifically for newborn. Dr. Deo and your team, DJ, clap for them as they dance it. Let's stand up and give them a round of applause. They've done great work over the last 1 year.
She said, I'm my love. You belong to me and I belong to
They will dance like a winner.
Oh, baby, you go kill somebody. They say love is blind, but I did see her for your eyes.
They also had an outstanding campaign called My Baby's First Cry. And I think it has improved how neonatal care is being provided in the country. So among them we have some new cohort of neonatal fellows. So once they graduate, we shall have over 10 neonatal fellows graduating from that program. So colleagues, I want to proceed to the next cohort of awardees. After the photo, you can now walk. We shall not play a song for you. You've already won. Okay, colleagues, our next awardee goes to the outstanding contribution to safe motherhood under the PNFP of the year. We appreciate the work all our PNFPs are doing in the country, but for this year, we wanted to give special recognition to Holy Innocents Children's Hospital, the only specialized pediatric facility in southwestern Uganda. And they've done a tremendous work in providing newborn care and child health care to the entire region. And you know, through the excellent NICU, state-of-art with CPAP machines and the rest and high-quality instruments, they've been able to do great work. A big thank you to Holy Innocents Children's Hospital. Allow me now go to LMNS of the year. Out of our 17 plus LMNSs, we had one LMNS that stood out. And interestingly, it's among the youngest LMNSs, JP Farm Right. A round of applause to Yumbe LMNS. Yumbe LMNS, LMNS coordinator, our obstetrician. You can come with your pediatrician who is championing the newborn. Thank you so much. The Yumbe LMNS serves the largest refugee population as well in the country. Over 600,000 refugees from the districts of Koboko, Yumbe, Obongi, Adjumana, and Moyo districts. Congratulations to Yumbe LMNS. This shows how powerful the LMNS is. So probably next year we shall see more energy. But also we want to see the trends now falling. Maternal mortality, neonatal mortality, and everything. Okay, colleagues, we've had tremendous improvement in neonatal care in the country. And there is one outstanding mentor who has moved to facilities mentoring our midwives and nurses all over the country. And this award goes to none other than Sister Damali. Sister Damali Mogerera. Sister Damali, do we have you here? Let's clap for Sister Damali. She's done great work. If you're a lover of newborn care, let's clap for her as she comes to pick her award. Sister Damali is being escorted by a very huge army. I think they must be co-trainers. Probably next year we shall have some of them being awarded as well. Congratulations, Sister Damali. As I wind my duty here, ladies and gentlemen, we have one outstanding pediatrician who recently concluded her fellowship in neonatology. But besides that, she has done tremendous work in mentoring fellow doctors in neonatology. And allow me invite Dr. Anita Tumwebaze, who has excelled as the outstanding mentor in the category of pediatric and neonatology. She's very passionate and she's dedicated to improving newborn survival and quality care in Uganda. Colleagues, do we have Dr. Anita around? Oh, I wish he had a representative. Whoever loves Dr. Anita, come and receive an award on her behalf. Okay, so I'm going to, we have Pamela who will read out our last person. Then I will ask all our awardees in this category to step forward. We have a photo together with a guest of honor. Don't forget to pick your bags. Congratulations once again to our awardees of the year.
Thank you very much. The photo moment for this team, please. Kindly walk up very fast. The hotel, I am very disappointed in you. I requested you to change the lights. I think this is why people are not clapping and getting excited. Kindly turn on the lights so that we enjoy the moment. We've been having this light for the whole conference. I beg that you change and put our mood into a better mood. Hotel, please, this is for you. Speak Resort Munyonyo. And before we go to the next, we'll have a mentor. But before please, our awardees, come on. We take the photo moment and we go. The next will be read by our PPA champion. She will be awarding our next set of awardees with Mr. Kenneth Akiri. You'll kindly stay here. And in this next category, please, the ones who are red, kindly increase the speed. The hotel, I am still waiting until you turn on my lights very well. I will not stop mentioning it until it's done. Except the photo is not curved very well. Commission, I think we need to make a straight line so that you appear in the photo very well, sir. So thank you very much, team and colleagues, to you all. We celebrate you. Continue the good work. Let us celebrate them, please. So in this next category, we have one special person. This person has gone beyond and over himself to train other anesthesiologists. He is also a call away in case of emergencies. And if you want to see his energy and passion, call him and tell him he needs to resuscitate someone. He will do it over and beyond himself. But interestingly, he is also a very serious professional DJ. Ladies and gentlemen, welcome with me none other than Dr. Agri Lubikire, the senior anesthesiologist from Kawempe National Referral Hospital. In the night, he's also called DJ Happy. DJ, please do not bore our DJ. His birthday cake always has his tools and his stethoscope. You have known Dr. Happy. We congratulate you and work well done. Congratulations to you, Dr. Agri. Our PPA champion, you're supposed to kindly be walking up here to award. No. So the next is tier 2. Who are the champions? Thank you very much. In this category, we have people who have outdone themselves. We know in the different categories and workplaces, we have different energies, we have different things we put out to the table. But for this special category, they surely deserve a hand clap. I will not allow them to move if we are not clapping and applauding them. If you could please stand up because they have really outdone themselves. And the first champion is none other than Agnes Nambozo. Agnes Nambozo is a midwife from Bulambuli district. She has been cited several times climbing over the mountains, single-handedly, not facilitated, to go and reach MNH services to the people in the hard-to-reach areas. She is the best performing midwife. It is unfortunate that Sister Nambozo could not make it because she has an exam, but she sent this lady to represent her. However, Nambozo has been the best midwife and the best health worker. We appreciate you and we are proud of you. May the lives you serve, may the Lord count every good thing for you on the different lives you serve. We'll straight away move to another person who has also outdone themselves. The next champion who has outdone herself is Miriam Lokwi from Karamoja. She works at a health center 3. For those of you that have been to Karamoja, you know how hostile, if I could use some communities, can be. This lady is being awarded for her bravery during an emergency with PPH, where the community had refused to take a mother to the hospital, and this lady walked there with police and requested, with her skill, requested and explained to them what PPH was and that it was not witchcraft or anything, and she was able to convince this mother to come to the facility. And because of this, the whole community has believed in her. They always congratulate her and they do everything that she requests. Miriam Lokwi, unfortunately she's not here, but Kwam will receive it on her behalf. We appreciate her so much. Thank you, Team UNFPA, for the beautiful gift you're giving them. Let us move to the next champion. Vanisha Mugide is also one of those beautiful champions from the islands. She has been seen several times referring mothers on a boat holding their drip and trying to resuscitate them as they move these mothers to the next level. Vanisha Migude, you're amazing. The Ministry of Health honors your work, and we pray that God will bless you for the extra hand you give. Let us give them a very huge round of applause. For this next category, I may not be the best person to relay this. I request my boss, the commissioner. Thank you very much, UNFPA. Let us have a group photo with our champions. The one who carried the one for Lokwi Miriam and the lady from Bulambuli plus Vanisha, please come over as we. And the last one, champion, is a lady who has served in the newborn unit for over 25 years. She has been a mother to the babies that have been abandoned. She has been a mentor to mothers who fear small and sick newborns. She has lived over and beyond her means. She's a support staff, but who has special interest in newborn babies. None other than Hasifa Namuli from Kawempe National Referral Hospital. We congratulate you, Auntie Sifa. Congratulations to the team. DJ some music. The hotel, I'm disappointed in you. The next category will be taken on by the commissioner, and the chief guest And the Undersecretary, please do not go. And the Commissioner will invite our guest of honor to also come and award this category. Madame Charlotte, we request you to come back, please. Thank you very much.
Wow, it's getting interesting. I was waiting for my name, I couldn't hear. But I am a strong believer that those who have not received like me, our rewards are in heaven. Amen. I have seen our rewards in heaven. These lifetime awardees are 3, and they are going to have special songs that they are going to usher them here. DJ, kindly organize the music for these special songs, and I think our very own will also sum it up as we conclude. Prepare, I don't want to end up in this. Prepare their decorations. Prepare everything. If you can clap, you clap. If you can stand, you stand. If you can stamp, you stamp. If you can ululate like Juliana, please do. It's an exciting moment. It's a moment to celebrate achievement. It's collective achievement. We are not saying that you're the only achievers. I want to begin with the first lifetime achiever, Dr. Jamil Mugalu. Dr. Jamil Mugalu is a consultant, senior consultant pediatrician and neonatologist with extensive expertise in neonatal and perinatal medicine. As head of the Special Care Unit and Neonatal Intensive Care Unit at Kawempe National Referral Hospital, Dr. Mugalu is a teacher. Dr. Mugalu is a clinician. He has trained most of the doctors in Uganda about neonatology, a very dedicated servant, a honorary lecturer at Makerere University. Mugalu has mentored countless number of professionals, Medical Association of Uganda, championing passionate ethical care. His leadership in clinical excellence, mentorship, and neonatal innovation makes him a standout lifetime achiever for safe motherhood. We congratulate you, Dr. Jamil Mugalu, for being one of the outstanding lifetime achievers 2025. A big hand of applause for Dr. Mugalu. You are the reason why Uganda is excelling. We want to appreciate you. And you remain here with your award. I want to move to the second. As I earlier said, if you can clap, you clap. Miriam Najemba Mwanja. Miriam Najemba Mwanja is a nurse. DJ, please. If you can have a Rusoga song. Is a nurse midwife and a public health leader whose career has shaped Uganda's maternal and child health landscape. From her days in Mulago Hospital to her days as the district nursing officer. That is what I want to see, the excitement. We honor you, we recognize you, and you are our lifetime achiever for 2025. Incredible performance. Thank you so much. You also retain you, Pamela, decorate her in the white color. She can remove the yellow one. Or she can do both. And I'm moving to the last one. I'm moving to the third lifetime achiever, Professor Dan Kekaye, an outstanding obstetrician gynecologist. Professor Dan Kaye has mentored, has taught in Mulago. He has spearheaded sexual reproductive health. He has published a lot of literature. He's a moving textbook. He's a moving textbook by himself. Professor Dan Kaye, a very humble man, very passionate about service delivery. Uganda is so proud of you, and we want to recognize your outstanding achievement for the lifetime achievement of the year. This is special. I don't know how to make it more special, but please decorate Dr. Kaye, Professor Kaye. I'm going to request that the three stand in the middle. Yes, the three stand in the middle. We got. Thank you, thank you, thank you. Thank you for your service. Thank you for your dedication. Thank you for your passion. We appreciate you. Photo moment. Photo moment. A photo moment. We want WHO, UNFPA. If there are any other ambassadors who are remaining here. Chair Health Service Commission. Commissioners, please join in. Let's make it special for Dr. Olive Sentumbwe. Join us. Commissioner Baku. Okay.
Let us celebrate them, please, with a round of applause. Would like to apologize for the technical glitch. There is an LMNS whose champion was not mentioned, and it would be Dr. Oriema John Bosco from Arua LMNS. Please move forward for your award, and we congratulate you. Dr. Oriema John Bosco, the Ministry of Health appreciates your work in Arua LMNS. As Dr. Oriema comes up, Vanessa, as Dr. Oriema comes up to receive his word on behalf of Arua LMNS, I request Dr. Bagala JP, who has been the chair for this organizing committee, to come forward and appreciate our different partners. And lastly, I'll have a gift from a former awardee that is going out to the Ministry of Health, particularly to the PS and the Minister of Health.
All right, thank you very much indeed. And I think it's really worthwhile for us to say thank you to the people who have enabled us to be here. And colleagues, ladies and gentlemen, let's put up a round of applause to Baylor Foundation Uganda, who have been our platinum sponsors for the NSMC 2025. Baylor. As Baylor comes, we can have Save the Children, platinum sponsor, NSMC 2025. As Save the Children comes, we have UNFPA, platinum sponsor. Yes, let's start with Baylor. I think this is Team Baylor, and then Team UNFPA. Dr. Mugahi, please, come and thank your people. Please. They have enabled us to be here. Okay, fine. Elma Philanthropies has been our gold sponsor. IPAS Africa Alliance, gold sponsor. AMREF, gold sponsor. The Clinton Health Access Initiative, the Clinton Health Access Initiative. We can get our awards and we can keep here for a group photo with the chief guest. Thank you, thank you. PSI, UNICEF, Maristops, Uganda, Japaigo, the World Bank, Dr. Mulindwa, the World Bank, Self-Care Uganda, my sister Rose, Self-Care Uganda, the World Vision, where is the World Vision? You did amazing. Stanbic Bank, if you're in the room, Stanbic Bank, DKT, you did amazing. Living Goods, thank you. Yes, Living Goods. And we can now have a photo with the chief guest and the representative of the Undersecretary. Please, with our sponsors who have really touched everywhere in this very difficult year of the stop work order to ensure that we have this mammoth of a conference. And I think you liked it, didn't you? Thank you. Let's take a group photo. We can also use the stairs. We can stand down. All right. Are we fitting in the photo? Let's. Very good. A round of applause to our sponsors. So we can. I don't think someone. Let's correct. World Vision. Someone took it. Oh, one of the team. Thank you, Dr. And it's the other batch of partners that have enabled us to be here. The Danish Embassy, Bank of Uganda, Pathfinder International, Path, the Macquarie University School of Public Health Center of Excellency for Maternal and Newborn Care, Nama Wellness, the Global Financing Facility from the World Bank, Mother to Mothers. They're doing some incredible job in Namaingo there. Nakasero Hospital, thank you. Adara, thank you. LifeNet, thank you. Vitamin Angels. Seed Global Health. Cachet Pharmaceuticals, if you're in the room. The World Health Organization. Value Global Health Foundation, and the Reproductive Health Uganda. Thank you. Without your phenomenal support, the 5th National Safe Motherhood Conference wouldn't have been a reality. Thank you very much indeed. Thank you. A round of applause, ladies and gentlemen. They have enabled us to be here for the 3 days, and they have sponsored a number of you, and that's how we made the 1,000 delegates for the NSMC 2025. Thank you very much indeed.
Thank you very much, Dr. JP. Dr. Richard Mugai, please don't go back. One of your awardees last year sent a special gift to the minister and to the PS. I would request that you deliver it to Mr. Kenneth Akiri. He will have it delivered. It was the old lady, the midwife last year, a Lifetime Achievement Awardee, who wrote words from her heart appreciating the recognition. So without a further ado, I would request our Lifetime Achievement Awardees, our PPA champion, the guest of honor, Mr. Kenneth Achiri, the Undersecretary for Administry of Health, I would also request Dr. Olaro to come forward and we celebrate our awardees at the cake cutting. All our Lifetime Achievement awardees, our commissioner, Mr. Kenneth Akiri, our PPA champion, Ms. Charlotte, and Dr. Charles Solaro. To the cake table, please. Dr. Bagala JP, on behalf of the organizing committee, please join the cake cutting team. And immediately after the cake cutting, we'll have a photo moment. Lifetime awardees, Professor Kaye, Dr. Mugalu, and Sister Maria, please walk forward. I'm also reminding all our awardees with award plaques to please pick your paper bags. It might be hard to carry the plaque without a bag. Our Lifetime Achievement awardees, we are waiting for you, please. Dr. Mugalu. I think he has run back to the NICU. It's his favorite place. Professor Kaye is here. DJ, please, some music as we cut cake. Congratulations song. On the count of 3, 2, 1. Congratulations to all our awardees. Congratulations to the National Safe Motherhood Conference 2025. Our guests for the dinner, kindly do not leave. Immediately after the cake, we are having a photo moment. Organizing committee for the National Safe Motherhood Conference 2025. With the team that was cutting cake, please run forward for the photo. Organizing committee. Organizing committee for the National Safe Motherhood Conference 2025. Our PPA champion, I'm sorry I'm going to get you tired. Our guest of honor, Dr. Richard Mugahi, Mr. Kenneth Akiri. Photo moment with the organizing committee as we walk out to the dinner.
Please, organizing committee, come forward. The last item is going to be dinner. Organizing committee. Apologies for photo moment about every photo moment. That is how success is sweet. In my village, we had a saying that success has many grandfathers and failure has no grandfather. If you are short, you'll be in the middle. After this photo, we are going to sit. After this photo, we are going to sit and listen to a few remarks, very wonderful remarks from our chief guest. First, wait to take a picture. First, wait. Let's celebrate. There's a party going on right here. A dedication to last throughout the years. So bring your good times and your laughter too. We gon' celebrate and party with you. Come on now. Let's all celebrate and have a good time. Our chief guest, I request that you remain behind. Her Excellency, the chief guest. Your Excellency, Her Excellency, the chief guest, I request you remain behind. It's time to come together. It's up to you. Excellency, the chief guest. Apologies, we delayed you. It was worth it, and we really appreciate you for the time. Let's settle down and listen to the wonderful words from Our Excellency, the Ambassador, and you're welcome, Your Excellency.
Thank you very much. And let me, at this point, stand on the protocol already observed. I recognize it's been very long days, and you are probably waiting for the dinner and the occasion to really celebrate each other together. So I will be very brief, and I apologize to the writer of my excellent remarks that I will then just maybe leave them a little bit. And say that it's really been a pleasure and an honor to be here tonight to celebrate all this dedication and tireless efforts of the frontline health providers. I think it's such a wonderful initiative to take the time to celebrate each other and to recognize people that work so hard every day, and though they might get appreciation from the families and so on, to be brought to this occasion and get this very well-deserved recognition. I have to say it's something we could learn from in Sweden, because I have not seen it there, and it's really a beautiful event. Sweden is in health. We have supported health with a special focus on maternal and infant health for many years. We work on sexual reproductive health and rights. And I was very happy when I saw the awardees today to say that I've been to Kawempe Hospital. I visited the neonatal department. I've seen the maternal department there. I was even there with my minister. I've seen the work that's done. I see how much can be done, but I've also seen the lack of resources and the challenging working conditions that many people still work in. I've also been to the Arua Referral Hospital, and again, been amazed by the dedicated staff, but also struck with still limited resources that are. And as was said before, I am an Alongo. I have 2 boys myself. They were born 1 month early, and I was lucky. I was actually posted to Kinshasa, Congo, but I had the opportunity to go back to Sweden and know that I would be safe and my boys would be taken care of, which they were at the neonatal. So it's a very personal experience when I go visit, and when I hear and I know the importance of midwives and all the personnel that works. I want to thank you, the Ministry of Health, of course, as well, the leadership provided with the Ministry of Health on daily basis, but also to putting us all together for a conference like this. Thank you very much. To all the midwives, you are the cornerstone of maternal newborn care. Your work is truly something special, and there is a lot of positive record to show for that. And also, of course, to all the doctors and specialists here who dedicate their time and skills around the clock to care for mothers and newborn. Some of you might know that Sweden has awarded the work of midwives in Uganda at our residence for many years, and I have done that for 4 years together with Maria, who was awarded the Lifetime Award here. So I was very happy to see her here tonight, and I have personally seen her passion and commitment for this, and also, of course, Makerere, a historical partner to us. So, as the time is late and you must be starving and tired and very anxious to maybe spend some time and celebrate in a more informal setting, I will maybe stop here and again just assure you all that Sweden remain committed partner to Uganda when it comes to health, when it comes to maternal health, infant health, and to ensure that women have an equal standing, and that when women and girls thrive, communities thrive, and let us continue working together to safeguard motherhood, strengthen health systems, and build a healthier world for generations to come. I thank you very much. I hope you had very good 3 days, and I wish you a festive evening, and I look forward to continue following the work all of you are doing. Thank you very much.
And thank you, Your Excellency, once again, and all our partners. I think the next agenda item is our dinner. And our dinner is ready. I'm told you have coupons. Dr. JP, step forward and where exactly? It's where we had last year?
Yes, thank you very much indeed, Commissioner. So we will be proceeding to the Sunset Restaurant. You have those invites. They're digital invites. The restaurant where we've been having lunch from, that's where we should proceed for the dinner. I would request our awards team, Divine, please let's take our guests to the dinner, and then the rest of us will follow. Please, Divine. Thank you. Yes, you might have received that small invitation